గజానన పద్మార్కం గజాననమహర్నిశం అనేకదంతం భక్తానాం ఏకదంతముపాస్మహే ఏకదంతముపాస్మహే. థ్యాంక్ యూ.
Thank you very much, sir. I invite Dr. Mridula to come on to the dais. Morning, madam.
రాకేష్ మనం వీ హ్యావ్ టు ఇంట్రడ్యూస్ మనం ఇంట్రడ్యూస్ చేయాలి కదా. ఇంట్రడ్యూస్ చేయాలి.
So, welcome to all the delegates and speakers to the today's CME program. Welcome to all the delegates and speakers to the today's CME program. The first session will be on shoulder secrets from cuff to fracture. The first speaker is Dr. Mridula. She will speak on proximal humerus dilemma.
Awesome. Very good morning, everyone. It's a pleasure to be here, and I thank the organizers for giving me this opportunity. So, respected chairpersons and dear delegates. So, today I'll be talking about a topic which we see very often, the proximal humerus fractures. We see it in young individuals because of high energy or high velocity injuries, or we see it in elderly because of trivial falls. But whenever we see a fracture of proximal humerus X-ray, more than one option comes to our mind. So we'll always be questionable, do we leave it or do we fix it or do we replace it? So this is where the proximal humerus dilemma starts. So unlike most of the fractures where the fixation pathway is straightforward, for proximal humerus, always you have more than one option. So I'm Dr. Mridula, Associate Professor of Orthopedics from Siddhartha Medical College, Vijayawada. So I'll take you through this dilemma. Next slide, please. So this is the pattern or spectrum of fractures which we come across from undisplaced, minimally displaced to more severely displaced and comminuted patterns. But here it's important that we add another variable here, that is the patient, because a same looking fracture in a 40-year-old is completely a different problem when compared to a same looking fracture in a 75 and 80-year-old. And even in elderly, the patients who have very debilitated or very bedridden or low functional demand, it's completely different from someone who wants to get back to their daily activities ASAP. So, more than one option can always be right. So, same fracture pattern, they can always be a 3 defensible plans. That is, leave it in case of low demand and risky patient, and when the patient has good bone stock and active lifestyle, we go for fixation. And if the cuff is compromised and its head is not salvageable, we go for arthroplasty. So, when we decide if we want to fix the fracture, we have a platter of options, be it K-wires or plating or multi-lock nail, or in some conditions when we cannot salvage the head, there are always options like hemiarthroplasty or reverse shoulder arthroplasty. So why is this a clinical dilemma? Because it's a common fracture without a common answer. It constitutes about 5 to 6% of all the adult fractures, and third most common fragility fracture next only to hip and distal radius. And it has a bimodal distribution, and surgical rates have been increasing steadily over the past 2 decades. But high quality RCTs have repeatedly failed to show that surgery the patients are receiving is clearly superior. So what actually stays the decision is that we have to look at essentially these 4 components. First is a fracture pattern. So we need to know the type of fracture, the displacement and angulation. Then we have to look at the bone and soft tissue quality. If the medial hinge integrity and calcar combination is good, these are the key predictors for avascular necrosis and varus collapse. And also we have to look at the patient factors, that is the age, functional demand, the bone quality, comorbidities and his risk for surgery, and the joint status, that is the rotator cuff integrity or pre-existing arthritis, or if it's more comminuted involving the head. So this brings us to our framework, that is either leave it, fix it or replace it. We'll talk about it one by one. Next slide please. So who is genuinely a non-operative candidate? So a patient with minimally displaced or impacted fractures regardless of the part count, and displaced fractures in a low demand or high surgical risk patient where the operative complication risk is more than expected functional gain. So we go for a non-operative management, that is immobilize and early rehab. Serial radiographs are taken to confirm any secondary displacement. Next. So does this non-operative management actually work? Here is the evidence. This is PROFERT trial is one of the landmark trial which changed the way we looked at it. So this is a multicentric randomized control trial from UK. So which suggested that there is no much difference between the surgery and non-operative management. The primary outcome and also the other patient related outcome measures are no significant difference between operative and non-operative methods. And there are other multicentric trials also pointing in the same direction, that there is no much difference between non-operative and operative management. Next slide. So who is a candidate for fixation? So patients who are young, high demand, who we want to preserve the native joint has most long-term value, and reducible fracture patterns with reconstructible calcar and intact or repairable medial hinge. So and the patients with adequate bone stock, because fixation failures are more in a case with an osteoporotic bone, and we have a wide platter of fixation techniques, plates, nails, percutaneous pinning. Next. So the trials have shown when compared to reverse shoulder arthroplasty, the fixation has a better rotation, but there is no difference in the functional scores. Next. So when we are not able to salvage the head, then we still have 2 options. One is a hemiarthroplasty and reverse shoulder arthroplasty. And who is a candidate for Hemi? In Hemi, the outcome is purely dependent on tuberosity healing and rotator cuff function. And this is slowly falling out of favor for displaced 3 or 4 part fractures as the reverse shoulder arthroplasty data is maturing. It's still reasonable in younger patients with intact tuberosities and good bone. Whereas reverse shoulder arthroplasty, the outcome is largely independent of tuberosity healing and the key advantage in comminuted and osteoporotic bones, and it's increasingly favored in displaced 3 or 4 part fractures in patients over 65 years. Next. So the meta-analytic data when comparing the reverse shoulder arthroplasty with Hemi and fixation, with Hemi there is reverse shoulder arthroplasty is always better. It has good scores, less pain and more forward flexion and abduction. Whereas when compared with fixation, there is low revision rate and no difference in function or complications. Next slide. But mind you, reverse shoulder arthroplasty is not a free lunch because it has its own cost issues. Some series report up to 4 times greater odds of post-op complications with reverse shoulder arthroplasty compared to Hemi arthroplasty. And the patient reported outcome measures have shown no significant improvement compared to non-operative. And implant longevity and revision burden in younger patients remain an open question because most of our data about reverse shoulder arthroplasty comes from the patients over 65 years. And indications, they are actually related is low demand, bone is osteoporotic, viable enough and functional cuff, go for non-operative management. And if the patient is young, good reconstructable bone and cuff function is good, then go for fixation. But if the patient is old with low reserve, poor osteopenic, poor bone quality, unsalvageable hip and the cuff is also compromised, go for reverse shoulder arthroplasty. So the fracture pattern tells what we can do, but patient factors actually tell us what we should do. Next. Next slide, please. So this is a case of a 68-year-old low energy fall, poor general condition. What should we do? It is, we leave it, but that is non-operative management. Next slide. So sometimes doing nothing is also doing the right thing, and we have our support the PROFER trial. That is no clinically significant operative advantage in cases even a short term as well as long term. Next slide. We have to fix it. Next. Next slide. So what makes the fracture worth fixing? Young, active individual, reconstructable head, medial hinge and calcar is intact and adequate bone stock. Next slide. And when do I stop trying to save the head? Very elderly, low energy fall, severe comminution and tuberosity fragmentation and cuff is questionable, then go ahead and replace it. Next. Next slide, please. So reverse shoulder arthroplasty will give us a predictable shoulder, but there is always a trade-off because it's a permanent implant with its own complication and revision profile. Next. So in young patients, we are not having a data. Actually, most of the data of reverse shoulder is from the elderly. So the longer implant horizon, less mature evidence in younger patient, and indication is relative. Next slide. So 3 fractures, 3 different decisions, because leave it when the surgery, you think surgery adds very little, fix it when you think joint is worth preserving, and replace it when the reconstruction is unlikely to give you a predictable shoulder. Next. So my take home message would be non-operative management is not a fallback for a large share of displaced proximal humerus fractures, and a PROFER trial shows it performs equivalent to surgery. The medial hinge and calcar are the single most decision relevant anatomic details, and fixation rates better rotation for substantially higher reoperation rate, and reverse shoulder arthroplasty has displaced hemiarthroplasty as a default replacement in elderly comminuted fractures, but its advantages are relative, not absolute. Thank you.
Okay, a nice presentation by Dr. Mridula. Thank you. So next speaker will be Dr. Srinivas Kasha. He will be giving lecture on medialization of the shaft techniques to increase the medial buttress in type 3 and 4 proximal humerus fractures.
So very good morning to you all, and I congratulate Tosa on 2026 for this wonderful event that is being organized. Can you play? No, no, not this one. Video. Yeah. So this is simple intraoperative technique, which is known as medialization of shaft technique. Let me just take you through a case, 48-year-old male with a history of seizures. You can see the CT scan, both sides you have got 4-part fracture, fracture dislocation, that is posterior dislocation, and secondary to seizure attack, and that's axial section. You can see posterior dislocation, and it is bilateral 4-part fracture. These are coronal sections. Obviously, the treatment options would be to relocate the joint and then go ahead with plating. So that is the position which I usually use. And the first and foremost important thing is to secure your tuberosities in any proximal humerus fracture, especially more than 2-part fracture. So this is after securing the tuberosities and holding them, and then I have used the shank pin to relocate the head from posterior to glenoid fossa. So this is, there is a medial comminution if you can observe, and what I try to do is I put a artery and then medialize the shaft to support the medial side of the head. I'll tell you the biomechanical advantage of that in the further video. And this is, tuberosities are anchored to the plate with those stitches, which is first and foremost important thing in any proximal humerus fracture. That is post-op X-ray right side and post-op X-ray left side. In both the things, if you can see, and there is a slip fragment which has happened on left side, if you can see that, but I have not addressed that in the follow-up, and over a period of time, 1.5 years, he has got full range of movement, both the sides. Fracture has nicely healed, that is rotations, and that's how he actually moves his shoulder. Almost normal range of movement, both the sides, even on the side where tuberosity has slipped a bit, that is towards left. So, proximal humerus fractures usually fail in varus, and how to prevent this is, it usually happens around 14 to 30% of the times, and acceptable reduction and suture anchorage and locking plate, calcar screw, and of course medialization, which increases the buttress on the medial side, by which you prevent the cuff pull acts against medial hinge. When medial hinge is gone, that buttress effect is gone, and usually it fails in varus. And wherever there is medial comminution, you have to either address by augmenting it with a plate or a fibrillar graft, or just by using a simple intraoperative technique of medialization. Medialization also helps in centralizing the shaft. It is a simple ice cream cone concept where you have an ice cream, and if it is centralized over the cone, it won't fall off even if it is a bigger one. But when it is offset, placed offset with an offset, it obviously spills over. So when you medialize this by, even if there is a comminution, medializing that cone, it obviously makes it stable even in an ice cream cone. The same concept. So when you medialize the shaft, it acts as a hinge on the medial cortex and increases the buttress effect, and all the shear forces are converted into compression forces at the medial hinge, and it leads to fracture healing. So that's how it actually works. When you have a medial comminution, anatomical restoration actually takes off your medial support. So that red zone is off support, the shaft, that is obviously supported on the medial side. So that is the supported area, and that small tiny thing is unsupported area. And this is done with a, here I am using an instrument in between the plate and the, you have got medialization, and the fracture has healed nicely after an year's time. That is the function after an year. So here is an elderly female, 80-year-old. So medialization with fracture healed nicely, even though there was a comminution on the medial side. That's her function. Another example, 65-year-old, medial comminution, and that is after a fracture has nicely healed. So how it actually helps in 4-part fracture is, this is how you have a 4-part fracture with displacement, anatomical restoration, and you put a plate on lateral side, and so the maximum contractile forces are almost around 340 newtons at the medial hinge. That is too significant, and with the varus forces, it obviously leads to varus collapse. And what you do is either augment it with a plate on the medial side, or use a fibula, it after you secure your tuberosities, something like that. This is first and foremost important step. And the principle on which it works is this tension band principle, where your medial hinge is necessity to have the principle work. But when medial hinge is gone with a medial comminution, that's when you either use some augmentation by, here I am using medialization, which increases the support and holds the head in place. And the tension band effectively works. So take home is, rotator cuff pull can only be counteracted by securing with sutures. Medial buttress is important to give tension band effect. Medialization decreases the lever arm and deforming forces and supports the head and prevents varus. So, and it doesn't alter the function of the shoulder, and the chances of AVN are comparable with any other technique. So with this, I welcome you all for Orthopedic Trauma Summit, which is going to happen in Hyderabad from October 16th to 18th. Thank you.
Nice
Thank you, sir.
presentation by Srinivas Kasha.
ఇచ్చిన నేను ఆల్రెడీ ఇది వస్తుందా 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 ఇదే ఇస్తుందా ఇదేనా Okay. Speak on MIPO technique for humeral shaft fractures, the anterior bridge plate technique. So, contributing factor in fracture healing. Well, biology heals the fracture, whereas mechanics decides how it's going to heal. Neither will work optimally without each other, but given the right mechanical stability, often determines whether good biology succeeds or not. When coming to the anterior bridge plating, the anterior bridge plating is a synergy of these two principles, that is biology and mechanics, whereas the MIPO is the biology and the bridge plating is the mechanics. In this anterior bridge plating, you have relative stability, which gives secondary bone healing. And here we do an indirect reduction of the fracture site, thereby preserving the biology and without causing any local vascular damage. It is done to two small incisions, one proximally and one distally, where the implant is inserted percutaneously through safe zones. Now, what are these safe zones? So, if you look here, in the proximal humerus, circumflex humerus are going posterior. So, your anterior surface is pretty safe for you to slide your implant. Coming to the midshaft, again, most of your neurovascular bundle is medial, whereas posteriorly you have your radial nerve and your profunda artery. So, again, it is your anterior surface which is quite safe, where you can slide your implant. Distal humerus, again, you have, most of them are medially. The two structures which are there anteriorly and laterally are your musculocutaneous nerve, which runs on your brachialis, whereas you have your radius, which is between your brachialis and brachioradialis. So again, relatively your anterior surface is a safe zone. So you have got the anterior surface of proximal, middle and the lower regions of your humerus which are relatively safe. So what are the indications of MIPO? Almost all the shaft fractures can be addressed to this MIPO. Only thing is that the most proximal extension of the fracture should be distal to the bicipital groove, which is here, so that it allows at least fixation for two locking screws. Similarly, in the lower end, the fracture should be proximal to your coronoid fossa, so that it allows at least two locking screws fixation. Radial nerve involvement is not a contraindication for doing this technique. Higher union rates have been reported with MIPO when compared to open reduction. It was the Brazilians who in 2004 first described this technique, and it was the Thai group who actually showed us that it is possible to do a MIPO humerus in their cadaveric study. Coming a bit about technique, it is done in a supine position. The arm is abducted to about 60 to 90 degrees. The surgeon stands on the lateral side of the arm, whereas the assistant is in the opposite side. The C-arm has to come from the side. Nowadays, I think a LCP, a narrow LCP is the implant which of choice which can be used. It varies between 10 to 14 holes depending on the length of the humerus which you are dealing with. You could also use a DCP plate. It is cheaper, it is easier to get, and make sure that the bone quality is good when you are using the DCP. Now, how do you make these two, the biceps and the deltoid? It's about 3 centimeters in length. It's about 6 centimeters distal to the acromion. It is almost like your deltopectoral approach, which you do normally. The distal incision, again, about 3 centimeters. It's about 5 centimeters proximal to the flexor crease. Make it parallel or on the lateral border of your muscle. The brachialis muscle can be split in the middle so that you get access to the anterior surface of your distal humerus there. Now that you have these two incisions, the next step is to make a submuscular tunnel. So this tunnel is in underneath the brachialis muscle and it is over the periosteum. It is extra periosteum. So what you do is that you take a Scobbs or a periosteum elevator, gently insert it through the proximal incision under the brachialis, go over the bone and make a submuscular tunnel till you get into the fracture site. The similar maneuver is done through the distal incision, where again you put in your elevator, go under the brachialis muscle and you tunnel it, and then you have a very nice submuscular tunnel where you can slide in your MEPO plate. So now that you have slid your 10 or a 14 hole narrow LCP, how do you reduce and fix it? A few principles. Whereas in the reduction, you need to put one more how you reduce and fix it off. Once you have these reduce and fix it off. Once you have these 2 screws each, you can go ahead and put on your. Whereas in the distal part, put on your. Whereas in the distal part, it's in the lateral part where your radial nerve can be damaged. So be very gentle with your homons. Don't use homons which have very long tips. Use distal segment. Don't use long screws. This can go. Use long screws. This can go beyond the cortex and damage your radial nerve distal incision. One tip is to keep the forearm in supination. Once you keep it in supination, your radial nerve moves away from your shaft. When compared to putting it in pronation, where the radial nerve will come nearer. So always keep the forearm in supination. A few case examples. This is a transverse fracture. This was a young girl who was actually preparing for NEET. These are the two incisions. These are pretty small incisions. You can an appropriate length narrow LCP, submuscular tunneling, and then you put your plate there. Here you're centralizing it over the proximal fragment, locking screw, distal fragment, locking screw, and then you go ahead and put your other screws. A little bit of translation doesn't matter. You can use your screw which can be put percutaneously and it will reduce it off, even if you have a bit of translation there. And these are the post-op x-rays, union. You get very good function. Another case, mid-third, a little oblique kind of fracture, comminuted. Again, tunneling there with a periosteal elevator. Connect both the tunnels of there. Passage of your plate. Again, yeah, these are the sizes of the incisions what you can get. And this is the post-op x-rays. Another example, lower third, comminuted, union. Yeah. This is another example in an this is an example where we have done used a DCP. It's a long DCP. The bone quality was pretty good, and this is how it is. Post-op x-rays there. This is another case, lower third. Here we have twisted the plate so that it sits on the lateral part. Examples, yeah. Union. This is another case. This was a little larger guy. Here we have used a broad, long 14-hole. The complication rates are much less. The union rates are much better than open reduction. And yeah, the radial nerve.
A nice presentation given by Dr. Praveen Rao. on the MIPO techniques for long bone fracture humerus. Thank you. And I welcome Dr. Shashikant, who is going to give a lecture on tuberosity fractures, when and how to fix them. Please come to the dais.
Thank you. First of all, thank the organizers of Tosa and Oasiscon for this opportunity. It's always nice to be in this part of the state, Warangal. And my talk is going to be on tuberosity fractures. As we all know, as trauma surgeons, proximal humerus is a completely different type of fracture when we deal with. The more comminuted, the more difficult it is to fix. And apart from the humeral head, the tuberosities which are attached to the media, the lesser and greater tuberosities, though they are small bones, they have a very important function. So that is the reason the tuberosity fracture fixation becomes very important. More often than not, they are associated with like a 4-part fracture, as Srinivas Kasha has shown. But occasionally we do get isolated fractures of the lesser tuberosity and the greater tuberosity, and they have to be dealt with equally well to get a good functional result. So I will just go through greater tuberosity fractures to start with, and briefly touch upon lesser tuberosity, which is a rare isolated fracture. Yeah. Next slide, please. So greater tuberosity fractures commonly occur in males in a ratio of 2:1, and they usually form nearly 20% of proximal humerus fractures. You have a greater tuberosity fractures along with other fractures. Next slide. So why does greater tuberosity fracture matters? Because it's a small bone, but the most important thing, as we all know, is basically it is a footprint for the most important muscles of the shoulder, the supraspinatus, infra, and the teres minor. So the most important reason why we need to deal with it is because of this attachment of these muscles. Though it is a bony fragment, the most important reason is it is a footprint for these tendons. So if you go through the anatomy of the proximal humerus, this is just a picture to show. These are the facets of the greater tuberosity, the superior, medial, and inferior. And those are the attachments of the muscles, the tendons, the supraspinatus, infraspinatus, and teres minor. So this is the main reason why the greater tuberosity need to be dealt with very carefully. So if it is not dealt, obviously patient will have rotator cuff dysfunction. So there are different ways in which the greater tuberosity can be fractured. Obviously, the sudden forceful contraction of the rotator cuff which can happen, fall on the shoulder or directly, or fall on outstretched hand, or Scheser-related convulsions also can produce greater tuberosity fractures. So there are two different groups of patients whom we deal with in greater tuberosity, as was previously mentioned. One is the elderly patients who have a very trivial trauma. They can have a greater tuberosity along with the other parts of the proximal humerus or in isolation. And the other one is the young patients who are involved in high velocity injuries, who also can have a greater tuberosity fracture. And with regards to the phenotypes of greater tuberosity, there are two types which we need to identify. One which occurs in isolation, and one which occurs with a fracture dislocation. So both of them have to be dealt with in a different way. So we talked about the anatomy briefly. I mean, the supraspinatus is the main abductor and causes the superior pull of the fragment, while the infraspinatus and teres minor, because of their attachment, they usually pull it posteriorly. So that is the reason the greater tuberosity gets pulled superiorly and posteriorly because of this. And with regards to the classification systems, we have different classification systems for the greater tuberosity itself. They form a part of the NIRS classification, where they form a part of a 2-part fracture when they occur in isolation. And the other important classification, or the practical classification, is the Much classification, which is commonly used, where the greater tuberosity fracture is classified into 3 different types: type 1, type 2, and type 3. And the type 1 is an avulsion type of fracture, type 2 is a split fracture, and type 3 is a depression type of fracture. So all of them have to be dealt with in a different way. So as far as the evaluation of this greater tuberosity fracture is concerned, X-rays are the preliminary investigations, but most important thing with X-rays is don't judge the displacement or the size of the fragment just on an AP view. You have to take special views with internal external rotation, and occasionally they can be associated with some sort of a rotator cuff injury or labral tear. So sometimes MRI can be useful. So these are just the investigations which we have. X-ray which shows, but CT gives a better differentiation, and in undisplaced fractures or associated rotator cuff, we do an MRI. So the different displaced or minimally displaced and low demand patients. And even in a fracture dislocation, if there is no persistent instability after reduction, we tend to treat it non-operative fracture which is displaced more than 5 mm. Usually we tend to treat them operatively. But that 5 mm rule is not a fixed rule. It can be a bit flexible. Some people, even if there is a more than 3 mm displacement in active patients, we tend to go for fixation. And even in overhead athletes, even a 2 mm displacement can cause problem. So a 5 mm displacement is standardly taken as a rule for operative fixation. So what are the indications for surgery? Obviously, if there is a secondary displacement, you follow up a case, a regular suspected mechanical impingement or malunion risk, then you go for operative management. And the other important group which we talked about is fracture dislocation and it is when you decide a patient needs fixation either based on the fracture size or the fracture pattern or the instability of the fracture, you talk about fixation methods. One is the cannulated screw fixation. If the size of the fragment is reasonably good and if it's extending above the level of the surgical neck, you go for cannulated screw fixation, and if it's a 2-part fracture. So these are just pictorial depictions where you open the fracture or close, open or close reduction depending upon the technique used, reduce the fracture. Then the second one is plating. Obviously, if the fracture fragment is reasonably big enough, you usually use Phillips plating where you open the fracture. Used for comminuted fractures is a suture bridge technique, which is a very useful technique where we use these sutures which are placed on the bed of the fracture, and the sutures are taken through the rotator cuff and tied over the greater tuberosity so that it has got a good fixation. So this is what it looks like post-operatively with the suture bridge. Other technique which people are commonly using is an arthroscopic assisted fixation where you use an arthroscopic portals and use a medial row and lateral row to fix this greater tuberosity fracture. So these are some of our cases. This is one patient, 60-year-old female who had an isolated greater tuberosity fracture. Initially when she came in, it was an undisplaced fracture, so we monitored it. But in the next week when she came in, the fracture was displaced. So we went in and did the suture bridge technique where the fracture was well compressed and where the dislocation was reduced but it was unstable. So we went in with a technique of a combination of screws and the suture bridge technique, which is a very effective way to treat these fractures. Another case where you have a avulsion type of fracture which is also repaired with a combination of screws and suture technique, which is a very good technique. Another case is a 33-year-old female who had a reasonably big fragment of greater tuberosity, which was reduced and fixed with a Phylos plate, which went on to have a good union. So whenever you are treating with the greater tuberosity fracture, these are some things to be kept in mind. So don't just judge the displacement of the greater tuberosity fracture by single view. Usually a single AP view can be deceptive and may look undisplaced, but you need to take special views, and if in doubt, go for a CT scan. Whenever there is a fracture dislocation, make sure that you don't miss a surgical neck fracture, which is sometimes accompanied by the greater tuberosity fracture. And leaving the prominent screw or plate under the acromion can also cause a problem. So the take-home message for this is define the injury, make sure it's only a GT fragment or a fracture dislocation. Define the fragment, define the patient, and then rehabilitate intelligently. So this is just all about the greater tuberosity fracture. Rehabilitation is also an important phase. Phase 1, phase 2, phase 3, depending upon the fracture healing, you go phase-wise. So conclusions, surgical fixation is a treatment of choice for 2-part proximal humerus fractures when it is displaced. Preoperative planning is important, and the choice of fixation depends on the patient's age, activity level, and other aspects. And the larger fragments extending from will need a fixation with Phylos. But arthroscopic fixation, assisted fixation also has got a big learning curve, and early mobilizations remains the cornerstone for successful outcomes. So that's all about the greater tuberosity. There are some slides about lesser tuberosity as well, which I'll probably skip. Lesser tuberosity on its own, isolated, is a very rare fracture. So there are different ways to fix it. Screw fixation, which can be used for isolated lesser tuberosity, or suture fixation, which can be used. So based on the fragment size, you decide what needs to be fixed. So yeah, same take-home message with regards to lesser tuberosity as well. because of the functional significance, we need to take these tuberosity fractures as very important fractures and give them a good result. Thank you.
Thank you. So nice presentation by Dr. Shashikant. Next speaker will be Lalit. So he will be speaking on locked posterior dislocation shoulder.
Morning. Thank you, Tosa, and although proximal humeral injuries are uncommon among most of the fractures, dislocations are less common, which is anterior more common. Situations where I have seen these cases being misdiagnosed as frozen shoulders, and they come down after 2 months or 3 months saying the shoulder isn't moving, and what is found is that they missed a locked dislocation. Relatively rare, more naturally more in men than women. External rotation, abduction is more common. That's why the anterior dislocations are more common. For a posterior dislocation to occur, there has to be excessive internal rotation and adduction, which we don't do in day-to-day life. But for that to happen, there have to be eccentric forces like in seizures. So when it is axially loaded, when the patient falls down axially loaded with eccentric forces, these kinds of dislocations are common. So seizures, electric shock injuries, these are the cases where you find these kinds of severe violent eccentric rotations. Only in these cases the internal rotators overpower these external rotators and lead to these kinds of dislocations. So the thinking point is that the history is the injury or the fracture pattern is unusual, and expect a posterior dislocation. So whenever the head internally rotates and goes back, what you get is an anterior and or an anteromedial defect. So it hinges against the posterior part of the glenoids and locks in. This, and as the when neglected within 2 weeks or 3 weeks, once they start coming down, because of the rapid weakening of the anterior deltoid, the coracoid process becomes very prominent. And the most pathognomonic feature in these cases, clinical features, is along with the prominent coracoid process, it's the lack of supination and external rotation. All these cases, they will not be simply able to supinate their forearm, or most of these cases, when dealt with acutely, let's say within a week or so, generally will have good prognosis. About more than 2 weeks, the defect tends to get increased. Because of the contracture, the defect, the anterior defect continues to increase, the contracture also increases, it becomes a cycle and it tends to get locked. There is a CT-based classification. The type A has only the reverse Hill-Sachs lesion, type 2 has a reverse Hill-Sachs with a greater tuberosity injury, type 3 has a reverse Hill-Sachs with a metaphyseal injury, and so on and so forth. Although the management keeps varying, the CT-based classification does give a management, but the management is always bespoke or tailor-made. Diagnosis when missed for more than 3 weeks is always considered chronic. You generally tend to get very large these kinds of dislocations. Associated injuries, often we see humeral neck fractures, lesser tuberosity or greater tuberosity injury. Most of these 65%. 75% of cases, 75 to 80% of cases will have an anteromedial defect, what you famously call as reverse Hill-Sachs lesion. In the AP radiograph, because of the excessive internal rotation, the head will look unusually round. Usually when there is an anterior dislocation, the overlap of the head over the glenoid will make the diagnosis easy for the radiologist or a clinician to say that there is a dislocation. But here it's not so. The head appears excessively internally rotated. It appears unusually round, making it look like a light bulb. And this reverse Hill-Sachs defect will give rise to a trough sign. And the space between the anterior glenoid and the humeral head, the space will be unusually more. That's the reason these cases are missed by young clinicians. So all cases where when you get the history of an electric shock injury or where you get the history of a seizure, never miss to take an axillary view. Axillary view is a must for all humeral injuries. In an acute injury, so let's say if the patient is unable to abduct and you are unable to get an axillary view, at least ask for a CT scan. A CT scan is very useful. You will not miss the humeral head behind the glenoid. Rockwood Green says about 4 to 6 weeks you can still try closed dislocations. I haven't done that. By 2 weeks, the pectoralis major, lats, everything starts contracting. Closed reduction, maybe 1 week, 10 days, you can try. The crux is, unlike anterior dislocation, you will have to do some lateral traction and do internal and external rotation till the head reduces into the glenoid, which is a difficult maneuver. So, maybe closed reductions can be done up to 10 days. After that, open reductions is a must. Once it becomes more than 3 weeks, open reduction, deltopectoral approach, probably biceps stenotomy. Some amount of pec major release also is needed to reduce these contractures and then reduce the head back into the glenoid. And once you open up the biceps, find your rotator interval, the first thing you have to do is identify the lesser tuberosity. If you have a fracture of lesser tuberosity, it becomes easier to get the exposure. If you don't, you have to do an osteotomy, raise the osteotomy and find the head. I'm talking about chronic dislocations, more than 3 weeks, 4 weeks. It's always useful to do a lesser tuberosity osteotomy and fill the lesser tuberosity osteotomy into the anterior or reverse Hill Sachs defect, what you call as modified McLaughlin's procedure. In the absence of a lesser tuberosity fracture, and if the injury is less chronic, let's say 2 weeks, or the defect is less than 20%, just a McLaughlin's procedure, probably the transfer of subscapularis will work. But most cases, probably the transferring the tuberosity itself will help, around 20%. But more than 20%, you will need an allograft, probably iliac crest. If you have a femoral head, and it is well, preserved and it is clear of infection, you can use a femoral head, and in very rare cases, you will have to use a osteotomy too. Arthroplasty, more than 50% defects, arthroplasty is indicated. Bad glenoids, go ahead with total hip, total shoulder or reverse shoulder arthroplasty. Rehabilitation, ensure that the limb is in external rotation. Don't allow internal rotation to occur. Even minor internal rotation, the head again goes back dislocating because of the contracture. So keep it in external rotation and abduction. Prognosis, 10 days to 2 weeks, the prognosis is generally good. It generally depends on how long the defect has been there. If the defect is large, it's been there for 2 weeks or 3 weeks, the contracture would have set in. In these cases, rehab is difficult. Even if you reduce, the chances of some minor subluxation is always there. So lock dislocations which are chronic, you will have a stable shoulder, but not a very good functioning shoulder. This is, I have a few unusual cases. This is a 25-year-old boy, IT software professional. The first picture was taken in February 2025. He came with that injury. He was treated conservatively by a surgeon. Then he went back in 2025 with that picture. The surgeon still thought that the head is still in place, let us go with conservative management. But by May, he realized that he has lost some external rotation. Then he went for an axillary view. This was a case of case of a seizure. So by the end of May, he had a lock posterior dislocation. So he went in and tried to fix it. What he did was he presumed, he presumed the fragment fills into the reverse Hill Sachs defect and fix that fragment into the reverse Hill Sachs defect, but it still stayed subluxated. Then we had to revise it. The fragment was actually that of a greater tuberosity. So the greater tuberosity required separate fixation, and then the reverse Hill Sachs defect had to be filled with the lesser tuberosity and by a modified McLaughlin's procedure. This is his movements at around 6 weeks. This is another case which is he's an RTC driver. This is a 5-month-old lock posterior dislocation. We explained him poor prognosis because he did not have even little amount of supination or external rotation. We tried to salvage his shoulder. We had some difficulties. He already had developed a pseudoglenoid, and there was severe contracture. We had to release the pec major also. We used a Haworth and gently levered back the head into it and used some iliac crest graft and did a modified McLaughlin also. Although he got back his external rotation and supination, abduction is still weak. He's still in rehab. Now he is probably 3 months post-op. He has some about 40 degrees of abduction, but he has full supination and external rotation and has stable shoulder. I'm hoping he will improve. This case we did about a week ago. This is a 30-year-old man with 4-month-old locked right shoulder posterior dislocation. He is a chronic alcoholic, had alcohol delirium tremens, he was brought late, and unusually he had some abduction, although there was limitation in supination and external rotation, but the defect was close to around 40%. There was some high risk for surgery also because he was throwing seizures every alternate day. For him to optimize for surgery, we took another 1 month. And by the time he came to surgery, it was already 4 months. So we went in and we operated on this case. More than 40% better use femoral head if you have one. Using an iliac crest graft, I found the fixation is good, it is stable, but then I found that there was some some amount of posterior subluxation. It is still staying. It's just 1 week old. We have put him on a brace. We have to hope how it works. Modified McLaughlin is a very useful procedure if the defects are less than 30%. For large defects, always go for arthroplasties. The conclusion is high index of suspicion. Whenever there is a seizure or electrocution injury, always suspect the injury itself will be precarious. Always get an axillary view done. Chronic cases, you will not have a good result, but then operating and salvaging for young patients is always useful. Don't replace the shoulders in young patients. Try to salvage the shoulder. Thank you.
Nice presentation given by Dr. Lal. Please be seated. And I welcome Dr. Ashwin Kumar, who is going to give a lecture on comminuted proximal humerus fractures and surgical management and discussion. Please come.
Thank you, sir. Good morning, one and all. Pointer pause, Raj. Video pause. Good morning, one and all. At the outset, I would like to thank the organizing team at Tosa and Oasiscon 2026 for inviting me to give my presentation on how I will be managing a comminuted proximal humerus fracture. I thought I would make this presentation with the help of a case which I had operated on. This is a 67-year-old gentleman with a history of slip and fall, injury to the right shoulder. He's, as usual, with all the comorbidities they had. He's presented to me with this X-ray, which shows a comminuted proximal humerus 4-part fracture. And as a protocol, we have taken a CT scan, and it has shown that it is a 4-part fracture with subluxation of the joint. Next, please. Yeah, I thought I would go ahead with my presentation with the video that I had made with this case. It's a separate. Stop. Back. Go back, please. Yeah, to start with, I'm using the B chair position after the anesthesia has been given. And as we can see here, keeping the patient in a B chair position with easy accessibility for the C-arm from the head end of the patient is what I want to enforce through this. Continue. After painting and draping the play, yeah, we can see here that through the deltopectoral approach, I'm developing the plane between the deltoid and the pectoralis major, with the first step being the identification of the cephalic vein. As we can see here, that becomes an important landmark for us. And once this is identified, we know that we are in the right plane. Through blunt dissection, the plane is extended. And the next step is to open up the clavipectoral fascia wherein my fracture is exposed. Pause, please. The one important step from here would be that I identify the fracture fragments and build the fracture on the humeral head. Continue. Just pause. So as we can see here, the first step I have taken here is to control the humeral head and to transfix it in the right position to the glenoid. I have used a blunt instrument to see to it that I am able to control the humeral head. Continue. So with control under the CM, under fluoroscopy guidance, pause please. We can see that I am able to get back the control of the humeral head and transfix it in the position which I feel appropriate onto the glenoid, following which I will build the entire proximal humerus on this. The important step here is to understand that we have what is called as the CCD angle, the centrum column diaphyseal angle, which is the angle which is formed between the humeral shaft and the humeral neck axis. The one point that we have to look at here is that anything which is less than 135 degrees will lead to a varus collapse, and anything which is beyond 150 degrees would see to it that my GT would not sit in its place. So getting this angle is the primary step when I am doing a reduction of the proximal humerus fractures. Once I see that this angle is restored, I can, in indirect method, I will also know that the GT is sitting in position, which is my next step. Please proceed. The next step here, pause please, is to get a control of the greater tuberosity and to bind it, as mentioned by my esteemed speakers previously, to get a control with the ethibond suture. Next. Once the sutures are taken through the supraspinatus tendon, I have a control of the GT fragment, which can be indirectly reduced. And once this angle is maintained or is rightly positioned, I will see to it that the GT will be sitting in its position. The next step, stop please. The next step would be, once I know that the head is controlled and the GT is controlled, the next step is to get the shaft onto this proximal humeral structure and fix it with the help of a Philos plate. Next please. The Philos plate is initially positioned with its, pause, with its height indirectly being slightly less than the greater tuberosity. Next please. And being lateral to the biceps tendon. That would be the position of my plate. Once the plate is positioned, its height is maintained with the top K wire, and I get a control of the shaft with the help of a cortical screw. As mentioned by Dr. Srinivas sir, that the medial buttress is an important point here, and I don't give too much of, stop please. I don't give too much of tightening to that screw to see to it that the shaft is lateralized, that I lose my medial buttress. Next please. Next would be the calcar screw that we can see that is being put in row E, which is an important screw over here, which would help me in preventing the varus collapse. And following this, under the CM, under the image intensifier, when I see that the position of the plate in the shaft and in the proximal humerus is optimum, I fill up the remaining screws. The image intensifier is mainly seen in two planes, and both in the AP view and in the axillary view. Pause please. Once the fixation is complete, this is my final position of the implant. Initially, you can see in this picture that the cephalic vein is identified. Following, please go on. The biceps tendon is identified. The plate is placed lateral to it, and I have restored the biomechanics of the proximal humerus. The suture which has been tied has been through the GT has been tied onto the plate. The range of motion of the shoulder is checked to ensure that the fracture fixation is stable in all planes. The final C-arm shot is taken. This is the final picture of the X-rays. And this is the video of the patient at 2 months follow-up, wherein he's having a good amount of abduction and movements has been achieved. Thank you.
Thank you, Doctor. Please sit. Volunteers, please put some chairs here. Audience will have some questions. I first congratulate the organizers who started the prestigious scientific session of Oasis, first time in Warangal, with shoulder joint. It is a very important joint, highly mobile joint, but I can call it as a anatomical paradox because the stability is very much less because of the anatomical conditions. It's a ball and socket where the ball is 4 times larger than the socket, and socket is very shallow. But it is a very strong joint as a unit, because weightlifting, it is necessary. For throwing the arrow, it is necessary. For a bowling action, it is necessary. Even batting, fielding, throwing, everything, it is a highly necessary. So, after surgeries, we are getting some movements. But how far the strength, that is very, very important. Most probably, it will be answered by the next generation very well. Now, as a first speakers, they shouldered the responsibility very well. I request all the audience having some questions or suggestions and share knowledge, because it's a continuing medical education program. Thank you.
Mike, sir, Mike, Ravindra, sir, Mike.
My question to Dr. Srinivas Kashyap, sir. You fix proximal fractures so well, sir. All 3-part and 4-part fractures. I want to know from you, what is your indication for reverse shoulder replacements? So, because of good osteosynthesis in your hands.
So it is, I would say, maybe after 80 years of age, severely osteoporotic. And even then, below 80 years, still you can salvage the shoulder. That's what I usually do. But severely osteoporotic, where your screw cut through is relatively more, and it is, if it is like an eggshell kind of a osteoporosis. That is where I do reverse shoulder. Otherwise, osteosynthesis.
Dr. Ravindranath here. My question to Dr. Praveen Rao.
Sure.
A small suggestion.
Sir.
If you can use adrenaline in saline at the two places where you want to put incisions, your life becomes very easy, number one.
Yeah.
This was the thesis case for one of my postgraduates, ABP, anti-bridge plate. We always use non-locking screws, and we don't tighten them the distal screw, also proximal screw. So you get alignment first, then your angulation can be adjusted while tightening the distal or else proximal screw. It's much advantageous, one. Third one is I always use Homan's retractors, not to go up to 45 degrees, just go up to 60 degrees only, and so that the bleeding will not be much when you're going through brachialis muscle, mostly the distal part of it. Thank you.
Yeah.
Any more questions? Please ask.
Yeah, one question from my side to Dr. Praveen. For a biological plating, what is the learning curve for the beginner, and what are the complications which we can expect, and how to prevent?
I think learning curve is not so steep in this. I think if you can see about 2 or 3 cases, you can start doing it on your own. In fact, I no longer do it. All my, my residents and my DNB students are actually doing it. So surprisingly, I mean, it looks very, looks complicated once you, so many nerves, brachial plexus, arteries, this, that, and we tend to think that all of them are going to come in between. But if you know your anatomy, you know your safe zones, I think it's a pretty straightforward procedure. And I mean, at the cost of not, sounding as I'm blowing my own trumpet, most of these cases don't take more than half an hour to 40 minutes.
Good morning. This is regarding Dr. Praveen sir's presentation ABP. We have done a thesis in our institute also. So, sir, we generally do unicortical fixation, 1 screw above and 1 screw below. Then we correct the angulation. We insert the second screw with both cartridges. And after that, we reinsert the screw, the first one and the second one. Thank you, sir. Very good presentation. And regarding Ashwin, that there is most of the time we have confusion. How to put exactly C-arm lateral view for shoulder surgery. Can you explain that?
Sir, when the patient is in the B-chair position, so based on how much of angulation we have put the shoulder part of the OT table, that is one part that we have to take it as an angulation, sir. So when the head end, from the head end the C-arm is coming, so we have to tilt the C-arm to similar amount of angulation to get an AP view. When it comes to the lateral view from down, because the shoulder blade is quite outside the table, we can get the U shape from underneath, sir. And once we are able to do that, we are able to tilt the shoulder joint in any position that we want. So there also, as much as the inclination is there, that much of angle is subtracted from 90 degrees, sir, to get a true axillary view. In case I find that I'm not able to get a true axillary view, I can always rotate the arm in my favor towards getting what I want.
Just a suggestion to Ashwin.
Yes.
Always put the patient in a semi-beach position, and the anesthesia workstation should be opposite shoulder joint.
Sir.
And C-arm is exactly at the top of the head of the patient.
Yes.
I never move the limb to get the lateral views. It is C-arm that should move so that you get good lateral view to see the end of the plate distally exactly on the bone. It's much easier.
Yes.
Sir, question to Ashwin sir. Especially you said medial calcar screw. Maybe Dr. Kasha may answer also, sir. So Indian patients, they're all small, petite patients. These Philos plates are designed for Western people.
Yes.
If you try to put the calcar screw, sometimes it may not engage the inferior part of the neck and head.
Yes.
It may go to the shaft. If you put more prominent, proximal, it may impinge the acromion.
Yes.
So how to bail out, sir?
Most of the time, as you're right, sir, we have seen that this problem is there. Most of the time, we have to lift the plate a little bit, but by default, if it is going to go anywhere close to the GT or above the GT, it will not be acceptable. I'll as well accept a shaft screw than taking the plate up, sir.
It is a very good practical point which you have mentioned, because all, especially when you are dealing with Indian women, your head is too tiny, and if you proximalize, if your focus is on calcar screw, your plate gets offset on the proximal side, or if you place it well, you cannot address the calcar screw. Then two ways. One is you can use the fourth row where you have got angulated screws, but you get calcar kind of a fixation. Or the last screw, I was just discussing with Dr. Praveen Rao. What he does is he uses cross threading. Once you have a proper trajectory, cross thread into that hole. That can also be done, but these are the two ways, I think. You want to add anything?
Yeah, same thing. I mean, I think most of our women, especially osteoporotic, and especially if you have a little bit of impaction at the neck junction, the calcar screws never go into the place where it is supposed to go. So, yeah, I mean, earlier that was a dilemma. I would never put the calcar screws, and the fourth row screws only would suffice and all that. But nowadays what I'm trying to do is that deliberately I would change the trajectory of this calcar screw so that it goes into the inferior part of the neck, something like a calcar screw itself, at the cost of cross-threading the screws, the titanium screws. I know you get cold welding, it might be an issue, but then that's for a later date. I don't know what's going to happen. Let's see what.
Imported implants don't allow this cross-threading and change in trajectory, because we do a lot of Indian implants. Very easily you can put a nice fully threaded cancellous screw against the threads of this thing. It will go and seat nicely. Keep some Indian screws, you will do it.
Even imported screws, if you cross thread it, you can do that. So, but getting it out is very difficult on table also.
Sir, this is Dr. Jayaprakash, sir. Sir, my question is to Praveen, sir. What are the chances of non-union with that procedure, sir? Whether to explain it to patient about that, and what is your experience in that?
I've not had a non-union up till now, at least all the patients who have come for follow-up. I've had a fracture when the patient fell down and had a sort of a refractured it. I've not encountered non-union up till now. Probably I'm selecting my cases. Maybe there's a selection bias or what. I would expect a non-union only in two situations. One, if my fracture is not reduced well and there is distraction there. Any distraction more than 3 millimeters or so, I think non-union should be there. And maybe in cases of segmental fractures, you could probably, expect that. I have not seen a non-union up to.
Last question, please.
My question is to Dr. Shashi, sir.
Last question.
So separately now, recently some GT plates have come, sir. Any experience with that for single GT fracture?
Yeah, GT fragment fixation plates you can use, but the most important principle, as I said before, is securing the footprint, the tendons attached to the GT. That is what you need to secure. Do it with a small low-profile plate. Yeah, that is also being used. Yeah, in comparison with the normal Phylos plate, the low-profile GT plate probably would be more useful, at least to prevent any impingement or anything. But the most important thing is to get the tendons back to its normal tension. That is what matters in the success of GT fixation.
Yes, I congratulate all the speakers and also audience who shared their knowledge. And one point to the postgraduates, you read thoroughly anatomy well and the clinical examination very well, and also you should know what are the tests for the dislocation, what are the tests for the apprehension, what are the tests for labral pathology, what are the tests for the impingement, what are the tests for rotator cuff. Everything you should know regarding the shoulder joint. Then you can jump into the MRI and you can do what the final diagnosis. Thank you, all the organizers, for giving me the opportunity. And also, I thank my co-chairpersons, Dr. Poner Rao and Dr. Surendra Garu. Thank you very much.
request Vijay Chandra Reddy sir, President-elect, to do the honors to the chairman. Request Raghuram sir to. I request the volunteers to see that the next session is ready. The pen drives and other things. Kindly look into it. May I now request, we are going to start the second session. This session is on unstable elbow challenges and solutions. Request Dr. V. Ashok sir, Dr. Kishore Kumar sir, Dr. Ganu Krishnamurthy sir to chair this session. I request all three members to come onto the dais and occupy their seats and start the proceedings. Ashok sir, Krishnamurthy sir, and Kishore sir. Hello.
Thank you for inviting as chairman and co-chairmen of this team. Now the important topic is the unstable elbow, the challenges and solutions. First of all, I'll call Dr. Uday Kumar to speak on terrible triad of elbow. Dr. Uday Kumar.
Good morning, everyone, and respected chairpersons, and my professors and colleagues sitting in the audience. I sincerely thank the Tosa organizing committee and organizing committee of Oasiscon for giving me this opportunity. Today, my topic is on terrible triad of elbow. So these are the headings under which I am going to discuss this talk. First of all, we have to define the injury, and we have to little bit know about the stability, and then mechanism of instability, and we have to assess the clinical assessment and radiological assessment, and then there is no conservative treatment for this injury. It is the surgical treatment only. So we have to know the surgical sequence and fixation priorities. And then we have to test the stability on the table itself, not post-operatively. We have to check the stability on the table. And the most important thing is the post-operative rehabilitation, and you also should know the complications. So this is a combination, this is a combo of terrible triad, elbow dislocation, radial head or neck fracture, coronoid process fracture, with or without lateral collateral ligament injury. So it is one of the most unstable elbow injury patterns. The failure of one stabilizer increases the load on the others. Untreated instability leads to redislocation, stiffness, and arthritis, loss of function. So it's a mandatory to intervene as early as possible. Successful treatment depends on restoring stability, not just fixing the fractures. Now, a lot of advances have come. The days we started our postgrad in 1982, now in 2026, a lot of developments have come. And then we are in the modern era. There are many protocols have improved outcomes, but complications still remain very common. So the stabilizing structures, why these are three structures are important. The radial head is the valgus and axial support. When we were students, we used to exercise the radial head whenever there is a fracture. So that is very common procedure those days. But that over the period of time, we realized the importance of radial head. It is the valgus and gives the valgus and axial support. The coronoid is the anterior bony buttress. The lateral collateral ligament complex is the posterior stability provides. And MCL secondary stabilizer often heals if the elbow remains reduced. Usually, we need not address the MCL. If we address all the above three, that is more than enough. So mechanism of injury is the most often due to fall and outstretched hand. It is the posterolateral rotatory force is typical, and injury progresses from the lateral to the medial structures. This is the first one that fails is the lateral collateral ligament complex. So the mechanism of injury progression, elbow dislocations are thought to occur with a progression from lateral to medial. Complete dislocation is usually associated with the disruption of the medial and lateral collateral ligaments and anterior capsule. You can see the sequence there on the right side. So clinical presentation as usual, we have the pain, swelling, deformity and loss of motion. Elbow may appear grossly unstable after reduction. Always assess the skin condition also. Don't forget to look for the neurovascular status. And open injuries are dealt separately. Check for associated wrist and forearm injuries. So the obtain imaging, obtain AP and lateral photographs. Use CT scan to define fragment number and comminution. Assess radial head reconstructability. Look for associated injuries and soft tissue swelling. We don't require MRI to assess these injuries. So what are the treatment goals? So we have to achieve a concentric reduction of the elbow, and we have to restore the radiocapitular contact, and the coronoid buttress also should be re-established, repair lateral collateral ligament complex, and it is the key for success of the functional restoration is the start early controlled motion once you ensure stability. The surgical sequence is, you can see the algorithm on the right side. First mobilize the radial head fragments, and before radial head fragments are mobilized, and you can also simultaneously fix the coronoid fracture before you address the radial head fracture. Then fix or replace the radial head or neck depending upon the situation. If the combination is more, which cannot be reconstructed, you have to replace the head. Now it is very regular practice now to replace the radial. We never had it when we were students, radial head process. Repair the LCL and test the stability and the procedure on the table itself. And approaches, there are supine position with arm on the table, there the post approach is there, allows access to both medial and lateral sides, and lateral approach is common for radial head work, and Cocker's Kaplan interval may be used depending upon the exposure needs. And coronoid fixation, as everybody knows, is small fragment, you have sutured with a suture lasso. Larger fragments have to be fixed with screws. The coronoid is important because it resists anti-translation. If you don't fix the coronoid, there is every chance this elbow may redislocate again. Fixing the coronoid early may improve exposure and stability. And radiated management is radiated contributes to valgus stability and axial load transmission. Simple exertion is unsafe in unstable elbow injuries. Preserve or restore the radial head whenever possible. Now you cannot afford to exercise the radial head now. Lag screw fixation when there is a partial segmental fractures, and plate fixation, larger repairable patterns, replace with prosthesis, comminution is severe. More than 3 fragments or reconstruction is reliable. But be careful of the post-intrusion nerve while operating on this proximal radius fractures. And ligament repair the LCL after boning reconstruction, use suture anchors or transosseous sutures. MCL repair is usually unnecessary if the elbow stays reduced. Consider MCL repair only when instability persists. Intraoperative stability, check the stability with full gravity extension. Test with the forearm in neutral. Use lateral fluoroscopy to confirm constructive reduction. If instability persists, consider MCL repair. Use injured external fixation, cross spinning or internal joint stabilizer. The instability persists. The role of external fixation is the injured external fixation is reserved for persistent instability. It allows protected early motion, useful in severe soft tissue injury or inadequate reconstruction. Should not be routine if a stable internal repair is achieved. The post-op protection is very, very essential. Short post-sprint may be used for comfort. Drains if used are removed early. Prolonged immobilization should be avoided when stability allows. So rehabilitation protocol is the begin active assisted motion with the first few days if stable. Encourage flexion, extension and pronation and supination. Delay resistance exercises until healing is secure. Avoid heavy loading for 6 to 8 weeks. Follow-up review every 10-20 days initially. Monitor range of motion and wound healing. Watch for loss of reduction, pain and stiffness. Continue rehabilitation until function is improved. So outcomes, modern surgical treatment often gives satisfactory function. Average function scores have improved in contemporary series. Good outcome depend on stable reconstruction and guided rehabilitation. Return of motion strength is gradual, not immediate. So complications are inevitable even in the modern era also. You can have elbow stiffness, heterotrophic ossification, ulnar neuropathy, recurrent instability, arthrosis and hardware irritation. And take-home message is, terrible triad is a common unstable injury. Reconstruction should restore coronoid, radial head and LCL. Check stability before closure. Early controlled motion is key once the elbow is stable. The final goal is a stable, concentric and functional elbow. Thank you so much for your kind attention.
Thanks, Dr. Uday Kumar Garu, for excellent presentation on the topic of terrible triad of elbow. I will call next speaker, Dr. Prabhudir. He will speak on complications of successful fixation, interarticular complications of the elbow fractures. Dr. Prabhudir.
Good morning, chairpersons. I thank the Oasis and the Tosa, the organizing committee, for giving me an opportunity to be here. Greetings from the Gandhi Hospital. The topic is complications of intra-articular fractures following fixation of the elbow fractures. The objectives of my talk are to understand the spectrum of complications, prevention strategies, evidence-based management. We'll go with a case. This is a case of a 38-year-old male, a right-handed person, an engineer with a grade 1 compound. He presented early. We operated him early. This is the... We did open reduction with a posterior approach. Had a good reasonable fixation. He also had a capitular fracture. Identified the capitular fracture, went through an anterior approach preserved the radial nerve, put a screw from anterior to posterior, saw that it was not impinging the radial head. Very happy at after the completion of the surgery that we had a very good stable fixation, good anatomical reduction. So that was the pre-op X-ray, and that is a post-op X-ray. Appears to be reasonably okay. Started the ROM from the day 2. That was the fracture when it has united fractures. This is another case in an elderly female patient, had a comorbid, was a high risk for surgery. So we decided to do a percutaneous K-wire fixation. So these are the images where the fracture went on to heal well. Patient was immobilized for a sufficient time to allow the fracture to heal. So at the end of the good result. We had not a good result with a very well anatomically reduced, early mobilized, and here is a patient where we have immobilized for a longer time but had a good reasonable elbow movement. So elbow, even in an experienced surgeons, the good result to excellent results are only 75. That indicates that about 25% of the elbow surgeries or the distal humerus surgeries are associated with complications. So elbow is a very unforgiving joint. It's because it's a highly congruent joint. It has a limited tolerance to malreduction, and early motion is essential. Coming to the classification of the complications, we classify the complications as intraoperative, early postoperative. Ulnar neuropathy occurs in about 13% of the distal humerus fractures, and it may be related to the injury per se, or it may be related to the mobilization, the stripping, compression by the implant, or by the scar formation. Now, how do we prevent the ulnar nerve injury perioperatively? It is by careful handling of the ulnar nerve, avoid overhanging of the hardware. Now, coming to the question of whether we should do an anterior transposition of the ulnar nerve or not. So, routinely, it is suggested that it is not necessary to do an anterior transposition of the ulnar nerve. Then, what are the indications for transposing the ulnar nerve? Ulnar nerve, when it is injured preoperatively, it can be transposed anteriorly. When there is a fracture involving the medial condyle, medial epicondyle, which may be causing a scar tissue and causing an entrapment of the ulnar nerve, it's better to do an anterior transposition. If the nerve is being tented by the implants, and when you are trying to do an open arthrolysis in a case of joint stiffness following the surgery, the early complications are the implant, or rather the intraoperative complications are the implant malposition and the mechanical failure. Elderly patients with osteoporotic bones always use a locking plates, and also be ready with a elbow prosthesis when there is a comminution and a poor bone quality. Orthogonal 90-90 plate configuration is better. Yeah, a parallel plating is equally good. Avoid ending the medial and lateral plates at the same level, as it may cause a peri-implant fracture due to stress rises. One of the plates should always be about 3 to 5 centimeters beyond the other, and avoid penetrating the articular surface with the screws, whether in the trochlea or into the olecranon fossa. The early postoperative complications are the hardware irritation. It is seen in about 22 to 50%, which is due to the implant prominence, because there's not a bulk, triceps is not a bulky muscle, and it's a very thin skin there. It's one of the common complications where we will be seeing the hardware irritation, but in spite of that, the patient have a reasonable good range of movements. We can leave it until the time the fracture heals and can be removed at a later date. Infection is seen in about 1 to 4% of the patients with the distal humerus fractures. It is commonly associated with open fractures, patients who are smokers, and a prolonged surgical time is again a predisposing factor for infection. Infections can be superficial and deep. The superficial infections are easy to treat, whereas the deep infections are the challenges. Like the prosthetic joint infections, you can do the DAYR, the debridement, antibiotics, and the implant retention. The late complication, these are the real challenges of the complications of the elbow fracture, is elbow stiffness, the heterotopic ossification, malunion, non-union, and the post-traumatic arthritis. Elbow stiffness is a big challenge because elbow stiffness causes significant limitation of the activities of daily living. However the good the surgery may be, we have to keep our fingers crossed because we don't know the range of movement what the patient may be ultimately getting, because it is not only the surgical factors, it is also the patient factors which contribute to the elbow stiffness. It is due to the unique anatomy of the elbow joint with a profound capsular inflammation, tightly stabilizing collateral ligament, and the relatively confined joint space. And the causes for the elbow stiffness are the initial trauma, the surgical trauma, the heterotopic ossification, and the post-traumatic arthritis. The post-traumatic stiffness has 4 stages: the bleeding, edema, granulation, and the fibrosis. Murray et al. Has classified into intrinsic, extrinsic, and combined causes for the of elbow stiffness. Intrinsic, those are associated with intra-articular adhesions, malunion, loss of articular cartilage, protruding hardware, loose bodies, and infection. Extrinsic are capsular and ligamentous contractures, extra-articular malunion. Combined are both intrinsic and extrinsic. Earlier it was thought that 30 to 100 degrees of flexion was needed for ADL, but with the modern days of usage of mobile phones, we needed a greater arc of flexion. Early mobilization will help in the prevention of the elbow stiffness. Treatment is either conservative by physiotherapy, manipulation under anesthesia can be done under 8 weeks. Beyond 8 weeks, if you are trying to do, it may cause an iatrogenic fracture. Better avoid manipulation under anesthesia after 8 weeks. Surgery is by arthrolysis, whether open or arthroscopic. And then in post-traumatic arthritis, it is elbow arthroplasty. So these are the indications for open and arthrolysis and arthroscopic arthrolysis. Whenever doing an arthrolysis, posterior approach is always better. That's about the heterotopic ossification, which is a big challenge. So treatment would be the excision of the arthrolysis. With maturation of the ossification, elbow becomes cold, which is occurring between 4 to 8 months. Beyond 8 months, it may be causing damage to the articular cartilage. So if at all you have to do an heterotopic ossification surgery, do it before 8 months. And there's a non-union. The treatment for non-union is here the plate has been short, the screws are not having a good hold. Do a parallel plating, bone graft, iliacus bone grafting, and most important is the capsular contracture release. Without releasing the capsular contracture, the non-union again may go into a non-union. So this is about the malunion. It's extra-articular malunion is easy by osteotomy and fixation. Intra-articular malunion is a challenge where the literature is also not sufficient. So these are the incidences of the various complications, and that's the take-home message. It's an unforgiving joint. Meticulous planning and execution minimizes complication. No need for routine ulnar transposition. Elbow stiffness is the most common sequelae even after stable fixation and proper rehab. Don't assure full ROM, and in elderly patients with comminution and poor bone quality, have a prosthesis ready. Thank you very much. Thanks the organizing committee. Thank you.
Now I request the speakers of first session and the next session, Dr. Uday Kumar Garu and Dr. Prabhudir, to come out to the dais to take the questions. The discussions.
Now I request the audience pose questions to the speakers, clarify their doubts.
Sir, Uday sir, wonderful talk, sir. Prabhudev sir, small question, sir. For elbow stiffness, heterotopic ossification, do you give any prophylactic like indomethacin or low dose of radiation to prevent the heterotopic ossification?
I think Prabhudir can answer better than me.
Yes.
His topic is the elbow stiffness and other. He has given already a talk on that. I think.
Yeah, the answer for that question of whether prophylactic indomethacin or low dose radiation will be helping in the preventing the elbow stiffness. There are various studies which have where both indomethacin and low dose radiation were used, but ultimately the studies show that though indomethacin and low dose radiation had decreased the incidence of elbow stiffness, but there was a high incidence of non-union.
But most of the stiffs, sir, post-traumatic stiffness, we will send to the physiotherapist. They do aggressive, passive physiotherapy. That may also increase the incidence of HO.
Yeah, absolutely right. That we have to even caution the patient and make them educated that it is the active treatment which is more important rather than the passive. And the physiotherapist should not be aggressive and expecting that that fellow should be giving a good result. He may be causing more harm. Agree with that.
Sir, how long you will wait to interfere, like arthroscopic arthrolysis or open arthrolysis? You give window period of 6 months or 3 months of post-traumatic
yeah, I'm not an expert in arthroscopic arthrolysis. But anyway, talking about the open arthrolysis, in case of with a heterotopic ossification, it's better to wait at least for about, you can start away at 4 months, because until 4 months, the elbow will still be hot. And probably at 4 months, the bone will be maturing, the ossification will be maturing. And between 4 to 8 months, beyond 8 months, you will be causing, because the articular cartilage will be degenerating. So it's better to intervene early whenever the elbow is cold.
Jagan, okay, please carry on. Usually, these type of sort of cases, I never send my patient to physiotherapist. I make it especially knee joint and elbow. I never send my patients to any physiotherapist. I teach my patient my own way of doing things only. Because they do it differently. The problem is, they don't, the service should be complemented. But they feel they are individuals. They don't consult us, they don't contact us. So that is the issue.
Sir, in some cases like elderly, very highly comminuted elbow fractures, do you do primarily elbow replacement in elderly, low demanding patients? Very distal fracture may go into non-union. How best do you fix it? So is there any role of primary elbow replacement in elderly, highly comminuted distal humerus fractures or elbow fractures, sir?
I think this question is out of our purview, because we have not discussed the TER in this. But I just say Kasha is there. I think Kasha, can you answer Jagan's question? What is the indication for primary TER? Primary TER.
For trauma, sir, primary total elbow arthroplasty I don't recommend. And it is distal most comminuted with severe osteoporosis. One can consider total elbow arthroplasty. But I personally still reconstruct the joint.
I also haven't got an experience of doing elbow replacements in acute trauma, but the literature suggests that whenever there is an elderly patient with osteoporosis and severe comminution, it is always better to have a elbow prosthesis ready.
Hello.
Hello. Now the next one important presentation in the second session is by Dr. Walia, minimally invasive release of stiff elbow, arthroscopy and open approach. I request Dr. Walia to come out to the. Request the persons to be seated.
ఏది ఇదా ఇది
Check.
ఇది good morning. See, this is a very rarely done procedure, elbow stiffness. So most of the time after seeing the any elbow stiffness, we will be advising only physiotherapy. But this is the say where we have done almost more than 20 cases. So this is elbow is as you know, this is very sensitive for trauma. So most commonly affected joint in the entire human body. Then not moving. So this is the functional arc is 30 to 130 degrees. Though it is range is 0 to 150, but we need only 30 to 130 is that is functional arc. Then supination and pronation may be 100, but it is only 50-50 is functional arc. So most of the time dysfunction, flexion is more dysfunctional than extension. So these are many causes. Already our Prabhudir already explained these causes, intracapsular, extracapsular and combined. So the mixed type, this most post-traumatic conditions are mixed one. Both will be there. Is not moving. So, see in the evaluation, see routine history, clinical examination, see here most of the time history of massage will be the common culprit. So, and that is the quack treatment, and we have to find out duration. See 6 months, 1 year, depending on the duration our management will be changing. So, elbow trauma, that is the trauma or pathology. Pathology may be infection or inflammation. So then comorbid condition, we should know the hemophilia or neurological conditions where it will be, the stiffness will be very known. See then coming to clinical neuro, ulnar nerve, whether ulnar nerve is intact or not, we have to see, check beforehand. So then at the same time, we have to see the shoulder, wrist, hand range of movement. See, the end point is whether the soft end point or hard end point like ACL. We have to check whether it is bony hard or soft. Okay, is not more. So X-ray, see AP lateral, and you have to take oblique view and CT scan, and even sometimes continuous fluoroscopy exposure will be telling whether the all around the bony spurs. Then differential diet, this is so the treatment options are non-surgical and surgical. See here minimal contracture and 6 months or less, non-osseous origin, you can try non-surgical. See, the different modalities which can be used are active and passive exercises, static splinting or static progressive or dynamic splinting, CPM machine, botulinum toxin, and even manipulation under anesthesia. See, this is different from the knee where only 3 weeks duration is post-operatively you can manipulate, but we have to, in this elbow, we have to wait at least for 6 weeks post-operatively. One should not
do the manipulation under anesthesia before 6 weeks. See, these are the different splints, static progressive splinting. This is the only principle of creep loading, that is gradual loading. So that the extension splint or flexion both are available. Then surgical options are, there are arthroscopy, open or combined, both will be used, and interposition orthoplasty, total orthoplasty, bone resection. These are the different options available for the stiff elbow. Hey, this is not proper. It's not functioning.
Bike burn.
B side. Okay. So these are the options. So arthroscopic, see, this is the arthroscopy is indicated where the stiffness is mild or moderate, and less severe disease, arthroscopy will be recommended. So the complications with the arthroscopy is one delayed onset dawn, that is they are described like tardy ulnar nerve palsy. It will be ulnar nerve palsy will be delayed, presentation will be there with arthroscopy. That is almost, they are described 11%. So see, prophylactic ulnar nerve decompression is recommended, though we are doing arthroscopically, we are releasing the arthroscopically, but prophylactic ulnar nerve release is recommended. Then open contracture release, here the approaches are maybe the medial, lateral and posterior depending on the pathology, and depending on the, see this incision depending on the previous skin conditions and the pathology, and see the approach will be depending on pathology and direction of the loss of motion. So the passive flexion less than 90 degrees, where we have to do the releasing of the posterior band of the MCL and ulnar nerve decompression. So the lateral column approach, this is the proximal to the elbow joint, is any bony obstruct is there, means we have to go between the ECRL and triceps, and distal to the joint means between the ECRL and ECRB. Then this is the very important approach. This approach I have used in all the 20 cases. See, medial column approach, that is MOTT, medial over the top approach. See, where we can reach the joint anteriorly. See, it is beyond the joint, like drone approach. See, we will be looking from the above. So medial over the top approach, where you can even in the same sitting, same approach, you can release the ulnar nerve also. See, and this is the one more option is interpositional arthroplasty. See, interpositional arthroplasty, this is very unique for the elbow. See, if the articular surface is involved more than 50%, this option will be there. That to young patient. The older patient, like more than 60 years, where direct arthroplasty. So here we can use the biological materials as a facial leta or allograft, Achilles tendon allograft, or graft jacket like dermal graft. See, after putting this graft interpositional tissue, we have to immobilize with the external fixator till it take the attachment. This is a very important step. Then coming to total elbow arthroplasty, the elderly patient, more than 50% articular surface is involved. This is the option. Then the proximal radial bone resection. This is like here in the picture. See, there is a the bone formation. See, just distal to that exostosis or bone formation, we can resect the 1 centimeter radius and we can achieve the supination pronation. This is the, then our cases, see, we have done anterior arthroscopy, posterior arthroscopy, and medial over the top approach of the Hotchkiss. This is the person who has described the medial over the top approach, then posterior approach. So here we will see here the patient is presented with this history of massage with a trivial injury 1 year back. Range of movement is 110 degrees. Here we have done the posterior arthroscopic release. See the pre-op and post-op, we have removed the posterior osteophytes. Then a 5 month post-op, this I told that is ulnar nerve. Dawn, I told Dawn. Delayed onset of the ulnar nerve. This is the patient has developed the ulnar nerve palsy, but subsequently they recovered. Then anterior arthroscopy. This patient is admitted for the total elbow arthroplasty, but we have done this anterior arthroscopy. See, these are with the burr we have removed this osteophyte. This is a pre-op and post-op radiograph. Then this is see here we have achieved the extraordinary supination. Here patient is unable to eat. Supination was not there. So we have achieved the full supination. Here the lower picture you can see. See, then this is a medial over the top approach. This is the very extremely good approach where we have used here one software engineer. He came with the 90 degrees. This is the range. So he don't want to continue the physiotherapy after 6 months. So this is the here video. See, you can see this is the medial over the top approach, where see video we can see the complete flexion. Video is not playing. So there is one more. This is a one more person. Is one more patient is a gym trainer. So 2 years old post traumatic and post massage. So here we have isolated the ulnar nerve. Videos are see almost full flexion, achieved full flexion. And this is the subsequently we have to give that splint. This is one more patient. Here, a very good message, take over message here. This is the patient with coax treatment. Immediately the surgeon has operated. And the patient is landed in stiffness, complete stiffness. So any massage one should wait for at least 3 to 6 weeks till it becomes silent. The surgeon is not aware of that. After immediate massage, he has done the surgery and completely it has become full stiffness. So where we have done this is at least we have achieved in the beginning 10 to 20 weeks, subsequently. So then the take-home message is arthroscopic contracture release in mild and moderate cases. The one problem is this ulnar delayed tardy ulnar palsy. Then medial over the top approach is the ultimate approach. The last static and progressive splints, that is creep loading. That is very, very much important. And CPM machine in the immediate post-operative. Thank you.
Okay, thank you, Dr. Walia Garu, for a nice presentation. Now I request the presenters to be seated on the dais. For honoring for their presentation.
We are starting the inauguration of the Oasis CME right now. Chief guests have come after these felicitations. I request Sudhir sir to coordinate this inauguration event.
Andarki namaskaram. We request the August gathering to stand up for the Vande Mataram song.
Vande Mataram.
Dignity spike will chera.
May I request our President Oasis, Dr. Krishna Gopal Garu, to come onto the dais. We will play the song after the dignitaries have come to the dais. Request our Chief Guest, Commissioner of Police, Warangal Commissionerate, Srimati N. Shweta Madam, to come onto the dais. Request Dr. Ram Kumar sir to accompany her. May I request our Secretary General Oasis, Dr. Roshan Kumar sir, to come onto the dais. Our organizing chairman, Tosa Oasiscon 2026, Dr. P. Vijaychandra Reddy sir, please come onto the dais. I request our scientific committee chairman, Tosa Oasiscon 2026, Dr. D. Maheshwar sir, to come onto the dais. Now, please play the Vande Mataram song.
Sujalam Sufalam Malayaj Sheetalam Shasya Shamalam Mataram Vande Mataram Shubhra Jyotsnam Pulakitayamini Kusumita Drumadala Shobhini Suhasini Sumadhura Bhashini Sukhadam Varadam Mataram Vande Mataram Koti Koti Kantha Kala Kala Ninada Karale
Thank you. Now, Jyoti Prajwalana by President. బుకేలు ఇప్పుడు కాదు, ఇప్పుడే ఇస్తాం. ముందే ఇస్తారా? Request our beloved President OSS, Dr. Krishna Gopal Garu, with all the other dignitaries on dais to do the Jyoti Prajwalana.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं पुत्रांश्च मतिं स्वच्छाम्.
Now I request our beloved President OSS, Dr. Krishna Gopal Garu, to announce the release of the scientific program and announce the starting of the conference. Thank you, sir.
Respected Commissioner of Police, other dignitaries on the dais and off the dais. Happy and pleasant morning to all. Greetings from Pondicherry Orthopedic Association. It's a pleasure standing before you in such a beautiful auditorium with eminent seniors, colleagues and enthusiastic juniors who are attending this Tosa Oasiscon 2026, which marks a silver jubilee year. The CME theme, upper limb trauma, is a very important one, and the topics are very meticulously selected for the need of the hour, covering all the aspects of it. I congratulate VCR sir, fondly said so, for arranging such an excellent program. I was wondering until I came here regarding the communication and other aspects, but I was excited and surprisingly it's amazing to see such a venue, speakers, topics and hospitality. I request the junior colleagues to stay in the hall and listen to the talks. You may see all this in the digital media, but the speakers take efforts to speak what is necessary and they give their experience and evidence-based inference. So please be within the hall to attend when the talks are going on and tell your colleagues who are not inside that they have missed a lot. Even if you learn one point, it's a good one. With this, I inaugurate the CME and wish the program a grand success. Thank you.
Thank you, sir. Now I request our chief guest, CP Madam, Srimati N. Shweta Garu, to give her message.
Very good evening. Good morning, everybody. Frankly, I really consider myself very out of place here, given I'm in the midst of so many doctors, which I am not. However, I really thank Ram Kumar Garu for inviting me here to be the chief guest. I consider it an honor and privilege in the midst of all of you. And definitely, I am sure this is going to be a great value addition, especially to the youngsters, where the knowledge will be passed on, the years of hard work and thousands of hours of practice. The wisdom from that practice will be passed on to the younger generation. I am sure it will be a great value addition to all the youngsters. Of course, continuous learning keeps you young. That's why I'm sure a lot of seniors, really seniors, very active and, defying all aspects of age, both mentally, physically. And I think some of the credit should be given to the continuous learning. I'm sure I'll be supported by the medical evidence as well. Thank you very much. And as Commissioner of Police, I consider it a privilege to be in Warangal and to be hosting in this, second tier city, to be hosting such a privileged conference. I think this will be a landmark in your field and also in our field, that the city of Warangal is hosting South India level conferences, professional conferences. Thank you very much. We always extend cooperation in all its aspect. Thank you, and wish this conference all the success. I am sure we'll be ready. The city will be ready to host many more such conferences. Thank you.
Thank you, Madam, for your warm message. Now I request our President, Organizing Chairman Dr. V. Chandra Reddy Garu and Organizing Secretary Dr. Ram Kumar Reddy Garu to honor our chief guest with a memento, shawl and a bouquet. Please accept, Madam. I request our President. Now I request our President, Dr. Krishna Gopal Garu, to be honored by our Organizing Chairman and Organizing Secretary. Request our Secretary General to Roshan Sir. It's our pleasure, sir, to honor you. Secretary General, OSS, Dr. Roshan Sir. I request the August gathering to stand up for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you. We'll continue with our sessions now. I request Dr. Rakesh sir to carry on.
Coming back to our academics, we would start with our wrist and wrist wizards. I request the chairpersons, Dr. Kodeshwara sir, Dr. N. Srinivas Reddy sir, Dr. M. Srinivas Murthy sir, to come on to the dais and chair this session. It's going to be an interesting session. Request all the speakers to be on time. We are going a little delay in the schedule. I also request Dr. Srivant also to come on to the dais, please.
Yeah, we are starting the next session on the wrist, which is very interesting and at the same time difficult also. We are having very eminent speakers who are specialized in wrist surgery and wrist specialty. We are having 6 topics and I expect, okay, for the first one is Dr. Manish Jain on distal radial ulnar joint instability associated with distal and radial fracture. Please start your lecture.
Respected chairpersons and delegates, very good morning to everyone. As chairpersons told that it's going to be an interesting thing. So from hip to elbow and now to the wrist. And in the wrist, we are again talking about a very specific joint, which is a distal radial ulnar joint. So my topic given was, what is distal radial ulnar joint instability and in distal radius fractures? So there are many confusing questions most of us as a treating orthopedic surgeons would have when treating a distal radius fractures. Most of the times you see that the ulnar head is dorsally subluxed in the x-rays. Sometimes you feel that it is unstable even after fixing it. What to do? Sometimes there is an ulnar styloid fracture. Sometimes it's a tip fracture, we think we can leave it. Base fracture, we need to fix it. So what is the literature saying and what are the studies done? So I'll be giving a brief outlook on all these important aspects of distal radius fractures. So before we proceed, what we definitely need to know is whenever you're treating a distal radius fractures, we have to get these 4, in fact 5, I'll get the 5th one in the next slide, parameters absolutely right. The radial inclination, the radial height, the volar tilt and the ulnar variance. So these are the normal values. And the 5th and most important, which we often neglect, is the teardrop sign, which is formed by the ulnovolar fragment of the distal radius. So most of the times in lateral view, we only look for a volar tilt, but we should also look for a teardrop sign. If this teardrop sign is below the normal 40 to 50 degrees, then there is a volar ulnar fragment which is not reduced while fixing it. And these are the acceptable, you can see on the right side of the table, and on the left side table, there are the normal values. So before we go into DRG instability, what is stabilizing the distal radial ulnar joint? The capsule, the TFCC complex, the distal oblique intraosseous membrane. Most of you might not be aware of this part. In the intraosseous membrane, the distal most oblique band also stabilizes the distal radial ulnar joint. The dynamic stabilizers like pronator quadratus and the ECU subsheath also. And so when to suspect DR region instability when you are doing a distal radius fractures? look for radial translation, ulnar styloid base fractures. Is there a dorso-ulnar fragment on the CT scan or volo-ulnar fragment? And get back your radial height and inclination. If these things are there, you should suspect that there can be a DRUJ instability. So what is a DRUJ stable fixation? Whenever you are treating a distal radius fracture, and you should know that, yes, your DRUJ has become stable. So very interesting Gothic arch concept you need to know. Whenever you see in a PA view, the marker is, sorry. So whenever you see in the PA view, you can see in the second picture, you draw a line from the ulnar border of the radius straight towards the carpus, and you draw a horizontal line on the lunate. The ulnarmost point of the lunate should be ulnar to this line after your fixation. It should never be on the line or radial to the line. If this point comes on or radial to the line, that means your DRUJ is unstable. There is a radial translation which you need to correct. So, radial translation, as you can see in this picture, the black line, and you see in the top left A picture, the radial, the lunate point is on the ulnar side, which is normal. You can see in the down, in the C and D, the lunate point has come onto the line, and in the D it has come radial to the line. That means the DRUJ is unstable. So this is one way you can measure your DRUJ instability when fixing it. Not only radial translation, you can see in this picture, the radial translation has been corrected, but still you see that red dot is radial to the line. What are we missing here? You should also look for the inclination. Unless you get back the inclination also, you don't get back that ulnar lunate point or ulnar to the line. So as I mentioned in my first slide, you should get back your 4 parameters absolutely right after fixing your distal radius. And how to get things right on OR table. So whenever you see a translation, correct the translation either by drifting the proximal part of the radius to the radial side or the distal fragment onto the ulnar side. And sometimes even if fixation looks good, you can see on the right side of the picture, still you can see the TFCC and the intraosseous membrane are little lax. So in that case, before putting the other proximal screws, just increase the radial height a bit. You can see the intraosseous membrane and TFCC has become tense. So that will make your joint stable. This is a very interesting article on this topic. It is a must read. You can have an entire very absolute idea on how to manage the distal radial joint instability in distal radius fractures. And 50% of it I have spoken already. So whenever you get an acute distal radius fracture with DRUJ instability, first get the anatomic reduction of the radius and then see for the stability. If it is absolutely stable, don't do anything. Then sometimes you have partial unstable. This is most of the times we encounter this part. It feels like the ulna is moving. Okay? So that is where we get confused what to do. In that case, you again try to get back the radial height if possible and then stick for instability. And if still the partial instability continues, you can either put a plaster on above elbow for 4 to 6 weeks. And if the DRUJ is unstable in all the direction, then it is absolute instability. You have to look for the causes. Whether your radial fixation is not good, whether there is a big ulnar styloid fragment, or it could be a TFCC tear. And that you have to manage accordingly. So usually patient present with ulnar sided pain or difficulty in lifting weights. So this review article from Journal of Hand Surgery talks about the pearls of managing acute distal radial ulnar joint instability following the distal radius fixation. Very interesting point in this article is, what they say is, they have compared people who have repaired TFCC after fixation of radius and compared with people who have just managed with plaster or the K-wire fixation from ulnar to radius. What they have found is people who have managed with plaster did well compared to people who have repaired the TFCC in terms of grip strength and in terms of range of movement of pronation supination. So the ulnar styloid, most of the times we think that yeah, it is a base fracture, it needs to be fixed. What is the literature saying? We have our own study from India, from Ganga Hospital. Should ulnar styloid be fixed? Yes or no? The conclusion is the base fracture is associated with most of the times instability, and if the displacement is more than 2.1 mm, then only you need to fix. Otherwise, most of the ulnar styloid you don't have to really fix them. So what if patient comes late to you? Somebody else has fixed fracture and you get instability. Patient comes pain with you. What is the literature saying about it? So first you have to diagnose it clinically. The best test is the press test. and get a CT scan. Better to do a dynamic CT scan of both the wrist, impronation, supination and mid-prone, and look for the radioulnar line and epicenter method. These are the ratios. You can talk to your radiologist. And work up for the possible causes. It could be a malunited distal radius or a non-union of ulnar styloid, could be a TFCC tear, or there could be a DRUJ arthritis. So this is a flowchart for chronic instability. So if there is an arthritis, straight away go for either Sauerkopf or Dirax. If there is no arthritis, look for bony problem. If there is malunited distal radius, do a corrective osteotomy. If there is ulnar styloid fracture, non-union, fix it. Or if there is a soft tissue problem, then either you repair the TFCC, and if it's old enough, more than a year, then you might have to reconstruct the TFCC to make it stable. So my take home message would be, first attempt is always the best. If the patient is coming with an acute distal radius fracture, get the things right on day one. And also assess intraoperatively for a global instability, unless you have a global instability. What I mean by global instability? In pronation, supination and mid-prone. If you have instability, then you have to check for management of DRUJ. Plaster cast definitely helps in minimally unstable DRUJ for 4 to 6 weeks. You put an above plaster after a distal radius fixation, they do really well. And for the late presenters, you first evaluate them thoroughly for the causes and then treat accordingly. Thank you.
The next speaker, Dr. Gopinath, on DC and VC. Very puzzling topic, very difficult to understand.
Good afternoon, everyone. Very happy to be here in my alma mater, Warangal, KMC, and carpal instabilities. This is one such topic where people tend to move out of the hall and think that this is not my thing. So out of this talk, I wanted to make sure that the concept of carpal instabilities is very clearly and easily understandable to everybody. So I've made some animation so that we can understand the carpal instability concept very easily. So we'll go quickly into the presentation. Can we have the slide on? Yeah. So understanding carpal instability is one of the most difficult topics. So what we are trying to understand here is what is carpal stability, that we have to know. Then carpal instability, understand the wrist ligaments, why we do miss them often, and what are the types of these instabilities and how to manage them. So carpal instabilities, first I tried to see the definition for what is carpal stability, but I found that there is no defined structural definition what actually carpal stability means. It has not been defined anywhere, but people have defined carpal instability. Instability is a place where a wrist is unable to take support, physiologic loads, and it has altered kinematics, or usually both a combination. So if you see the wrist joint itself, the radius is in a 20-degree inclination and there is a tilt. This tilt makes the scaphoid and the carpals to slide. So that itself is making the entire structure unstable. And also if you see the distal radius, it has 11-degree tilt, that also makes it unstable. Moreover, the volar structures like FCR, they keep pulling the carpus down and they themselves make them unstable. So all the carpus, they are not in a very stable condition. The joint itself is very unstable inherently. So what are the factors which add to the stability of the joint? The ligaments which are there, they are obliquely formed. These oblique ligaments give inherent stability. The intrinsic perilunate ligaments give instability. The transiting transcarpal flexor tendons, extensor tendons give stability, and the negative intra-articular pressure. whenever we see this picture, everybody tends to forget that this is not my cup of tea. So many ligaments around. I hardly remember any of those names. But the most important thing what we have to remember is the proximal ligament, which is the scapholunate, and the lunotriquetral ligaments. These are the things which are very much interested in. And again, some volar extrinsic ligaments, which are the radioscaphoid, radioscaphocapitate, and the radiolunate. These ligaments, they are placed in a very oblique fashion, and this oblique pull of the ligaments, it stabilizes the carpus onto the radius. So this is preventing the subluxation of the carpus. And also there are multiple intracarpal ligaments which are also providing stability. And the flexor and extensor tendons, they exert pressure onto the compartment so that all the carpals are stabilized, and a negative intra-articular pressure is finally giving and making a wrist so much dynamic, moving and stable at the same time in all the flexion extension. Now let us come to the most important thing, the proximal carpal row, the scaphoid, lunate, and the triquetrum we are seeing in a sagittal and coronal views. The scaphoid naturally has a flexion force because of the attachments of the FCR, and also it is loaded by the triquetrum and metacarpal, so it inherently tries to flex. And the triquetrum has an extension force. So between these two ligaments, the lunate is very stable, and the normal scapholunate angle comes to 30 to 60 degrees. This is the stable configuration. And if you compare with the Gen Z concept of benching, so I don't know if anybody here knows the concept of benching. The female here has two people. Whenever she breaks up with one guy, she can go to immediately to the other guy. So this is a concept of benching. So this concept came with Gen Z, but it was there since before in our body itself. So when scapholunate ligament breaks or the scaphoid fractures, the lunate tries to go with the more powerful bone. So this is going into extension. So here what happens, the scapholunate angle increases and it becomes more than 60 degrees. This is called as DC deformity. And here, when the lunotriquetral ligament breaks or the triquetrum is fractured, the lunate goes into flexion along with the scaphoid. So here the girl is going with the strongest guy, the scaphoid, and the lunate, the triquetrum is behind. So here the scapholunate angle decreases less than 30 degrees. This is called VC deformity. So this is how they work. And why are these injuries missed very frequently? Lack of proper radiological knowledge, improper views sometimes, inadequate views sometimes. Because of all of these, we keep missing these injuries. A lot of the times, x-rays are taken like this patient is sitting, arm is close to the body. This is a wrong view. This is how we should not take a wrist x-ray. Wrist x-ray should be with a shoulder 90-degree abduction, elbow 90-degree flexion, and a PA view and a lateral view has to be taken in this position. Then only the proper alignment and proper visualization of the carpals can be seen on the x-ray. So reading of the wrist x-ray, so many things are jumbled up in a single closed area. It looks like almost you are decoding so many things. There is a bull, there is a woman, there is a horse. Everything we have to decode in a small single area. So in a wrist x-ray also, carpals, they are jumbled up, they are overlapping. So we have to decode everything only by taking proper PA views. So Gilula's arcs have to be identified, the proximal carpal row, the proximal most margin, the middle margin and the distal margin, all of the three form the Gilula's arcs. Sometimes in perilunate injuries or carpal injuries, the Gilula's arcs can be broken. So whenever you see the x-rays not showing a intact arc, that means there is something wrong. Sometimes you see a Terry Thomas sign, a broken arc again like this. This is Terry Thomas sign. And again, this is the normal scapholunate angle. But when there is alternate alignment, the lunate is looking back. This is called DC. And here the lunate is looking forward. This is called VC deformity. These are the different alignments. How do we classify these injuries? We classify them by, as per Mayo classification, carpal instability dissociative, non-dissociative, combined, and adaptive. Coming to dissociative type of classification, where is the dissociation happening? It is happening within the intercalated segment. What is intercalated segment? We have listened to VC, we have listened to DC, but what is this intercalated segment? What does that mean? It is a portion of carpus that does not have any direct tendon attachment. It is positioned between two mechanical important structures, the distal row and the radius. It depends directly on, largely on ligamentous connections for stability. Whenever any ligament is broken within the segment, then it causes dissociation. So again, as we said, VC and DC can happen, and they are examples for carpal instability dissociative. Coming to non-dissociative carpal instability, when there is non-dissociation, where is the instability happening? Okay, non-dissociative carpal instability is the one where the carpal bones are normal and intercarpal relationship is disturbed. So there is a disturbance between here radiocarpal disturbance, and again another place there is a disturbance in the midcarpal. So here other structures are disturbed, not the intercarpal, and it is usually the midcarpal or the radiocarpal stability. You can see here the lunate is fine, but the midcarpal joint is dislocated in the first MRI image, and in the second MRI image the entire carpus is out, radiocarpal. And combined these, both of them are injured. So usually it is a perilunate dislocation. Goes according to the Mayfield progression. First stage there is a scapholunate injury where the scapholunate angle increases, there is a DC deformity. Second stage it progresses to lunocapitate disruption. Third stage it progresses to midcarpal dislocation, and finally the lunate is kicked out of the fossa, causing a lunate dislocation. Here the entire carpus is disrupted. It can be a greater arc injury where a bony injury can be present, or a lesser arc injury. This is the lesser arc injury. And adaptive is one when the problem is outside the carpals have to adapt to an external problem. Here there is no problem in the carpus, there is a fracture in the distal radius, but this fracture in the distal radius is making the carpals to adapt to that in deformity. It can be seen in distal radius fractures or mid-lung deformity. So these are the carpal instability patterns. So never ignore a radial sided wrist pain or a central wrist pain, even if the x-rays are normal. Make sure that the x-rays are done properly. Proper understanding of the x-ray, the knowledge of the kinematics which is happening has to be there. Read the x-rays correctly and understand the carpal relations well. Whenever you are seeing a normal wrist x-ray also, try to see for all the carpals alignment so that it becomes a habit and that we will not miss any injury whenever we are seeing a wrist x-ray. Thank you.
Thank you, Dr. Gopinath. Thank you for a wonderful topic. Next topic is TFCC injuries, open and arthroscopic management by Dr. R. Sunil.
Thank you, Chairpersons.
Welcome.
It's good to be back at Warangal, KMC and MGM. So my talk for the day is TFCC injuries, arthroscopic and open repair. We have heard from the first speaker regarding the overview of DRUJ instability in terms of distal radius fracture. So I'll be dealing about isolated injuries. So we know that this rotation of the forearm happens at 3 points. One is a proximal radial ulnar joint, the middle and the distal radial ulnar joint. And distal radial ulnar joint is the commonly injured pathology which affects this pronosupination. Because the bony anatomy is very restricted in terms of providing stability, it depends a lot on the ligaments. What we mean by ligaments is the TFCC or the triangular fibrocartilaginous complex, and the primary component of this is the radioulnar ligament, which is a primary stabilizer of the DRUJ. So if we see the different components of DRUJ, it has a palmar part, a dorsal part, a deep part and a superficial part. And what exactly we mean by this is, concept is an iceberg concept where what you see from the articular side or the radius is only the not the stabilizer but the shock absorber part, but the deeper part, which is the hidden part, is the primary stabilizer, which is hidden under undersurface. So this is exactly what happens when you have a TFCC injury. Restraint on the bottom is lost and it starts floating up, and with that, that's where you get the instability. The other components are the articular disc and ECU sheath, ligaments, and secondary stabilizers like your ECU tendon, pronator quadratus, introitial. These are all the secondary stabilizers. So the primary one was the first one, which is the dorsal radioulnar and the volar radioulnar ligaments. So in terms of management of these TFCC injuries, they can be in different scenarios. It can be an isolated TFCC injury or associated with a distal radius fracture, associated with the ulnar styloid fracture in terms of Galeazzi fracture, or sometimes in late presentation in presenting of arthritis. So I'll be discussing only with an isolated TFCC injuries. This has been classified by Werner and Palmer into class 1, which is a traumatic one. Class 2 is a degenerative one. Again, we will focus only on the type 1. In this one, whatever the injury presentation, the patient complaints are usually ulnar side wrist pain with or without clicks. They will have pain reciprocated on loading on the wrist, like trying to get up or during activities. Tenderness on the soft spot between your FCU and the ECU. And when you try to grind it, you get pain. That's called the ulnocarpal stress test. And you can assess your stability by ballotment and the piano key sign. These are the typical findings what we see in a chronic instability, but in acute scenario, not usually definable. So what is the determining factor when the patient presents with a ulnar side wrist pain? So is it a stable DRG or unstable? If it is a stable one, there is a role of conservative and all ulnar side wrist pains don't end up on the table. You can try splinting and activity modification for maybe a couple of weeks or months and then wait for it. But if it's a gross instability after the initial pain subsides, then you evaluate further with an MRI and go for arthroscopic or open repair. So a type 1A tear is what is a central tear, and I'll just show how it would look like. So on a scopy, this is a central perforation, and you usually end up just debriding the central perforation, and if it is a neutral variance, that would be sufficient. If it is a positive variance, you end up doing a wafer resection or an ulnar shortening to balance that radioulnar joint. A type B, 1B is one which is a foveal tear. That's where the instability comes into picture. And you have two classical signs, the trampoline and the hook test. So the video shows what exactly is happening here. The hook test is actually lifting of the entire TFCC up. The tautness of the disc is lost. That's called the trampoline sign. And another interesting is suction sign. When you apply suction, the whole thing starts lifting up. That's called the ghost sign, which suggests a undersurface foveal tear. How do you repair these tears? You can go by an outside in technique, an inside out technique, or a foveal fixation for the foveal tear, or an open repair. So a short fast forwarded video of how this is done. This is a presentation of a young male, history of 3 students you can see. This is quite fast, so I think you can catch up with the video. So this is where the surgery starts with skin markings. The portal placement is dependent on the skin markings because the extensor tendons and the cutaneous nerves are always in place. Listers and ulnar striae are always palpable. That's where you start with, and your tendons are placed, and usually the working portals are the 3, 4 and the 6R. It can be done dry scopy or you can inject a saline, but once you put your scope in, it's all turbid, you can't see anything, and you start shaving off, doing suction, then you actually see where the tear is there. Usually this is hidden under a overlying synovium in proliferation. As you start debriding of this synovial proliferation, then you see actually where the tear is. So this is where you're actually starting to see in the peripheral, that's a dorso-peripheral part, and this is an illustration of where you're locating this. And then you start debriding the tear more and more till you see some healthy tissue, especially in case of chronic scenarios. So that's a typical detachment of the capsule. And you start going up into your repair. That's what we do in this particular pattern is a outside in repair, where needles are passed from the capsule, from the skin capsule going into the torn part and retrieved back. So it's just like your meniscus, how you do your outside in. That's the needle and the PDS suture. That blue one is a PDS. We can use our fiber wire as well. 2 or 3 limbs of these PDS, depending on the extent of the tear, are taken, are looped out, and all of these are retrieved onto the skin. So that's the first limb taken in, the second limb coming in, and it's being taken out. And this is how the sutures lie outside the skin. You make a small incision so that the tendons are not impaled. UEDM is the one which usually gets entrapped, and you tie your knots on the capsule. That's how a peripheral tear looks like after being done. Now the rent is closed, and you can see now that trampoline sign, that sponginess in the TFCC is restored back. So that's how is a peripheral tear repair. It's coming to the transosseous foveal. This you can see the extensive foveal injury over there. It was an acute injury, probably a day 5 presentation of boxer, and you can see the whole TFCC being lifted up. So the hook actually grasps and lifts it into the radiocarpal joint. And you make your needles through the bone. These are transosseous tunnels. Take the sutures and tie it and tuck it back to the bone. You can use a targeting jig sometimes to identify the exact footprint. So K-wire goes, your needle goes into the tract of the K-wire, and you get loops of sutures, and they're shuttled back to restore the foveal footprint. You can use a fiber wire or a fiber tape. These are retrieved back through the 6R portal, and the suture tape is taken in. This captures both the dorsal and the volar parts of your foveal footprint, and it's just tucking it down, and then you proceed with the remaining part of the tear. So that's about arthroscopic repair. And I think next would be an open surgical TFCC repair. This is a chronic instability in a young adolescent patient. You can see MRI showing significant dorsal translation. So how do we go ahead? The typical ballotment is seen in such chronic injuries because it's quite painless. Incision is again slightly between a FCU and ECU. Start with the ulnar styloid marking. ECU tendon is marked. Then you go slightly ulnar to the ECU tendon. A longitudinal incision is given. Spread apart with your tweezers, and then you start seeing the ulnar sensory branch, the dorsal sensory branch of ulnar nerve. You just have to protect it, and it's always there, so always look for it. This is what we are trying to protect here, the dorsal sensory branch of ulnar nerve winding around the distal ulna. And then you put your retractors, you are on the capsule, just put a rent in the capsule and you are on the disc or the TFCC. And you can see here that this forceps is actually holding the TFCC and it's detached from the fovea. You use different kind of curates and all instruments to freshen the bony footprint. And you can either use your transosseous tunnels and pull it back onto its with a subcutaneous knot, or you can put an anchor. This is a demonstration of an anchor being deployed there. So your pilot hole goes, then your anchor is deployed, and the bites are taken through the volar and dorsal components of your TFCC. And they just put the sliding knot, they are just pulled and made to sit inside. So this is an arthroscopic and open, and again, if it is an acute isolated injury, we prefer an arthroscopy because the space is limited for you to handle with your instrument. So open is usually reserved in scenarios where you have ulnar styloid fracture or in a distal radius fractures. The other tear patterns are type 1C, which is a detachment from the radius, which is usually again a debridement and repair, and type D is from the sigmoid notch. So again would be if it is unstable fracture, we proceed with the repair. If it's stable, it's a arthroscopic debridement. Thank you.
I invite Dr. Dheeraj to give a talk on scaphoid fractures management algorithm.
Good afternoon, all. I'm Dr. Dheeraj, consultant hand surgeon from Jamaton Hospital, Hyderabad. So why scaphoid fractures are peculiar? Because these are the most commonly fractured carpal bones, and sadly these are the most frequently missed fractures because of the difficulty in diagnosing them. And because of the limited blood supply and delay in diagnosis and inadequate treatment, there are high chances of avian, non-union, and arthritis, which is called scaphoid non-union advanced collapse, SNAC wrist. So in this picture you can see there is no visible fracture line on the X-ray, but on CT you can see a fracture line in the proximal pole. So scaphoid is a boat-shaped bone. Most common mode of injury is fall on outstretched hand, causing wrist to hyperextend and radial deviate. Most of the fractures occur in the waist. Distal third accounts to 25%, and proximal third fractures are around 5 to 10%. Scaphoid is an important mechanical link bridging both proximal and distal carpal rows, and it is important to maintain motion and stability in the mid-carpal joint. And 80% of the surface of scaphoid is covered by articular cartilage. to articulate with distal radius, lunate, capitate, trapezium and trapezoid. Because it is covered by 80%, 80% as it is covered by articular cartilage, there is less space for the blood supply to enter the bone and supply it. So coming to the blood supply, it is supplied by branches of the radial artery. Most of it is supplied by the dorsal carpal branch, accounting to 70 to 80%, and it is the only blood supply to the proximal pole, and superficial palmar branch supplies around 20 to 30%. So when a patient comes with a radial sided wrist pain after a fall, we start with clinical examination. So we look for scaphoid tubercle tenderness. Scaphoid tubercle is palpated by initially palpating the ulnar most bony prominence, which is the pisiform, and starting from pisiform we move slightly radially, and the first bony prominence which you feel is the scaphoid tubercle, which is confirmed by ulnar deviation and radial deviation. Ulnar deviation will decrease the prominence, and radial deviation will increase the prominence of the scaphoid tubercle. And anatomical snuff box, which is between the first and second compartment, between abductor pollicis longus and extensor pollicis brevis, and the proximal pole, which is on the dorsal aspect, just distal to the listus tubercle. And the other test is pain on axial compression of the thumb, and pinch of thumb and index finger. So a combination of the tests will increase the sensitivity of identifying the scaphoid fracture clinically, suspecting a fracture clinically. And it is followed by X-rays, which are usually taken in 4 views: PA with ulnar deviation, lateral view, and pronation oblique 45 degrees, and semi-supinator oblique 45 degrees. So what if the X-rays are inconclusive? So the classical teaching is put a cast for 2 weeks, because in 2 weeks the bone resorbs and the fracture line is likely to be visible. And so we repeat the X-ray after 2 weeks. If the fracture line is visible now, we do a CT scan. We should ask the radiologist to give 1 mm cuts, and CT scan should be done along the longitudinal axis of the scaphoid. So this helps to not miss the fracture in CT. So in CT, if there is a fracture, if there is displacement, we prefer surgery. And if the fracture is undisplaced or minimally displaced, there is a controversy. It can be casted or it can be operated, which I will be dealing in the next slides. So if the fracture line is not visible on X-rays, but the patient symptoms are subsided, so we treat it as a soft tissue injury. But if the symptoms are persisting, we proceed with the CT scan. If the patient is not willing to wait for 2 weeks, we go for MRI. In the acute setting, MRI will give bone marrow edema, which starts in very few hours after the injury. And we can detect ligament injuries also, scapholunate ligament injuries, other ligament injuries also can be diagnosed with MRI. And CT is useful to characterize the fracture, to find the displacement and comminution, and to assess the non-union in the chronic setting. So optimal treatment depends on timing, because Langhoff et al. Told that delay by 4 weeks of identifying the fracture has a high chance of 40% non-union risk. And we have to see the fracture type, because fracture displacement is the one important thing which we have to see. It is defined as fracture gap greater than 1 millimeter, and scapholunate angle greater than 60 degrees, and lunocapitate angle greater than 15 degrees. So if all these are there, it is defined as a displaced fracture. So coming to the controversy, if the fracture is undisplaced and minimally displaced, what should we do? Whether should we cast it or we should operate? So when the cast, with cast given within 3 weeks of injury, the union rates are close to 88 to 95%, and the type of cast to be kept, whether it should be a below elbow or above elbow, whether thumb should be involved or not. So Tosa et al. Told that there is no difference between below elbow and above elbow, and whether thumb is included or not, there is no much significant functional difference. And it should be kept for around 8 to 12 weeks. What's the problem with cast is it delays the patient has to wait for so long to get back to his work, and it can cause stiffness. So this is a landmark randomized control trial by DAY et al. So this was published in January 2026, which is a recent one. So it concludes that the clinical effectiveness of both are same, cast and surgery. At 5 years, the outcome is almost the same. And so for minimally displaced fractures, the initial treatment should be a cast. If the fracture doesn't unite after 8 weeks or 12 weeks, then we should plan for a fixation. And this article by Bond et al. Compares the average time to union and time to return to work, which we see it is very less in surgery, and in casting it takes a lot of time to get back to his work. So finally, the choice whether to operate or whether to cast should be individualized after explaining the patient and after discussing the patient. Because some patient will have bilateral scaphoid fractures, we cannot give cast to both the sides, and some patients will not be compliant to wear scaphoid cast for 3 months. And some patients or white collar people like doctors and engineers, they want to get back to work as soon as possible. So we prefer surgery for them. And it can be done by using a volar approach or dorsal approach. Volar approach is used for fixation of waist and distal pole as it is easily accessible. And dorsal approach is for proximal pole fractures. And these are the steps of percutaneous volar approach. We should hyperextend the wrist to keep the trapezium out of the way and fixed with a screw. These are the steps of dorsal percutaneous approach. We should keep the wrist flexed, and the scaphoid appears as a ring. We should start the entry, and then it should go in direction of the thumb, base of the thumb, and then the wire should be brought out from the dorsum to the palmar aspect and then fixed with a screw. So comparing both volar and dorsal approaches, which one is better, volar approach or dorsal approach? This article concludes that both the approaches are equally good and the functional outcome is almost the same. In dorsal approach, we can keep a central axis screw. In volar approach, we can keep a screw which is longer. For undisplaced distal pole and tubercle fractures, cast is sufficient. And for proximal pole fractures, as they have insufficient blood supply, we prefer surgery. Open reduction is indicated when the percutaneous reduction is not able to fix the fracture, and when the displacement is more than 1 millimeter and scaphoid angle more than 60 degrees. And these are the steps of volar approach, extended FCR approach, and we incise the capsule as a Z. And dorsal approach, we take the incision just radial to the Lister's tubercle and incise the extensor retinaculum in line with EPL, incise the capsule and fix it. So the complications in scaphoid fractures are non-union, which is defined as absence of signs of healing after 12 weeks, and it is more common with the displaced fractures and proximal pole fractures in smokers and fractures which are not treated adequately, which is assessed by mostly CTs. And the non-unions which are not treated will end up in SNAC, scaphoid non-union advanced collapse, and the treatment for non-union of scaphoid is rigid fixation with a bone graft. This is a case of non-union scaphoid fixed by K-wires and distal it is bone graft. AVN is seen in untreated proximal pole fractures because of less blood supply. There is a controversy as to which type of bone graft to use, whether to use a vascularized bone graft or a non-vascularized bone graft. This controversy is because MRI is not good enough to identify whether it is vascular or not, and intra-op punctate bleeding is also not so much satisfactory. So these are the usual vascularized bone graft options. Yes, to conclude, a good clinical examination and a high index of suspicion and appropriate imaging will help not to miss a scaphoid fracture, and MRI helps in acute setting, and CT is used for assessing non-union and assessing in follow-ups. And for undisplaced fracture, choice should be given to the patient after discussing the pros and cons. And volar approach helps to keep a longer screw, and dorsal approach helps to keep a screw in the center. And for non-union and avian, no significant difference is there between vascularized and non-vascularized grafts. It's still a debate. Thank you so much.
Right, the next speaker, lunate and perilunate fracture dislocation, how to get them right, Dr. Avinash.
Good morning, everyone. I will be speaking on lunate and perilunate dislocations and how to get them right. The aim of my talk is to understand the anatomy of the wrist ligaments, to classify the perilunate fracture dislocations, to know what is the lesser arc injury and what is the greater arc injury and how these injuries progress as per the Mayfield progression, systematically interpret PA and lateral view X-rays and the importance of CT scan, highlight the technique of close reduction, surgical approaches and fixation, management of median nerve complications, and strategies for acute, delayed, and chronic cases. When we look at the anatomy of the wrist ligaments, we have extrinsic ligaments which connect the radius to the carpus and the intrinsic ligament which connects the carpus to one another. There is a potential weak space between the radioscaphocapitate ligament and long radial lunate ligament. When the wrist is hyperextended, the space gets increased and there is a potential space of weakness called the space of Poirier. So why these injuries are important and why these injuries matter? These perilunate injuries are rare and they are the result of high energy trauma. They usually occur when the wrist is hyperextended in ulnar deviation with intercarpal supination. There can be associated fractures of the carpal bones and median nerve can be compressed in many of these cases with lunate dislocation. The importance of these injuries are historically multicentric studies showed that the initial misdiagnosis is there in around 25% of the cases with routine imaging. How do you diagnose these injuries? The patient presents with a painful swollen wrist and there will be a dorsal prominence that could be a dislocated capitate with painful wrist ROM and finger ROM. It is very important to examine the median nerve sensations. It can be injured with a direct trauma or because of the compression in the carpal tunnel. So, what is a normal PA view X-ray of the wrist? If you look at the normal PA view X-ray, we have something called as Gilula's arcs, which are the carpal alignment. The first arc, which is the proximal one, indicates the proximal margin of the proximal row of the carpus, and the second line, which is on the blue, indicates the distal margin of the proximal row, and the arc 3, the third one, which is in red, indicates the proximal margin of the distal row of carpus. And in a proper AP view, if you see that the ulnar styloid is along the ECU groove. So what is the normal lateral X-ray of the wrist? If you see the lateral X-ray of the wrist, the radius, lunate and capitate are collinear. They are in a straight line. And what you have to see is the scaphopisocapitate line, the alignment of the scaphoid. The red one you see is the distal pole of the scaphoid and the blue one is the volar cortex of the capitate. The pisiform lies somewhere in the middle third of these two landmarks. And also you should see that the distal radius, the lunate and capitate are collinear in a straight line and the scaphoid which makes an angle of about 30 to 60 degrees with the lunate. And the capitate lying in between the distal pole of the scaphoid and the volar cortex of the capitate. So what is a perilunate dislocation? Perilunate dislocation is the dislocation of the capitate from the lunate, and the lunate dislocation is the dislocation of lunate from the radial fossa, and the capitate will be sitting in the radial fossa. So the lunate dislocation, you have the classical sign, the spilled teacup sign. So radiographic imaging in perilunate dislocation is the cornerstone for the diagnosis. You see there is disruption of the Gilula's arcs, the carpal height is reduced, the scaphoid goes into flexion with the rigging sign, and instead of being trapezoidal, the lunate appears triangular, which is the piece of pi sign, and the carpal alignment is lost. In the perilunate dislocation, there can be a lesser arc injury, which is mostly a ligamentous injury, or a greater arc injury, which can be associated with fractures. The fractures can be either at the styloid, or through the scaphoid, or through the capitate, or through the trapezium. To classify the carpal instabilities, perilunate dislocations come under carpal instability combined injuries, where there is injury with the radiocarpal ligaments and the midcarpal ligaments. Mayfield described the progression of the progressive perilunate injury in a sequential manner. The stage 1, we have a scapholunate dissociation. In the stage 2, they have lunocapitate dissociation, and the stage 3, you have tricotalunate dissociation, and stage 4, it's the lunate which is getting dislocated. So in what happens in a hyperextension ulnar deviation injury is the scaphoid tends to go into extension, but the lunate is not extending that much because of the strong volar ligaments which is attached to it. So the scapholunate ligament gets disrupted. Then the radioscaphocapitate ligament gets disrupted and the capitate comes out of the lunate fossa in the stage 2. In stage 3, what happens is that capitate comes out, because there is disruption of the midcarpal ligaments, and then the capitate pushes the lunate into the volar side. So this is the sequence what happens in the Mayfield's progression. So CT, the importance of CT is to identify the fractures which are not seen in the X-rays. In this X-ray, you can see that there is the radius fracture is not clearly seen, but in a CT, if you get CT, you can see a radiocarpal fracture dissociations. Sometimes there can be a fractured capitate which can be turned around, which is called the capitate syndrome, which cannot be clearly picked up in an X-ray, which can be picked in a CT in a better way. Progressive perilunate injuries, fracture dislocations are again classified into 5 types, but the most common ones are the first and second. The first one with the dorsal perilunate or palmar lunate dislocation, or a second one with the transcaphoid perilunate dislocation or transstyloid or scaphocapitate. This is where there is a greater arc injury. How these perilunate dislocations are reduced? So there is a method described, the close reduction method by Tavernier, where the surgeon should give traction along the line of the carpus and give pressure over the lunate with the thumb on the volar side and try to push the lunate dorsally and take the wrist into hyperextension and then get into the flexion. So the lunate gets reduced. Even after reducing, the carpals may not be aligned in a proper way. So it's always better to fix these carpals with percutaneous K-wires and put it in a slab for 6 weeks. What are the indications for surgical management? Surgical management is usually the keystone for planning perilunate dislocation management. The first one is acute perilunate dislocations. It can be an open or closed injury. Whether it is associated with a fracture, it needs an open reduction. Failed or irreducible closed reductions needs open reduction again. Even with closed reduction, if the carpals are not aligned properly, we have to align them and maintain the reduction, maintain the Gilula's arcs by putting K-wise. When there is radiocarpal instability, associated median nerve compression, we have to go olarly and also release the carpal tunnel. Chronic perilunate dislocations where the lunate is lying onar, or in these cases there will be extensive scarring on the volar side, so we have to go olarly and also release the carpal tunnel and release the median nerve. And also, without damaging the lunate, we have to get the lunate into the radial fossa. So acute injuries, the standard of care is a dorsal approach to start with. In acute injuries, we can reduce the carpus, align the carpus and fix the carpus with the dorsal approach. But volar approach is indicated when we want to decompress the carpal tunnel, when we want to repair the volar ligaments. And it's not only, if you have a healthy ligament, we can go and repair the ligaments also. So we will go with the cases. The first case you see here is the transstyloid perilunate dislocation. The fracture is going through styloid and the lunate is dislocated. Perilunate dislocation, the lunate is flexed in, the lunate is in the radial fossa and the capitate is lying dorsally. So these fractures are stabilized with diamond-shaped configuration fixation of the K-wires, and the ligaments on both the sets of the scaphoid, the scapholunate and lunate triquetral are repaired with suture anchors. And this is the result.
Line చూడు. Line చూడు.
Hello. In the meantime, an announcement. There is an EC meeting of Oasis is going on in the ground floor. Whoever is the EC member of Oasis can join the room, join the meeting, and Sai will guide you to the room. Members of, no, EC members of Oasis.
56. 556 only.
He's the one, his love for you is true. But does he know you call me when he sleeps? Or does he know the pictures that you keep? Or does he know the reasons that you cry? Or tell me, does he know where your heart lies? Where it truly lies?
This is the transcaphoid peroneal dislocation. We have reduced the carpus with diamond shaped configuration of the KOS and then repaired the ligaments connecting the scapholunate and lunotriquetral ligaments. And that's the X-ray at the end of 10 months with well-aligned carpus. And you can see the result at the end of 10 months. Play the video. The patient is getting near full flexion and extension with good radial and ulnar deviation and full extension, full flexion. Next video. The second case is a transtyloid transcaphoid lunate dislocation where the lunate has dislocated volarly with the scaphoid waist fracture and the fracture line is, the injury is passing through the radial styloid. Next one. So this is fixed, the scaphoid is fixed with scaphoid screw and lunotriquetral ligament is repaired with an anchor and carpus is stabilized with K-wires with good alignment of carpus. And this is the result at the end of 10 weeks. Can you play the videos? The patient is having decent amount of flexion at the end of 10 weeks with good grip strength. Next video. Next one. So the third case is a transcaphoid lunate dislocation where the fracture line is passing through the scaphoid and the lunate getting dislocated. The next one. So in the CT, we get a CT to confirm the diagnosis. And then we have again reduced it with scaphoid screw fixation and repaired the lunotriquetral ligament and reduced the carpus with good alignment of the carpus. Next one. So chronic injuries, we can try doing ORF, and if it is not salvageable, we can do other salvage procedures like lunate excision and proximal row carpectomy or a wrist fusion. So to conclude, these are rare injuries but not so uncommon. These are devastating carpal injuries. CT scan is must to know the associated carpal fractures and also guide our treatment plan. Early diagnosis and urgent reduction and stabilization within a week is the standard of care. Delayed present cases can be salvaged with salvage procedures, and the results are not suboptimal. So, okay, thank you.
Yeah, the next speaker, Dr. Sandeep Sriram on scapholunate ligament injuries. Please restrict to time because we are having shortage of time.
Good morning all. I'm Dr. Sandeep Sriram, hand surgeon from Kamnini Hospital. Thank you organizers for giving me this opportunity. I'm going to talk about a scapholunate ligament injury. Scope of the talk is it includes anatomy, mechanism of injury and treatment algorithm. Previous speakers, Dr. Gopinath and Dr. Avinash has given the brief idea about the other carpal instabilities. In this talk, I'm going to talk about scapholunate ligament injury. Scapholunate ligament as such is not a uniform band. It is a C-shaped structure with a dorsal being the strongest and membranous being the weakest. Dorsal component has it gives a mechanical strength of at least 70 to 80% of entire scapholunate ligament. So along with the other carpals, it maintains a synchronous movement in the wrist, like dorsal intercarpal ligament, radioscaphocapitate ligament, long radial ligament, radiolunate ligament, and etc. As Gopi previously said, scaphoid has a tendency to flex, and triquetrum has a tendency to extend, and lunate follows the flow. When there is a scapholunate ligament injury, the scaphoid flexes due to its tendency, and lunate extends along with the triquetrum, causing the disc deformity. And once there is a lunar triquetral ligament injury, triquetrum extends and scaphoid flexes. Lunate follows this scaphoid and causes a disc deformity. So, among the 8 carpal bones and 33 articulations, not a single scapholunate ligament does not alone contribute for the stability. Along with others, intercarpal and extra carpal ligaments, it causes a synchronized movement, and it acts like a cable in a cable bridge. So, once the cable fails in a cable bridge, entire wrist collapse. So, a common cause of mechanism of injury is fallen outstretched hand, like in sports injury or in RTA, with a wrist in axial load and forced to hyperextension along with the ulnar deviation. This causes the intercarpal supination of the proximal row, leading to shear forces failing the scapholunate ligament and causing the dissociation. Why a scapholunate ligament is commonly missed? Because it is because of its static radiograph appearance in the initial stages, it is most commonly missed and most common cause of the carpal instability. But even of the conservative treatment, the pain persists and mechanical symptoms limit the function with the loss of grip strength. This further leads to the slack wrist progression. So slack progression does not occur overnight. It is a slow, but this progression is predictable. In the initial stages, where in the pre-dynamic stage, where the X-ray appears normal, in this stage there might be occult scapholunate ligament tear and subtle joint line tenderness. In the second stage, it is a dynamic stage where the X-rays appear normal in the static forces, but instability occurs only under the stress. And third stage is static reducible, where the standard radiograph shows the scapholunate ligament widening on the X-rays. And fourth stage is decisive deformity, where lunate is fixed in dorsiflexion. And fifth is scapholunate advanced collapse, where entire arthritis, there is an establishment of radiocarpal arthritis. So how to diagnose? Clinical examination being the most important in diagnosing the scapholunate ligament injury. History taking, like mechanism of injury, duration, pain, location, and clicking with the activity, and any limitation with activity is seen. Also inspect and palpate the dorsum of the wrist, and where the tenderness is located in the scapholunate area. Watson shift test and ballotment test confirms the diagnosis or more specific for the scapholunate ligament injury. We also find out the grip strength and range of motion compared with the opposite limb. Here is a case scenario where a 32-year-old software engineer presents 3 weeks after fallen outstretched hand. His initial X-rays were reported as normal, but even after the conservative treatment, after 6 weeks, he still had the dorsal wrist pain with difficulty in performing the push-ups. Here the red flag signs are persistent dorsal wrist pain with a weak grip strength, mechanical clicking with the wrist ROM, and limited range of motion and tenderness over the scapholunate interval. Clinical suspension should always be on a scapholunate ligament injury once patient presents complaints of dorsal wrist pain. How to read the normal wrist radiographs with a scapholunate ligament injury? As Dr. Avinash said and Dr. Gopi said, read about the Gullela arcs and find out the scapholunate gap, which is more than with more than gap 3 mm is abnormal, and also find out about the scapholunate angle more than 60 degrees in DC deformity. Why stress views are important? Because in a normal static X-rays, scapholunate angle gap appears normal. But with a clenched fist view or pencil grip view, there will be dynamic forces acting on the scapholunate ligament causing the widening, or you can see the Terry Thomas sign. When X-rays are equal or X-rays doesn't give any information about scapholunate, MRI is helpful, but this is not gold standard. MRI answers about the ligament tear, is there any body edema, or is there any associated ligament injuries. But MRI does not reliably answer the ligament mechanism, mechanical competency, or whether the stability, unstable, dynamic or static, or whether the carpus can be reduced or not. CT arthrogram is also advised when MRI is equivocal, when there is a cortical details to be known or to know about the cartilage status. Arthroscopy, the gold standard in diagnosing the scapholunate ligament injury. In this, we can directly visualize the scapholunate ligament from 3-4 portal, assess the status of the ligament, whether it is reducible or not, cartilage status, grade the injury, and then treatment can be performed in the same sitting. Gisler's classification, this gives the arthroscopic grading of scapholunate ligament injury. In grade 1, there is simple attenuation of the scapholunate ligament, and in grade 2, there is a tear with the probe enters into the scapholunate ligament and grade 3 visible gap is seen on the arthroscope, and grade 4 the 2.7 mm scope passes. So Garcia Elias gives the stages on the classification which the treatment can be planned. In the pre-dynamic stage where injury is not detectable initially with imaging, in this the treatment plan is rest, immobilization and activity modification with a dynamic and static reducible where instability occurs on stress views, arthroscopic repair or reconstruction can be advised. In static irreducible ligament reconstruction and with slack wrist, salvage procedures can be applied. One has to know whether the ligament is injury or chronic. You need to question yourself that can it be reduced? Is the cartilage preserved? Is the ligament repairable? Can the biomechanics can be restored? The treatment should be planned accordingly. So treatment algorithm, whether the once the patient had the conservative management, even the pain persists, take proper history, give a clinical examination, Watson's test, Ballotman test, take stress views, MRI if needed, and confirm the diagnosis with the arthroscopy, stage the injury, then go for the procedure. Goals of the treatment is to restore the alignment, restore the stability, preserve the motion, protect the cartilage, and prevent the slack progression. Acute repair. In this early recognition, ideal patient is like acute injury with a repairable ligament and reducible carpus with a healthy cartilage. You can reduce the carpus, then repair the ligament with the suture anchors or any other modality. There are open repair techniques and other dorsal capsulodesis to augment the repair. Recent evidences show that augmenting the repair with the internal brace gives a strong mechanical support, which is 4 times more stronger than the simple repair itself, encourages the early mobilization and gives the better outcome. Once there is a reducible instability, you can go for the reconstruction procedures like modified Brunelli, Mayoras 3LT technique or FCR reconstruction. Salvage procedures, this purely depends upon the cartilage status of the carpus and radius. If there is a cartilage of the capitate is normal, then you can resort to PRC, proximal carpectomy. In this motion preserved is around 60 to 80% and grip strength up to 90%. If there is cartilage status is not of the capitate is normal, four corner fusion can be resorted with a motion preserved up to 40 to 60%. Once there is a full blown out arthritis in the wrist, there is no role of PRC or four corner fusion. Total wrist arthrodesis can be performed. So rehab determines the success. Initial 2 weeks protect the repair and 2 to 6 weeks control movements along with the strengthening after 6 weeks and resort to function in 3 to 6 months. Why do repairs fail? Because of late diagnosis, poor reduction, wrong indication, cartilage ignored and early loading. So before surgery, confirm the diagnosis, access the reducibility and review the cartilage. During the surgery, reduce first and then repair. Always preserve the dorsal tissue and verify the stability. And after surgery, protect the repair and progress rehabilitation gradually. Thank you.
Thank you, Dr. Sandeep. Now we are coming to the final topic of this wrist wizard. Now I request Dr. Abhijit Vahegaonkar to please come on to the dais and with his topic, column concepts and intra-articular distal end radius fractures.
Thank you very much, respected chairman sirs, dignitaries and office bearers of the Tosa and the OSS. Please accept my sincere gratitude to be here with you and talk on a very fascinating topic, distal radius fractures. And I'm sure this is something that fascinates all of us, right, since our residencies to our very retirement days. And I think distal radius fractures are so fascinating because of the paraphernalia of the different implants that we encounter at every conference. Beautiful designs, beautiful concepts, and it really kind of makes it a very challenging and a very fascinating. So I hope the PPT pulls up now. Yeah, done. Thank you. So, as we have gone through the evolution of treatment of distal radius fractures, we now are at an era wherein we have this beautiful concept called as the column concept, the classification of distal radius fractures seen in a new light and allowing us to treat these fractures more effectively. I do not have any conflict of interest. The scope of the talk is listed on this slide here. And I think we are still taught about this principle that Abraham Colles mentioned way back in the 1800s, and we are all taught to accept malunions of the distal radius because they still might have good outcomes. But we need to ask ourselves a question, does it still hold true in 2026, wherein we have more high energy injuries, we have more active individuals, longevity of patients has increased, and they're all independent. So do we really accept malunions? And we have all been through this journey, especially my senior colleagues and teachers here, right from just casting reductions to fixators and wires, and then volar locking plate came in, and then we have fragment specific fixation, and to the extreme right you see what's called as a sonoma nail. So the goals of treatment, whatever you do, whether you treat it in a cast, whether you put wires, fixators, plates, whatever it is that you do, the fundamental of treatment is to restore the normal anatomical relationships when and if possible, and to maintain that reduction till such time that the fracture unites, and by virtue of which you are restoring normal function while minimizing complications of these fractures. So I think the question that begs to be answered is to recognize any unstable fractures, and is there a method by which we can do it? Certainly. We have the AAOS guidelines that was described way back, but I think the LaFontaine criteria, which was published before the AAOS guidelines, is more pertinent in determining the unstable fracture patterns. There are 6 of them listed for you on this particular slide. So how do we then understand classification systems and apply them in a manner that is reliable and reproducible, minimizing inter and intra-observer variability? So there are several classifications. I, for one, am a very dumb person. I don't really understand classification systems and remember them. Of these, especially the AO classification is quite complex, and the column concept perhaps aims at minimizing inter and intra-observer variability when you look at it. So if you look at this particular set of X-rays in the PA view, the oblique view, and the lateral view, is there a classification system that will help us consistently identify the fracture fragments every time you look at it? Not only that, but in different incidences such as these. And can we corroborate those fragments even on a CT scan? And this is wherein this column concept comes in. So to begin with, this was a concept that was described by Rickley and Regazzoni. And the basis of this particular classification is the foundation of treatment of distal radius fractures, the so-called fragment-specific fixation. Very simplistically, the wrist and the distal radius can be classified into a lateral, an intermediate, and an ulnar column kind of a concept. And the lateral and the intermediate column rest upon the pedestal, which is the metaphyseal region of the distal radius. There is a little bit of nuance to the intermediate column in that there is a dorsal wall, a volar rim, a dorsal and a volar ulnar corner, or the fragments that are associated with this, free intra-articular fragments, or the diapenge fragments, and of course metaphyseal combination or metaphyseal defects. The ulnar column pertains to ulnar styloid fractures, metaphyseal fractures, head fractures, and so on and so forth. Now, there is a very consistent way in which these fault lines or the fracture lines will be seen, and this is dependent upon the attachments of the ligaments that were alluded to in the earlier talks. So these are the radioscaphocapitate, long and the short radiolunate ligaments, which will be the strong areas of the distal radius, and the fracture lines will run between the weak areas of where these ligaments are attached, both on the dorsal aspect as well as the volar aspect. This was very conclusively shown in this particular paper, which was published by Greg Bain. So please read that paper. Coming back then now with a backdrop of column concept to this slide again, and corroborating these fracture lines on a CT scan also in different incidences, that is to say a coronal view, a sagittal view, and an axial view. Can we then again identify the same fragments again and again? Yes, we can, and that is highlighted on this particular slide. So the concept is very simple. It is to achieve a stable fixation of all columns, and then you start with the simplest techniques and then you build around that particular fragment. We all have played with Legos and blocks, and I think we all like to do that as orthopedic surgeons. So here is a schematic diagram to help you understand how we go about this. The slide on your left, the image on your left, shows a volar ulnar corner fragment, which is also called as a tetrahedron fragment. And you don't need to use a big plate to fix that fragment. All you can do is use a small little plate to either buttress or fix that fragment. If you have, for example, a lateral column or an intermediate and a lateral column fragment, then you use an additional device or a plate or fixation system to address the radial column fragment. If you have a dorsal fragment, go dorsally and buttress it. So it's very simple. Case in point here, if you look at this X-ray, the ulnar column looks intact, there is no fracture. The intermediate and the radial column on the PA view look deceptively simple. If you look at the lateral view now, look at the dorsal combination with the dorsal subluxation of the carpus. So there is much more that meets the eye than on the PA view. How do we deal with this? Get a CT scan done. It'll add more flavor to your understanding of the fracture in showing you the intra-articular depressed fragment. Go ahead, fix the intermediate column on the volar aspect. Add a dorsal buttress as well as a radial column plate, and that completes the fixation with a wonderful restoration of the articular fragment, articular surface. Look at this X-ray. Looks deceptively simple until you pay attention to that little fragment in the DRUJ, and that is an ominous fracture, because if you look at the axial slide here, the fragment is so small that if you try to capture that fragment from the volar side, you will risk either being intra-articular or an inadequate purchase into that particular fragment. How do we deal with this? Volar plate and a dorsal buttress plate, and the job is done quite well. Another case in point, this was treated in this manner. I think all of us will agree that the surgeon did a good job. However, this patient did not have any problem with the radiocarpal movement. What he had was this. Why did this happen? We got a CT scan done, and look at this particular malunited sigmoid notch and the dorsal column fragment, which is leading to these problems. So don't take that lightly. Now, to achieve your fixation, there are three approaches that you should know of. The volar approach, I think all of you are aware of this. I won't belabor too much on this in the interest of time. What we do is we take that little dart across the distal radius to give you more access to the distal aspect of the distal radius. We have what's called as a volar ulnar approach, which is between the FCU and the palmaris longus, and this allows you to place the plate on the volar ulnar corner, and this plate is often used for that tetrahedron fragment that I was alluding to a little while ago. And you can achieve this kind of fixation with this fragment, with this approach. And of course, the dorsal approach, which is a little bit of, kind of an intimidating approach for a lot of us. Very simple. Take a dorsal midline approach. Identify the extensor pollicis longus, exteriorize the extensor pollicis longus, raise subperiosteal flaps of the second and the fourth extensor compartment subperiosteally, release the brachioradialis, and you have a fantastic approach to the distal radius on the dorsal aspect. And you can use the trap pretty much like we do proximal tibial fractures, and you can then use different plates to buttress and to fix these fractures effectively. There are certain tips and tricks that I would like to share with you. I think one of the most important tricks that I have learned is releasing the brachioradialis, that allows you to reduce the radial styloid fragment quite effectively and easily. And you see this incision that I'm taking, this is called as a transient fibrous zone. If you elevate a flap, ulnar based flap of this particular transient fibrous zone, you can place your volar rim plate quite distally and pass the watershed line, provided that you use the correct plate for it. So case in point here, I'll just take half a minute, so if you won't mind. So look at these two plates. The plate on the left hand side is meant to go across the watershed line. So the same fracture, elevate that flap. If you use this plate, you will not get adequate purchase into the distal fragment. So if you elevate that flap, you will be able to use this plate more effectively and get a better purchase. Quick note on ulnar styloid fragment fractures. So this this has been fixed very well. Once in supination, the ulnar styloid is toppling over. There is a very marked instability, and you fix it. Now, this ulnar styloid can be fixed either with, anchors, hook plates, K-wires, whatever you fancy, but do it. Certain caveats: avoid intra-articular hardware, avoid proud hardware because that's going to cause tendon attrition and ruptures, avoid malunions, and of course, have a proper surgical technique. So in summary, distal radius fractures will continue to challenge us all right from our residencies to the day we retire. We need to understand our failures and discuss them so that we'll be able to improve our successes. Be very careful in assessing the fractures in terms of anatomy and the optimal fixation, and understand that it is the surgeon and not the hardware that will make up for the outcome for your patients. A quick note, with a simple and a very humble request to please consider supporting my candidacy for the post of Secretary General of the Indian Orthopedic Association, and also an acknowledgement of my team, residents and fellows who continue to inspire us and teach us. Thank you very much for your attention.
Thank you. We had a very scintillating session on wrist wizard, and all the lectures are very lucid and captivating. I request all the speakers to come on to the dais for the question and answer session. We are having very shortage of time, and a quick session on question and answers. A couple of questions are entertained.
Any questions, please?
This is for Abhijit. Do you have any consideration of reducing closed methods of the lower end of the distal end of the radius by K-wire methods in old and osteoporotic fractures, like about 60, beyond 60 years of age?
Yes.
That is fragment specific fixation.
Yes, sir. So certainly, yes. I think extra-articular fractures can very well be treated with K-wires. The only thing that we always suggest and recommend is not to remove the K-wires at 6 weeks, which we are habituated to. Because the fracture will have looked fantastically united, but there is a very high incidence of late collapse in these osteoporotic bones. So I think it's a good idea to retain the wires if you have put in a good, tripod fixation of sort. So we usually use 3 wires or 4 wires, both from the dorsal as well as the radial side, to fix the fracture, retain them, put them subcutaneous so that they don't irritate the skin. Patients usually tolerate it very well. However, we always like, for intra-articular fractures, prefer plates rather than K-wires and fixators. Thank you so much, sir.
Dr. Manesh, you have mentioned about Dirac procedure.
Yes.
For one of your slides. Is it relevant today?
Definitely, sir.
In place of Suave Kapangis, in relation to?
No, because Dirac's procedure is usually preferred when there is a distal radioulnar joint arthritis and elderly patient, where you have a risk of screw back out or screw penetration when you're doing a Saukapanji procedure. As sir said, like in osteoporotic bones, sometimes you can have cut through. In those cases, Dirac's procedure with a tenodesis of either FCU or ECU will definitely help and give a faster results and rehabilitation for elderly people. For young people in DRUJ instability with arthritis, definitely my go will be Saukapanji procedure.
My question to
Abhijit sir. So you have said that to retain the KYs beyond 6 weeks in elderly patients. But I have noticed that in spite retaining the KYs at 6 weeks, when we take a check X-ray, we do see a collapse. So what is your advice in regard to that?
So very good questions. So yes, despite our best attempts, sometimes there may be some collapse that you see. Now, disabilities malunions, you have to look at them in three important perspectives. One is the length loss, the inclination loss, and the tilt loss. Unfortunately, there is no good evidence out there which points out to which of these parameters is the most important. However, in the elderly, the loss of length seems to be more concerning because of its direct effect on your distal radial ulnar joint. So you see that with the collapse, the ulnar tends to be positive, and then it might cause two problems, either an ulnocarpal abutment or loss of pronation and supination, which can be quite debilitating. However, if the loss of the radius height is within acceptable limits, you can very well, kind of put them on rehabilitation, see the recovery of function. However, if for whatever reason the malunion is quite significant, you will have to resort to a corrective osteotomy.
If the radial length is reasonably okay and if it collapses, do you still want to continue the KYs or do you want to remove it at the end of 6 weeks? Because
No, I would continue it for at least 8 weeks.
to prevent any more further collapse.
Well, wishful thinking. Very little that we can do to avoid it. I concede that it's really so difficult to, and I think it's case based. And a very recent example, mother of one of my own friend, colleague of mine, we did our best to kind of treat it non-operative, I mean with KYs, because she was quite elderly, almost 70, 80 years old. And she did have a collapse. She's lost some significant pronation, supination. She's up for a resection of the distal ulna next week, I guess. So there are every now and then outliers, but more often than not, they do reasonably okay.
Do you advise any teriparatide or any other?
No, no, sir.
Thank you.
Thank you.
Okay, the session is over.
Sir, Dr. Sunil sir.
Invitation.
Sir, one small question, sir. For distal radius, we are doing lot of volar locking plates. More abundantly, we are using, sir. The draft trial, they said there is no difference with the K-wires, plating, and conservative management. So how do you justify, sir? We are overkilling the distal radius fractures with volar locking plates, or what is the rationale, sir?
I think we just can't generalize it that one is better over the other. It's just a quantification of what you are seeing. If you suppose you have an initial collapse much more than acceptable, then a K-wire alone may not be able to sustain it. So if it is a acceptable collapse with minimal parameters disturbed, the K-wires work very well. In significant intra-articular involvement or dorsal collapse, significant shortening, K-wires alone may not be enough, where you may need to augment with a plate. But we, in general, cannot say that plates are superior to K-wires in distal radius. It's a case-to-case kind of a decision to be taken.
Yes, sir.
I think what the question that you ask is very pertinent. We all tend to think that when you talk and when you hear in conferences, you see all these slides with plates left, right, center. But a lot of times the scenario in which you practice also kind of dictates the way your practice evolves and develops. More often than not, when you have unstable fracture patterns, intra-articular depressed fragments, they are better treated with an operative procedure and using a fixation that will endure the healing period and prevent any complications to the best possible. So from that perspective, I think understanding instability fracture patterns, understanding implant usage is more important than, one size fits all kind of a philosophy. Thank you.
We are running a little late. I think we'll go to the next session. The same speakers are there mostly. So let us all felicitate the speakers now. At the end. Choice is for the speakers. Thank you. Thank you. Thank you. We want to felicitate the chairmen. In view of a little delay, there is a light change in the program. We are going ahead with Dr. Mettu Rangareddy sir's This is a Tosa CME protocol. We would honor to Dr. Mettu Rangareddy sir. Dr. Sudhir will conduct the proceedings. Five chairs.
చెప్పండి. వైట్ తీసేసే. Good afternoon all. As a ritual, if it is only Tosacon, we will have the Mettu Rangareddy sir CME, that's name after the great sir, Mettu Rangareddy sir. Hope you are all enjoying this Tosacon, Tosa Oasiscon 2026. Now may I call upon the dignitaries to the dais. President Tosa, Dr. K. Ramkumar Reddy Garu. Secretary General Dr. Jagan Mohan Reddy Garu, Organizing Chairman President-elect Dr. Alva Reddy sir, Organizing Chairman Tosa Oasiscon 2026 Dr. P. Vijaychandra Reddy Garu. Again, our own Organizing Secretary Dr. Ramkumar Reddy sir is already in the stage. Scientific Committee Chairman Tosa Oasiscon 2020 Dr. T. Maheshwar Garu. I call upon all the past and present office bearers and senior faculty onto the dais to honor our own sir Dr. Mettu Rangareddy Garu onto the dais. Past presidents, office bearers, senior faculty.
Kasha sir.
Where is Kasha? Srinivas Reddy sir. Srinivas Reddy sir, Randy. Dr. Timma Reddy sir, are you here? PL Srinivas sir.
So this is honors to the Mettu Rangareddy Garu. Please, all the senior faculty, please, you can come. Raghuram sir, Valia sir, sir Venkatramana sir, Rani, Radha, Srinivas, Bachu. You can come out, please, you can come.
Venkat Swami Bhaiya, Randy, please come. Our Treasurer, Dr. Sujan Siva. Dr. Shravan, Joint Secretary, Tosa Oasiscon. TV Rao sir. Uday Kumar sir, please come on to the dais. Now I request our President Tosa, Dr. Ramkumar Reddy Garu, to give his message. About Metro Reddy sir.
Good afternoon all. It is my privilege to introduce or say some few words about the Mettu Rangareddy Garu. Sri Dr. Mettu Rangareddy is a surgeon of on-par excellence and one of the outstanding ortho surgeons of his generation in India. He completed his high school examination at Bolaram High School, Hyderabad. His pre-university studies at Nizam College, Hyderabad and Ferguson College, Pune. He was the best outgoing student of his year in his medical training at Osmania Medical College, Hyderabad. He won the Drake Broken Medal in 1942, as well as a rare honor of being a triple gold medalist in anatomy, obstetrics and surgery in the medical schooling. He joined the Army Medical Service in 1942 and served during the Second World War. He left the Army in 1946 and was selected as a candidate for training at the UK as a part of post-war reconstruction program of Nizams of Hyderabad. He completed his MCH from Liverpool in 1950 and his FRCS finals in 1951. He was an outstanding trainee at the Royal National Orthopedic Hospital, serving as SHO and registrar. He returned to India in 1954, but retained a lifelong admiration for Britain and its ways. At a time when tuberculosis and tuberculosis of the spine was rampant due to poor economic conditions in India, he was the first in Hyderabad state to perform anterior spinal fusion. He conceived and planned the Nizam's Orthopedic Hospital, a 150-bedded hospital dedicated to cold orthopedic surgery, personally supervising all aspects of its construction. He was appointed as Chief Orthopedic Surgeon and Superintendent in 1965. He worked as orthopedic surgeon at Osmania General Hospital, was made Professor of Orthopedics in 1956. He was one of the 15 founder members of Association of Surgeons of India to start Indian Orthopedic Association on 30th December 1954. He was President Indian Orthopedic Association in 1976, gave his presidential oration on anterior spinal fusion for tuberculosis. He retired in 1976 from hospital but continued active orthopedic practice until 1986 when he unfortunately developed paraplegia following spinal surgery in Bangalore by visiting surgeon from Edinburgh. Even after such problem and despite his disability, he still performed surgeries sitting in a wheelchair. He continued to take active part in training programs of younger orthopedic surgeons and was the founder chairman of the Twin Cities Orthopedic Surgeon Association in Hyderabad. The Andhra Pradesh chapter of Indian Orthopedic Association instituted annual oration in his name and named the seminar hall in Osmania General Hospital after him. He was a senior fellow of the Bombay Orthopedic Association and emeritus fellow of the SICAT. So this is all laurels of the Mettu Rangareddy Garu. Thank you very much for patient hearing. Thank you very much.
Thank you, Ramkumar sir. I take the honors of giving the vote of thanks at this scientific session. Here, from the organizing team, we thank all the fraternity, senior faculties, delegates and young orthopedic surgeons who have come here. We hope you have all enjoyed the quality of this scientific session at this CME. We also thank the speakers who made the event more academic and highly appreciable in nature. We thank one and all, and from the organizing team, we will go into the next session. The next session would be the functioning hand, fix it right. So I request Nagendra Babu sir, Senior Orthopedic Surgeon, Varangal. I request Dr. Venkat Swami garu. I request Dr. Sirish Kumar to come and join us as speakers at this session, chairing this session. Sirish.
Hello. I welcome the presenters to this session, but at the same time, please maintain your specified time. It's already dislocated program now. It is very much delayed. So we'll have to set it right, whether by K-wire or by your plating, okay? So decide whether it is conservative or operative. Go fast, okay? May I now call upon Dr. Sahitya Bandi. Please take your this thing. Start presenting. Stick on to the time, please.
డూప్లికేట్లోనే ఉంది. ఓకేనా?
Good afternoon all. I am Dr. Sahitya, consultant hand surgeon at Apollo Hospitals, Jubilee Hills. Thank you Tosa and Oasis for giving me this opportunity. So today we are going to learn about thumb basal fractures. So the outline of the talk includes epidemiology, anatomy, classification. We'll deal in detail about the Bennett fracture, Rolando fracture, and then about the rehabilitation. Coming to epidemiology, among all the metacarpal fractures, thumb metacarpal fractures accounts for about 25%, and when it comes to base of the thumb fractures, it accounts for about 80%. So among all the fractures, Bennett fracture is being the commonest one, with its incidence being 1.4% in fractures of the hand. Coming to anatomy, the base of first metacarpal articulates with the trapezium. It is a saddle type of joint with a wide arc of motion, giving us wide motion in like flexion, extension, adduction, abduction, pronation and supination. So there are multiple ligaments supporting this joint. There are approximately about 16 ligaments supporting the joint. Among all the ligaments, the beak ligament plays an important role in in Bennett fracture, which we will be dealing in the next coming slides. Coming to classification, the Green and O'Brien classified the metacarpal base fractures as simple intra-articular fractures, which is the Bennett fracture, then the comminuted intra-articular as a Rolando fracture, and an epibasal fracture as is subclassified as type A transverse and the oblique one, and the last one is the epiphyseal fractures. Before going in detail about the fractures, let us learn how to take a proper radiography of the thumb. So, we need to take a true AP view, which is also called as a Robert view, which is by doing a hyperpronation of the forearm such that the dorsum of your thumb touches the cassette, and we take an AP view, and a true lateral view where there is 20 degrees of pronation, where we will get a true lateral view, which is also called as a Bett view. Coming to fractures, the Bennett fracture, it was first described by Edward H. Bennett in 1882. He published his description in a Pathology Society of Dublin. So, this was actually introduced a few decades before the introduction of radiographs. He initially called Bennett fracture as a stave of thumb. So, how did he found this? So, he saw many specimens in the museum where he identified that when he saw the base of the thumb, there was a palmar ulnar fragment which was stayed attached to the trapezium with a ligament, while the main shaft which was getting displaced, mimicking a joint dislocation. So, Bennett fracture, as we have learned, it is the most common fracture of the base of the metacarpal. It is most commonly seen in males in the mid-30s. So, it is an intra-articular fracture separating the this is the fragment. This is the volar ulnar fragment which will be stable with the palmar oblique ligament. That is a beak ligament, whereas the displaced fragment is the radial fragment which will be displaced proximally, dorsally, and it will be adducted. There will be dislocation of the first CMC joint also. It is most commonly seen when we blow the fist with a partially flexed fingers. So, Gedda has further classified Bennett into three types, whereas the first type is a simple large intra-articular fragment with dislocation with subluxation at the metacarpophalangeal joint. Type 2 is an impaction type of fracture without any subluxation. Type 3 is a small avulsion fracture with dislocation of the metacarpal. So, we have already learned what are the deforming forces seen in the Bennett fracture. There will be adduction of the radial fragment by the adductor pollicis muscle, proximal migration by the abductor pollicis longus, but the ulnar volar fragment stays intact. So, the reduction technique is simple. We will be learning in the next slide. Our main goal is to restore the stability and articular congruity. Coming to treatment options, there are different treatment options. When the fragment is very small and minimally displaced, we can go ahead with conservative management in the form of immobilization in the form of plaster cast. But they usually say this sort of fracture is very unstable. So, surgical treatment goes well with this sort of fractures. Coming to surgical treatment, we can go with closed reduction and percutaneous spinning, open reduction and percutaneous spinning, or interfragmentary screw when the fragment size is big. You can go with oblique traction and external fixator. The minimally invasive technique like arthroscopically, you can assisted reduction and internal fixation. So, there are different types of maneuvers in order to reduce the Bennett fracture. Among them, the most commonly followed is the closed reduction maneuver, where you give proper traction, palmar abduction, pronation, and direct pressure over the base of the distal aspect of the thumb. There is another maneuver called as screw home torque reduction technique, where you do passive opposition and pronation of the thumb in such a way that the thumb will be parallel to the index and third metacarpal. Index and middle finger, giving us proper reduction. So, there are different percutaneous spinning techniques. Usually we prefer close reduction and pinning technique when the fragment size is less than 20% with 2 to 3 millimeters of displacement. The various configurations of KY fixations are like the intermetacarpal fixations like Wagner's technique, Islane and Addy technique, whereas the Wigner is the carpo-metacarpal pinning. So all sort of patterns give you a good satisfactory stability. The intermetacarpal fixation usually avoids that passage of the articular surface of the CMC joint, so which is the preferred technique. It is not necessary to have the wire across the fracture site in case of a volar ulnar fragment. Our main aim is to achieve good joint reduction. Coming to open reduction is usually advisable where there is irreducible fracture, when the patient presents to you in a delayed fashion, and when there is intra-articular step of more than 2 millimeters. So what do we usually do is the incision made over the base of the thumb, which is called as a Wagner's incision between the abductor pulsus longus and brevis. Make sure you protect the dorsal sensory branch of radial nerve and approach the base of the thumb, and then you can reduce the fracture. Next comes the Rolando fracture. In 1910, Silvio Rolando, he reports the outcome and treatment of 12 thumb metacarpal fractures in a port worker. Initially, it was described as a 3-part fracture, but later the multiple fragmented metacarpal base fracture is also included as a Rolando fracture. So this is a picture showing the distal fragment, the dorsal fragment and the volar fragment. Coming to treatment options, there are close reduction and splinting and immobilization. Close reduction with KY fixation when the fragment is less than 1 mm displaced, which is not amenable for screw fixation, and when the fragment is more than 1 mm displaced, we will go with open reduction interfixation. Distraction and external fixators are also used in this case of in sort of Rolando fractures. So open reduction internal fixation using plate, T or L shaped plate can be applied, and open reduction with multiple K wires in order to stabilize multiple fragments are also used. There is a traction technique described initially by Thoren, and Gelbabam et al. Recommended there is by keeping an oblique traction using a 1.5 mm K wire, the fragments usually come and settle in their place. So after attaining reduction, a below elbow cast is applied for about 6 weeks by maintaining the traction with a rubber band. Additional stabilization can be given with the quadrilateral frames, triangular frames and uniplanar frames. Whenever there are certain complications like stiffness and osteoarthritis resulting in the CMC arthritis, then the main we can go ahead with trapeziometacarpal fusion. Coming to rehabilitation, we initially stabilize the thumb by below elbow thumb spica splint for about 4 weeks if it is stabilized with K wire. You can also initially treat with 2 weeks of slab and 2 weeks of splinting. Later start mobilization of the CMC joint after cast removal. After about 6 weeks, he will be able to do all sort of activities. After about 3 months, he will be able to do all sort of weight activities. Thank you.
Thank you, Sahitya. Next topic is neglected PIP fracture dislocation, how to make the joint mobile. Dr. Gopinath Bhandari, please go ahead.
Have the slide, please. So yet again, I'm here. Thank you so much, the chairpersons, for inviting me. So we'll be talking precisely on neglected PIP fracture dislocations. Lot of time, people who have cricket ball injuries to the fingers, they consider it as jammed fingers. Proper treatment is not taken on time, and it is usually neglected either by patient's negligence or sometimes it is undiagnosed. So in such scenarios, patient come to us with neglected fracture dislocation with stiff fingers, and that's what we see. So PIP fracture, PIP joint is a complex joint, and the stability is determined by the amount of the fragment. So if the fragment is about less than 30% of articular surface loss is there, A mild subluxation can be seen, a dorsal V sign can be seen. In such scenarios, even if we just do splinting in flexion, 20 to 30 degree of flexion with a splint, that is sufficient and patient will have a good movement. If there is 30 to 50% articular surface loss, in such scenarios the subluxation is even more, and these conditions you can do a volar plate arthroplasty. The volar plate can be advanced into the defect and two sutures can be drilled into the bone and fixed up with a button or a anchor. Anything can be done. This is volar plate arthroplasty. If the defect is more than 50% articular loss is there, in such scenarios there is a huge dislocation and an impaction at the articular surfaces, and in such conditions to reconstruct we need a graft, and this graft is most commonly taken from hamate. We take a hemi-hamate graft and fix it with a couple of screws and give stability. So we'll be discussing in detail about two procedures out of these, hemi-hamate arthroplasty and volar plate arthroplasty, which are the most commonly done procedures for neglected PIP fracture dislocation. In this scenario, we have a patient who has a more than 50% surface loss in the PIP fracture, and this is how we see under C-arm, and we give a trapezoidal incision under the regional block under a tourniquet and gently give skin incisions using a 15 number blade. Avoid bigger knives because these might cause danger to the distal neurovascular pedicles. Gently elevate the skin flaps. Thick subcutaneous flaps have to be elevated, otherwise skin issues can be present. Safeguard the distal neurovascular bundle. And once your skin flap is elevated, elevate your flexor sheath gently and isolate the flexor tendons. So once the flexor sheath is identified and the tendons are retracted, then we identify the volar plate and detach the volar plate from the distal margin. Here we are identifying the volar plate and we are detaching it from the distalmost margin. And after elevating, this is how we see the joint. The joint is identified. The accessory collateral ligaments are just given small nicks so that we'll be able to shotgun the joint. This is called shotgunning of the joint to expose the entire PIP joint. Now we do a thorough joint inspection and identify the fracture ends. The part of the one which is lost we mark with a marking pen, and we can use a different type of instruments. We can use a oscillating saw, which is a very small saw. We can use that, or also you can use nibblers or bone cutters and cut off that damaged part. Remove that gently with small osteotomes, and once the osteotome is done, measure the defect in all the 3 dimensions. And through a small dorsal incision, take the articular surface of the hamate, measure it, and then put it back into the defect and stabilize it with 2 small screws. 1.2 mm screws can be done. And check this defect after the screwing. Check this defect under the C-arm. See for the mobilization and see if it is stable under the fluoroscopy after your fixation. Start a flexion exercises as soon as your surgery is done, and this is how you get the follow-up movement at the end. Now coming to volar plate arthroplasty, this is again about less than 20 to 30% of articular surface loss in an old fracture. Patient has a stiff finger, he is unable to bend his finger, he cannot do the gripping movements. The skin incision and exposure is same. Here we are elevating the volar plate. Care has to be taken that the volar plate is nicely elevated off. Mobilize it well and then shotgun the joint, identify the joint and the defect well, and this is the volar plate again. Start making small drill holes through the base of the middle phalanx through the defect. This is the place where we make a footprint and the volar plate goes and sits into that footprint. And using a looped K-wire or any other device, we take a bite of the ethibond through the volar plate, and using this looped K-wire we pull out through the drill hole. So this bite of volar plate is now going and sitting into the defect. Similarly, we make another bite just adjacent to the defect, to the footprint. So at least 2 bites would give a good grip. So in such a way, we take the bite through the volar plate and then fix it. Then once both the threads come onto the dorsum, we fix it with a button, and the button is slowly advanced. We put a gentle small gauze piece for protection and then advance the button and tie it over. So this is how the volar plate is sitting into the defect and acts as a stabilizer. Accessory collateral ligament has to be repaired. This is how the movement comes after the repair. So to conclude, proper counseling about expectations and rehabilitation has to be given to the patient. Get proper anatomical reduction, maintain the reduction and keep the joint moving post-operatively. If you are not doing the mobilization earliest, there will be stiffness. Limit the extension by an extension block splinting while mobilizing. So allow him to flex completely, but limit the extension. Elevation and edema control is one of the most important things in any finger fractures. If you let the patient hang his hand down, the finger becomes swollen and stiff. So elevation has to be maintained. Long-term self or assisted therapy has to be done to gain good movements. These are a couple of cricket ball injuries who came to me on a single day in the OP. All of them had cricket ball injuries and PIP joint fracture dislocations operated by multiple modalities. Thank you.
Thank you, Dr. Bhandari. May I now call upon Dr. Sunil R. TFCC injuries, open and arthroscopic management. Please start.
That was from the previous session.
You are Dheeraj?
No, I'm Sunil, but the topic is different. Can project that. So
Sunil topic is complex intra-articular finger fractures, open reduction, internal fixation versus external fixation.
Thank you, chairpersons. Can we have the projection, please? Yeah. So I'll be talking about complex intra-articular fractures of the hand, and we see that some of them have been or to be told by our other colleagues. So I'll be focusing more on acute PIP fractures, phalangeal condyle and head fractures, and the metacarpal head fractures, which are more difficult to treat. So most of these complex intra-articular fractures have an issue with the cartilage integrity, high incidence of instability and risk of stiffness, and the common modalities, whatever you choose, you need to get an accurate anatomical joint reconstruction, a stable fixation and an early control movement. Out of these three, the early control movement is the one which will give you an optimal outcome in these fractures. So various modalities like closed reduction, percutaneous spinning, you have an option of ORIF, you have an option of external fixation, but a very limited option of conservative management in this separate subset of fractures of the hand. So starting with the PIP joint injuries, you have three particular fracture patterns. One is a dorsal fracture dislocation, the other is a volar fracture dislocation, other is a pylon. So pylon has both the components of a dorsal and the volar, and again you have to choose which one fits into for this particular fracture pattern. First one we will be discussing is about the dynamic skeletal traction. It's predominantly indicated for a pylon injury or sometimes for an unstable fracture fragments with comminution, or sometimes it can be used to augment your internal fixation as well. The purpose is that this fixators actually maintain the reduction, allowing the joint motion, and it also neutralizes the joint reaction forces. You have a reduction, a distraction and mobilization, all of them going all together. So if we see the evolution of these fixators, it started with the Aegis force couple, which is no longer used. Then you have your Suzuki traction, which most of us must have heard, which is a pins and rubber band kind of traction, and the other one is a push traction, where it's predominantly a wire based traction system. There are various configurations. Again, you can use wires, 2 wires, 3 wires, bands, without bands. So it's a matter of personal choice which kind of a frame you want to use for this kind of PIP joint injuries. So the far left is your Suzuki traction, the typical appearance of that. These are the wire tractions. Whatever the modality you choose, the main crux is that you have to identify the center of the proximal phalanx head and the center of the middle phalanx head. So a case example of how I apply this is a push traction device, where you identify the center of the proximal phalanx head, pass a wire, it has to be parallel to the joint. Then you identify the center of the middle phalanx head, pass a wire, both of these wires have to be perfectly parallel, and then you bend these wires such that they start meeting each other. Then you bend and hook them, and just make a frame such that you get a slight distraction. The distraction should not be too much to cause pain for the patient, and these bent wires are engaged and locked into place. So this is slightly different from the Suzuki traction, but this is how I do it. This frame is little bit concise and crisp and easy to maintain rather than the Suzuki thing. And that's how you lock the frame. And then you see how it looks like on a AP projection and AP view and a lateral projection and AP lateral view. And this is what you are allowed to do on the day one, and this is what the patient should be able to do. Complete digital movement is allowed. Another similar case of a dynamic traction, you can see the patient being able to maintain full movement with the frame on in the OPD, and this frame is usually kept for 3 to 4 weeks and then removed in the OPD. Now this is a case of a pylon fracture. The previous was a dorsal fracture. Pylon, what you see is you can maintain the distraction, but sometimes the fragments may not fall back into place. The central depressed fragment may stay away, in which case you can use wires to manipulate that and add some subchondral wires, or in some cases you may not be able to manage to do that closedly, in which you might need to open it and augment with wires. So ultimately you have to restore the joint and neutralize the reduction with a distraction. This is another case of a pylon fracture where you seem that the traction has maintained the reduction. You apply your frame, but you feel that it's still not okay. This is where you can use a mixture of your internal and external fixation. You can add a plate or screws and augment your forces along with the distraction element into this. And I assume all of these are mobilized on day one. And sometimes you find these kind of fractures where the traction alone doesn't again set into place and the fracture is eccentrically located. You can always rely on your internal fixation as a bailout option when your close reduction is not successful. This subtle looking fracture, another case example of a dorsal PIP dislocation, you have a central depression which looks acceptable. What happens inside is that the fragment is totally flipped off, the cartilage is lying upside down. So these are cases where if you don't get a reduction, you open it up and put a volar bridge plating and start mobilizing from day one. So this is how we customize and individualize the treatment for these PIP fractures. Now coming to the second set, which is a volar PIP fracture dislocation, which is usually a central slip avulsion without a dislocation. So what is the problem here? This arrow actually is a central slip pulling it, and these are the flexor tendons pulling it. So there is always a deforming force adding to the subluxation. So this is what the extensor apparatus and what we are trying to neutralize. So this is where you can't immediately mobilize the joint. You do an internal fixation and transfix the joint, allow the joint to settle down, allow the ligaments to heal, and then you start ahead with your mobilization. So that was the complex PIP joint injuries. The next would be focusing on the phalangeal condyles and the phalangeal head fractures. So if you see the various configuration could be a short oblique or a long oblique split fractures or a bicondylar fractures, which are traditionally seen, but it's not unusual to see these osteochondral fractures on the volar side and the dorsal side, which are a challenge to treat. Another we go to the case examples. Condyle fracture. Do we always need to open it? No. If you can get a close reduction and K wires do work very well, but the size of the wire is the one which matters. Here you get a close reduction. I have added 0.8 mm 3 wires which are as good as the screw, and you get away with a closed fixation and you start mobilizing it. But if even in long fractures you can still do this with K wires, but if your close reduction is not successful, like in this traction we are not able to reduce it, always you keep your screws back up and don't hesitate to put your screws or K wires after doing an open reduction. This is a particular pattern which will never settle down with your close reduction. This is a phalangeal head fracture with completely rotated arrow inside out. Your collateral ligament will be attached to it, and it has to be necessarily opened and fixed either with wires or with screws. The last one would be the bicondylar fractures, very unstable fracture configuration, where your wires alone may not be able to do, although you can try them, but always keep your other options, like you may need to add a rigid internal fixation device to maintain the reduction and start mobilizing these kind of fractures. Now that was all the internal or the K-wire fixation. Is there a role of external fixation in finger fractures? I would say the push traction or the Suzuki was an external fixator, but sometimes in the phalangeal fractures in this scenario, where you can't necessarily think of where do you start, where do you end. These are cases where you can ideally put your just fixator or any external fixator device which would actually help you by avoiding the joints and mobilizing the joint at the same time. So that is a specific scenario where you can still, there is a role of external fixation in a comminuted fractures. The third subset of fractures where you get this comminuted intra-articular are the metacarpal head fractures, again a challenge. We all know that metacarpal neck fractures, and I assume the next speaker would be talking on those metacarpal fractures. They are very straightforward to treat. You put your intramedullary K wires or screws, they work very well. But the head fractures are always challenging, because when you put your wire intramedullary, they come out through the fracture side, they exit into the joint. So how do you manage this? This still can be managed with your favorite implant, which is your K-wire. You maintain the length onto the large chunk and add some supplemental K-wires, and you still can maintain this. But the problem is you can't mobilize them early, so you just protect them for a couple of weeks and then start mobilizing them. The other subset of metacarpal head fractures are the shear fractures. Like what you see here is a dorsal shear fracture osteocondyl fragment which is blocking the extension of the MCP joint. This can't be managed conservatively. You open up, put a screw or a wire and just start mobilizing it. And the second set of fractures is a volar metacarpal head shear fractures, which is a very unstable fracture pattern because the joint subluxes with this. And you end up opening from the volar side. You do like your typical trigger release, separate the flexor tendons, identify the volar plate, you are on the metacarpal head and fix it with your headless screws. So in summary, complex intra-articular fractures, the 5 most important take-home messages, I would say 1, 2 and 3 would be an imaging. Never miss these fractures, go for CT if required, always fix it adequately and stabilize it and mobilize it. And 5th, don't go with a fixed pattern, always customize a treatment plan for each particular fracture pattern. Thank you.
Thank you, Dr. Sunil. May I now call upon Dr. Abhijit Vaikonkar. He will be speaking on phalangeal and metacarpal fractures, how to fix them right.
Thank you very much, Chairman, sirs, dear friends and colleagues. Again, members of the Tosa, the dignitaries and the officials. It's really my distinct privilege to be here amongst you. I bring greetings from Pune and again, my charge is to talk about phalangeal and metacarpal fractures. A lot has been discussed by my colleague, Dr. Sunil. I'm going to just take you through a little bit of the nuances as well as some philosophy of phalangeal metacarpal fractures. So I do not have any, I don't know. All right. So I don't have any conflict of interest regarding this presentation. Thank you so much. So I would like to begin with this aphorism by Alfred Swanson in 1970, wherein he made a very astute observation, and he said that hand fractures can be complicated by deformity from no treatment, stiffness from over treatment, and both deformity and stiffness from poor treatment. And I think this holds true for almost every fracture, but more so in the hand because of the functional importance of the prehensile function of the upper extremity. And I think a lot of times most of the phalangeal metacarpal fractures of the hand can be managed non-operatively, provided you adhere to a few basic principles. And I think immobilizing the hand in the functional position with the MP joints in about 70 degrees of flexion and the IP joints in full extension and the thumb in palmar opposition is the most important thing that you can do. Even if the hand were to go stiff, you would still have an opposable thumb and fingers that would render the hand functional despite the stiffness. And this position is dictated by the anatomy of the volar aspect of the fingers, wherein the volar plate that we just saw a little while ago is maintained in full length along with the check-rind ligaments and preventing stiffness. What we need to understand about the joints of the hand is that any amount of angulation of the phalanges due to an imbalance in the tendons around the finger will lead to some kind of a deformity. And this is very well illustrated in this slide here. So we already heard about the intra-articular fractures. Shaft fractures involve either the spiral, oblique or transverse patterns involving the base, the mid shaft and the neck. And of course you can have comminuted fractures, and we've already heard about the PIP fracture injuries. Again, this has been talked about by Sahitya a little while ago, wherein proper x-rays are the key to diagnosing these fractures, and getting proper x-rays of individual fingers both in PA and an orthogonal view are very important. Don't rely only on oblique views, please. And of course, the treatment principles are again universally fundamental and very simple. Reduce the fracture, retain that particular reduction until such time the fracture is united, and then you rehabilitate so that you are able to get a good function. I think this, again, this little advice is very important. 75% of phalangeal fractures have little or no displacement, and reduction may not be necessary. It is extremely important to know when to leave these fractures alone. Here is a treatment algorithm for fractures of the middle phalanx used as kind of a representative model, wherein it's a very straightforward kind of an algorithm, wherein if you have an unsatisfactory reduction, you would usually resort to an open reduction in internal fixation, and in a stable satisfactory reduction you would either immobilize or perform some kind of a closed reduction and percutaneous fixation. Now, we have all heard about and think we utilize buddy taping. It's extremely important to keep the PIP and the DIP free. Don't just wrap the fingers together in the name of buddy taping. Keep some absorbent gauze between the two fingers. Use non-elastic bandage. So don't use something like Dynaplast, use Micropore so that edema is minimized, and mobilize the fingers earlier on. Avoid this kind of splinting. Please do not immobilize your PIPs and DIPs and MP joints all in one particular splint like this, which is illustrated here. This hand will have a disastrous outcome and should be avoided. So most important to know is the minority where active management is required, and that will sieve out the good doctor from the average one. So there are certain treatment options that we all know about, we heard about it: percutaneous fixation with closed reduction, open reduction. You can use just simple K wires, cross K wires, or you can use tension band wiring. I won't belabor too much on this because this has already been talked about, and there are different ways in which you can achieve this function. Closed reduction internal fixation should not be taken lightly because it's a very difficult technique. If you're doing it alone, have someone to assist you to hold the reduction while you're passing the wire. Do not impinge the collateral ligaments or the extensor tendons. Do not injure the neurovascular bundle. Stay in the safe zone. So that just like Elizarro, where you have safe zones to pass your wires, for the fingers, you have safe zones to pass your K wires. And use small wires. Do not use these thick K wires on a high RPM drill. Use a low RPM drill with a 1 or 1.2 millimeter K wire. Retain it for about 3 to 4 weeks. Mobilize at the earliest possible, and try and achieve good function for these patients. Nicholas Barton made again a very nice observation. It is that the indication for surgery really has to be justified when you are not able to get good outcomes with closed reduction, internal fixation, or immobilization. That is when open reduction is required. So with that little brief about phalangeal fractures, we'll come to metacarpal fractures very quickly because excuse me, the outcomes, the techniques and the principles are pretty much same for both of these fractures. So again, the goal is to aim for union with an acceptable alignment with a good range of movement, and closed reduction again is the most common form of treatment, and then open reduction is required and indicated in certain scenarios such as open fractures, soft tissue injury, such as if someone has punched some hard surface or another person, and there is a complex infected open wound, for example, tendon injuries, malrotations, displaced fractures, bone loss, replantations, and multiple fractures. So the metacarpal is a short, long bone for all practical purposes. It has a head, a neck, a shaft, and a base, and then it articulates distally with the proximal phalanx and proximally with the carpals. And again, fracture patterns are pretty similar to long bones such as short oblique, long oblique, transverse, basal fractures, comminuted fractures, and so on and so forth. The anatomy is quite important because you have the intermetacarpal ligament and a lot of these introshi which can hold the fracture stable in a majority of the cases. It is only when there is shortening and bone loss that is when you need to restore the length of these particular fractures. And often these muscles also act as deforming forces, and you need to understand and realize that. And it is a transverse fracture which is the most important, most mechanically unstable fracture, wherein you need to be very meticulous and particular about the treatment protocol. A lot of times you use these, unligated splints or these boxes fractures. A lot of them can be treated non-operatively, and then open reduction internal fixation is indicated in those instances that we saw earlier on, and can be accomplished with these particular techniques that are listed on this particular slide. So there are again multiple implants that are available. A lot of the companies are coming up with these small fragment sets, very small fragment screws. So we also have 1.2 millimeter screws now for a lot of these head fractures and intraarticular fractures. Case in point, so this is a fracture of the fourth and the fifth metacarpal. It's transverse, oblique, and in one case and transverse in the other, unstable with displacement. Can be treated in this particular manner with good kind of reduction and stability, or can be treated with plating and internal fixation, as in this particular case. So both are valid and validated modalities of treatment for these fractures. And this here is a demonstration of how we reduce, and we use this plate that is pre-bent for compression for a transverse fracture, pretty much like a long short bone, and you're using these same principles for fixing. The principles of fracture treatment are universally the same, and then that is how your post-op x-ray would look like. You can mobilize early and so on and so forth. Here is a neck fracture, a typical boxes fracture. This patient declined non-operative treatment. One of the ways you can deal with these fractures is with an intramedullary screw, which is depicted on this particular slide. I think this was shown earlier on by Sunil. Osteochondral fragment. This was 5 months old by the time he presented to us. Reduced, fixed. That's the outcome. Basal fractures are unstable. This is the reverse Bennett's, again treated with close reduction internal fixation. So again, I would like to reiterate and leave with this aphorism for you to remember: no treatment, deformity; over treatment, stiffness; poor treatment, both deformity and stiffness. So in conclusions, hand fractures are one of the best ways known to sift out the good from the bad surgeon. So be aware of this and treat your patients accordingly. And the good surgeon is really not the one who knows 100 different surgical procedures, but the one who knows when not to attempt surgery. Thank you once again for your attention. I would like to acknowledge my team, our fellows and residents, and of course, again, a very humble and a very sincere request to please consider supporting my candidacy for the Indian Orthopedic Association. Thank you very much for your attention. Thank you.
Thank you, Dr. Abhijit.
Thank you, sir.
Next topic is why are CMC joint injuries missed and how to manage them. Speaker is Dr. Sandeep Sriram. Please welcome.
Good afternoon, all.
most of the times in any conferences we got to hear about first CMC joint, but second to fifth metacarpal, carpometacarpal dislocations are less spoken and less and most under-recognized fracture dislocations. In my talk, I am going to cover about the anatomy, how to diagnose them, and classification and management of second to fifth carpometacarpal joint dislocations. Here is a case scenario in a 29-year-old right-hand dominant presented with pain and swelling on the ulnar aspect of the dorsum of the wrist since 2 months. In the first consultation, it was reported as X-ray with no bony injury and initially managed only with the pain management. But with a proper lateral oblique view, we have found out that there is a dislocation of fourth and fifth metacarpal, carpometacarpal dislocation associated with hamate fracture also. This is most common scenario that we encounter with these dislocations. It is always lately presented or lately diagnosed, and before going to the management, we'll initially know about the anatomy. Second to fifth, we can divide them into radial pair and ulnar pair. Second and third carpometacarpal joints, these joints are most rigid and minimally mobile joints, and there are, it is fixed to the carpal arch. Dislocation is very rare. It indicates high energy in, trauma. Fourth and fifth, most commonly injured, and it contributes for the power grip. There is a flexion and extension of up to 10 to 30 degrees along the fourth and fifth carpometacarpal joint. Coming to the individual joint, second carpometacarpal joint, it has an articulation with trapezoid and trapezium and most rigidly fixed of all the CMC joints. And it is most rare type of dislocation that occurs usually in high energy trauma. Third is also fixed unit that articulates with the capitate, and it's also a rare type of dislocation. Fourth and fifth articulates with the hamate and most common of among four. Fifth is most commonly dislocated and is almost associated with hamate fractures. So mechanism of injury on a fallen outstretched hand with a clenched fist, crush injury on the dorsum of the hand, or high energy RTA. These are the common causes of carpometacarpal dislocations, and it is very rare, less than 1% of all the hand injuries. And mostly dorsal displacement is seen, volar is not uncommon, and usually this occurs in young males with high energy sports injury or punch injuries or motor vehicle injuries. Frequently, these injuries are most frequently associated with other fractures like hamate fractures or adjacent metacarpal fractures or metacarpal shaft fractures. If there is a hook of hamate fractures, usually under motor deficit is usually seen. And if there is an injury to the ECRB or ECRL, there is a subluxation of the CMC level is also seen. Why are these injuries are that commonly missed? Because it is overshadowed by other louder injuries like distal radius fractures or shaft fractures or carpal bone fractures, and in standard views like AP and lateral, usually these overlap the dislocations, and standard views are not obtained like true lateral view or 30-degree supination view, which helps in recognizing the dislocation, especially the fourth and fifth carpometacarpal dislocations. And also in clinical examination, that swelling on the dorsum of the hand masks the deformity or masks the dislocation, clinical palpation. For any second carpometacarpal dislocation, a clinical examination is must. You must inspect the knuckle counter. There is a loss of knuckle counter in dislocations. Also palpate for the CMC bases, check for the rotations, and also screen for the ulnar nerve if you suspect any hamate fractures. You should always obtain a true lateral view that will help in identifying the second to fifth metacarpal dislocations, if any, and 30-degree supination oblique view that helps in fourth and fifth carpometacarpal joint dislocations. And you should always find out the angle, is there any increase in the intermetacarpal angle. Normal is being 6 degrees, and more than 10 degrees suspect for the carpal metacarpal dislocation, or there is a rotational deformity. CT scan helps in diagnosing these dislocations, and also helps in identifying the associated carpal bone fractures. Kane's classification, this helps in identifying, classifying the hematometacarpal injury. In type 1A, there is only subluxation without any hamate avulsion fracture. And in type 1B, there is an dorsal subluxation with an avulsion fracture of the hamate. In type 2, it is an dislocation of fifth carpometacarpal joint with combination of the dorsal hamate rib. And type 3, here is the coronal split of the hamate. In type 3, usually it is associated with ulnar nerve injuries most commonly. First line, coming to the management, first line of treatment, if diagnosed early, it is always a closed reduction and K-wire fixation. Give a longitudinal traction on the affected ray combined with the direct dorsal to volar pressure over the displaced metacarpal base with a metacarpophalangeal and wrist in flex to relax the extensor and intrinsic pull. And always secure the fixation with a intermetacarpal wires or part the K wires into the carpus to stabilize the fixation. Immobilize the fracture for at least 4 to 6 weeks and allow the mobilization of fingers within the splint. And after the splint is removed, resort to the rehabilitation to regain the wrist range of motion. When close treatment is enough. Indications are for open reduction when there is delayed presentation or delayed recognition of the fractures, failed or unstable closed reduction, significant hamate combination like type 3 or type 2 or type 3, or when there is an interposed dorsal hamate fragment blocking the reduction, or when there is second to fifth transcarpal pattern type of dislocation. Open reduction is usually performed when there is hamate fixation along with the fourth and fifth carpometacarpal dislocation. You can use these screws or bridge plating to fix the fractures and dislocations. When there is a multiple joint like combined injuries like second or third or fourth and fifth, each and individual joint should be reduced, fixed, and the intermetacarpal K-wire should be applied in acute injuries to avoid the rotational instability. In open injuries, mostly the scar formation and fibrous tissue interposition that inhibits the close reduction. So always open the fracture site, remove the scars, remove the fibrous tissue, and fix it with the appropriate plating or K-wires to get the anatomical reduction. So while treating the second to fifth metacarpal joints, always get a true lateral view and 30 degrees oblique view. The AP alone does not give the proper views to or proper identification of the dislocations. An isolated ring fractures should give a prompt that it is not that should be associated with other injuries like fourth, fifth, or any metacarpal shaft fractures. Use the intermetacarpal angle in a lateral view that is more than 10 degrees is abnormal. Reduce and pin every joint involved, and do not assume that one reduction fixes all. CT, one should have an least every time there should be, if there is a suspicion of carpometacarpal dislocation, one should have a low threshold to get the CT. This will help in early diagnosis and treatment planning. Thank you.
Thank you, Dr. Sandeep Sriram sir, for the topic on the CMC joint injuries, which are missed especially of the second, third, fourth, and fifth CMC joints. Now I may call upon Dr. Manish Jain to talk on mallet and jersey fingers, little injury, big effect.
Good afternoon, everyone. I think this is the last talk on the hand injuries, and I think this is one of the important topics which definitely needs discussion. This is not one topic, this is two topics, mallet injuries and jersey fingers. So I'll run through quickly and important points. So we know mallet injury is the extensor tendon avulsion from the distal phalanx. As you can see, the mechanism is force flexion against the axial load, and usually patient present with a history of cricket ball injury. Two classifications are important, Warby and Schneider's classification, which tells us about three types where depending on the DIP joint subluxation is there or not, and these three types are again subdivided depending on the size of the fragment. But Schneider's classification does not describe anything about closed injuries, which is described by Doyle's classification. In Doyle's classification, you also have a growth plate fractures in pediatric, which is called as Seymour's fracture, as you can see here, in which the germinal matrix of the nail bed is incarcerated into the fragment of the fracture. Usually a good AP view and a true lateral view is required. Ultrasound is required when you don't have a bony mallet, just to see whether the extensor tendon is in continuity or not. No need of any CT or MRI scans. And if you come to the management, splinting, you can have a custom made stack splints are better, and whenever you are putting splints, at least 6 weeks of splinting has to be done, followed by 2 weeks of night splinting. But you have complications such as ulcerations, maceration and non-compliance. Sometimes you can also put cast, as you can see in this picture. Patient has a mallet injury of the thumb, which was pretty in place, so we just managed with the plaster cast and it went on to unite well. Then what are the indications for surgery? As you can see in this picture, there is a subluxation of distal interphalangeal joint, or if the bony fragment is more than 30%, or if the conservative treatment is failed. And non-bony mallet injuries, splinting should be okay or axial wiring is good. This study compares splint versus pinning in distal interphalangeal joint in closed mallet injuries, which tells that axial pinning is better than just splinting. So just put a wire across the DIP joint and leave it there for 6 weeks, it will all heal well. In bony mallet injuries, we have variety of treatment measures, Ishiguro's technique, hook plating or tension band wiring. So here is a case where there is a bony fragment. Under the CM, you just bend the finger for 30 to 40 degrees and see the fragment under the CM and pass the wire. Sometimes I pass 2 wires, dorsal block or 1.8 mm wires, because the fragment will be very wide, which cannot be assessed in lateral view, and 1 axial wire. This is a case where there was thumb mallet which was displaced, so we managed with the screw fixation percutaneously. So this is intra-op fluoro, where it's very stable. And this is 2 months follow-up, patient is doing well. So my take-home message for mallet would be splinting works if patient is compliant and on regular follow-up to look for skin condition. Surgery is must if there is distal phalanx subluxation or if the fragment is more than 30%. Always remember extension lag and little extensor flexion is always a rule. Most of the patients will have this so you have to counsel them before. Jersey finger, we also know that it's called as rugby finger. Usually it's FDP avulsion of distal phalanx. Mostly the finger gets stuck into the jersey, commonly seen in ring finger. Lady Pecker's classification is very commonly used. The most important and different point from the mallet finger is here the fragment will be avulsed and also the tendon can separately be injured, which is uncommon in mallet fingers. So you should always look for the level of the FDP, even though the bone fragment will be seen distally, but the tendon would have been retracted in the palm. So patient usually present like this, where he could not bend his DIP joint. So X-rays are important, ultrasound is must. Whenever you see a jersey finger, sometimes MRI will also be required. So here you can see in the oblique and lateral view there is a fragment, but if you see in the MRI, the tendon is retracted till the PIP joint. So we usually expose palmarly. This is the FDP avulsion. You prepare the footprint, take bites from the tendons, look for the glide, then pass drill holes across the distal phalanx and get the sutures. This is the another pin going in. and then check. As you're gliding, you can see the DIP is bending. Then I put a small butterfly Venflon soft material to prevent any abrasions. Then pass a button and suture it. Always look for the tenodesis effect. You flex the wrist and see whether the finger joint is extending. That means it is not in too much tension. That's your CM picture. We can also put a screw fixation if the fragment size is big. Early rehabilitation is important. This is at the end of 10 days after suture removal. We start doing. The tendon does not act initially. We have to train the FDP tendon. So that is more important. The moment you repair, don't mean that the DIP will flex. It will flex after 2 or 3 months sometimes. But the patient will get stability so that he can do all his activities very well. So my take home message would be always look for the FDP level by doing an ultrasound scan. Adequate fixation by bone tendon or by fragment fixation is good. And good rehabilitation program is important as your surgery. Thank you so much.
Thank you very much, sir. Manish sir, for a nice presentation and surgical video presentation.
Due to delay in the program, we are trying to continue the program. Before that, I would do small felicitation to all the members who have given such a nice program, both the programs with respect to hand injuries. Audience, any questions?
Any
Kindly
questions from audience side?
Any questions from the audience? Thank you. We go ahead with the felicitation to the speakers, please. I request the chairmen to come forward and do the small felicitation for the speakers. Thank you, everyone. I request all the members who had their lunch to join us. We are not breaking for lunch. We are continuing the session. This session, this session is around the hip from acetabulum to neck of femur. I request Dr. Lakshminarayan sir. Dr. Banna Kiran Garu, Dr. Rajesh, chairmen for this session. I request all of them to come forward. Okay, sir, there's a small change, sir. One speaker from the next session, Dr. Santosh Ram Gaddam, has to go back to Vizag. So he requested us, the organizing team gave a consent. He's going to give a talk before that session starts, which is in the next session, that is communicated proximal tibial plateau fractures. Is 3-column fixation mandatory? And for you, Santosh, you have a nice chairman, Lakshmanan sir, is a beautiful trauma surgeon for us at Warangal. I request Lakshmanan sir to take over.
Good afternoon, everyone, and thank you for the organizing team to give this opportunity. I hope all of you have had your lunch. Now let us start this session, post-lunch session. I request Dr. Santosh Ram Gaddam to give his talk on comminuted proximal tibia plateau fractures. Is 3-column fixation mandatory?
So
Please.
thank you, sir.
Yeah,
thank you
go
for
on.
permitting me out of the session, and I thank the organizing committee for the opportunity as well. So my topic was, does the 3 columns always need fixation? So for that we need to understand the fracture patterns and strategies. This also will provide us answers to whether they need a fixation or not. So definitely we all know it depends on whether, when do we need to do all the 3-column fixations. We know tibial plateaus presents to us with a wide spectrum of injuries. It could be because this could be part of a larger injury than what we see on the X-ray. A simple X-ray can be a part of a polytrauma. He can have multiple limb injuries, open injuries. So first is, we have to never forget the basics. Any proximal tibia fracture, rule out polytrauma. So if possible, always do an articular reduction, but detailed reconstructions only after the second hit. So this is our first strategy for attending it. And next, so what we see in this case is a 50-year-old male who presented with a depression and a split. Now the first thing which comes to our mind is whether we need a single column fixation or 2-column fixation, or do we need to do more, whether we need to do an orthotomy and all. But never should this be our primary concern. We all know that this is a region where it is not the bone which decides, but it's always the soft tissues which decide the treatment. So this patient was having a soft tissue like this, so we had to go and do something else, not internal fixation, and later we converted him to internal fixation, and it took almost more than 3 weeks for the skin to settle down. This is a CT scan, and this is how we came up. So never forget your skin and soft tissues. That is your strategy number 2. Now again, this is an open injury with a lot of damaged skin. So it is pretty much obvious. Again, in a young individual, a 42-year-old, this is what we had to do. So once we went in, there was extensive degloving. So we had to debride, do a flap cover, and primarily we have done a Ilizaro fixation. The whole idea of presenting these strategies is to let you all know that, so we cannot just go in with a single point of agenda that do we need to fix all the columns. There are many factors which we need to consider in a proximal tibia fractures. So we all know why we apply an X-fix. It gives healing time for your soft tissue. So those are the real emergencies. So once again, one more case where the soft tissue is compromised, 50-year-old male. So we did this spanning external fixator and an articular recon, and later we converted this into an Ilizarov. So now coming to whether all the three columns need our fixations or not. So what actually avoids failures in a proximal tibia fracture? It is restoring the alignment and condylar width, giving it a stability and restoring the articular surface. So that is all these three we have to restore. So how can we do this, and what fracture components actually contribute to these failures? So the joint surface, that is your articular fragments, that is what decide your articular congruity. They are nothing but your depressions in our common language. If you see this case, the depression that was tried to be restored, not adequately restored, that's why he could not have an articular congruity. For unicondylar fractures, when you restore this articular block, you can get back your alignment, you can get back your stability, and you can get back your width. But for bicondylar and multiple column fractures, what happens is restoring the articular block alone can give you back the width, but not the alignment and stability. And we need to do something more to get that. So remember, your joint surface gives you is brought back by restoring the articular fragments, whereas your stability can be restored and your alignment can be stability can be restored by bringing back your condyles or the columns, the language which is now spoken. So see this case, they miss the column, that is the condyle, and it goes into failure. Next, how about the alignment? Alignment is restored by restoring back your metadiaphyseal block. So this has to be restored properly and stabilized to get your alignment properly. So why this happens? We might think because only one condyle is supported, it went into failure. But this case, both the columns have been supported, condyles have been supported, but it still went on to failure. So because we started thinking beyond Schatzker's and Moore's classifications, now we know thanks to the CT scans that there is something other than the condyles happening, it is the columns. Now we started seeing proximal tibia in terms of columns. What was once just a medial and lateral condyle has now become a medial column, lateral column, and a posterior column. So we started looking at fixing columns rather than condyles. So what was initially bicondylar fixations have now become tricolumnar fixations. Now in this beautiful paper, once again, if you see, this is a tricolumnar bicondylar fixation. So here the Hoekstra's modification, he identified another grave area, this area which is covered by the fibula. So this cannot sometimes be addressed by the approach we take. So in order to plan for this, what he has told us, if this fragment, this fibular fragment is a part of an anterior fragment, then you can approach this with an extended anterior approaches. And suppose if this is part of a more posterior fragment, then you need some dedicated posterior approaches to address this fragment. So this was done with a Frosch and a lateral, with patient in lateral position. So this is how you address these kind of injuries. So the things we need to know is how to address your depressions, splits plus depressions, multiple splits and depressions, and metaphyseal playing end. So if it's a pure split, it is a one column or a two column injury. Usually they are your flexion and shear injuries. What you need to do is reduce them, compress, and do a proper buttress plating. You can manage these injuries even with non-cannulated screws. This way back in 2017. Now, of course, I'm using a plate for all of this. So that was an isolated condyle. I got away with screws. So this was another articular was fairly reasonable. So we got two plates. This is an osteoporotic. So we started using locking plates. This is another case where the articular block was restored, and 3 weeks later we converted it into a. So all these cases it was purely splits. The joint was fairly reasonable. So this is another same case. You have to always watch for the coronal splits, wherein you need to put some two anteroposterior screws as well and get your column right. So this is same through the posteromedial approach itself. We could get two plates. This is again same, a tuberosity fragment, separate, not a component of your columns, deal it separately. Now what do you do for your splits? Reduce, compress, and buttress the corresponding column. Now what about the depressions? So whenever you are handling depressions, these could be your 0 column, 1 column, or part of 2 and 3 column injuries. So if there is a window, very well you use it, that is in the form of a split. Otherwise you go ahead, create a window and then elevate it. So this is how we have done. We have done an arthrotomy and fixed it. Final picture, and that is how we look at it. Here there is no cortical window. So we had to create one, go ahead and fix it. So here same, again a gross depression. So you can see the amount of depression, it has gone back. We have done an arthrotomy, went ahead and fixed. So whenever the depression is more than 6 to 7 mm and the condylar width is increased, remember there could be some soft tissue interposition, which is usually the lateral meniscus which has gone into the injury. Once again another illustration where we have made elevation percutaneously without actually creating a cortical window. Another case where we had to go posterior with a Frosch and an anterolateral approach and done this bicolumnar. So if you see that orange line which shows, So that area is the bare area where you need to have a dedicated posterolateral approach. The green can be addressed by a posteromedial approach and the anterior can be done by an extended anterolateral approach. If you see a small red dot, that is what your fibular head exactly obscures it. So no way you can do that with any other approach. You have to go through a fibular osteotomy. So depressions, access them, unblock, elevate, maintain and support by filling the void. Now, how to deal the metadiaphyseal comminutions? Same principles of bridge plating apply. Bridge them properly, support them adequately. It is the principles, not the implants. You can still get away even with such a construct with 100% satisfactory results. So as if common problems are not enough, this might seem like a single column injury, but this is a very difficult injury to treat. These are your hyperextension injuries. So this patient, 29-year-old female, she had a CPN deficit. It was a hyperextension and a varus injury. So if you see the posterior cortex was intact, so the high chances of PLC and PCL injuries are common. She did have them. Why are they different or difficult? Because if you see, Ganga had the largest study of 3058 proximal tibia, in which only they had 7 of such injuries. Such rare is their occurrence, limited literature and guidelines to treat them. There is a beautiful paper by Firozibad et al. So this shows how you can reduce it in various methods. This is once again another beautiful paper where the fragment is pinned to the distal femur and the hyperextension is corrected. So this is the CT scan of my patient, went in with an anteromedial approach. So I was not able to elevate the fragments, they are very frail. So I put bone graft underneath the fragment and used that to elevate these fragments and finally fixed it and given her a brace and repaired those injuries. But her CPN never recovered. Even after 1 year, we had to do a tibialis posterior transfer. This is one more case. Again, on the X-ray, it was very silent and subtle. On the CT, this is how was there. The lateral side was depressed. So elevated, that was the amount of void, filled it. Used a 3-column fixation and used a rim plate to support the elevation. That was reasonable enough, but had a minimal collapse, and this is his recent follow-up is doing well. So the strategies are splits, you identify the problem, reduce and buttress it. Depressions, locate them, elevate, maintain with rafting and support the void. Multi-columnar injuries, same principles apply as he splits, depressions and metaphyseal playing. Time your surgery, address the shear, depression and metaphyseal combination. Keep in mind hyperextension and restore the slope. Thank you.
Nice. Thank you, Santosh. Thanks for the talk.
We start session around the hip, from acetabulum to the neck. May I call upon Dr. Ravi from Hyderabad to talk his lecture. Dr. Ravi.
I request Santosh Ram to come. Sorry for the delay, sir. We request Santosh Ram to come. I request Lakshmanan sir to come forward and felicitate Santosh. He has come all the way from Vizag to this conference. So, Oasiscon. Banakiran. Rajesh.
Good afternoon, everybody. I congratulate the organizing team. I thank them for this opportunity for me. My topic is bipolar hemiarthroplasty in unstable intertrochanteric fractures in senile osteoporotic patients. This is a common injury in old people, as all of us know, all of us have treated. It is associated usually with poor bone quality, combination of the fracture site, excessive collapse, and loss of fixation, cutout of the lag screw in cases of fixation. These unstable fractures account roughly to the 50% of the total intertrochanteric fractures. It has a variety of complications and high mortality rates. All kinds of plate fixations have been tried, including dynamic hip screw, and various intramedullary nails are there. All of us have tried it, different combinations. The fact that a particular fracture has so many fixations reflects that not a single method is successful. That's why so many variations are there. But slowly we are shifting towards nail, and beyond that in old osteoporotic fractures with this kind of fracture for hemiarthroplasty. So various complications of fixation of these kind of fractures include non-union, resorption, breakage of the screw, breakage of the implants other than screw also, migration of the implant. In this case we can see how badly the screw has migrated into the pelvis. That's because of osteoporotic bone. And peri-implant fracture, there's a cutout in this case. This is very common, all of us have seen, sometimes in our own cases also. So, even PFN can fail in osteoporotic bones because of various reasons. Because of the paucity of the time, I'm not reading out the percentages. So the summary is that higher failure rates are there in patients above 80 years, 60, 70 also in case of Indian patients, because life expectancy of our patients is less when compared to Western countries, and also the osteoporosis comes early. Even hemiarthroplasty is not devoid of complications. We should remember all these complications are possible in hemiarthroplasty before choosing hemiarthroplasty surgery. These complications include dislocation. This most often happens immediate postoperative period before anesthesia wears off. Particularly after well-done surgery, that's the only possible region for dislocation. The periprosthetic fracture because of osteoporotic bone, prosthetic loosening, particularly if cement is not used, acetabular erosion and leg length inequality, etc. Hemiarthroplasty also has a higher rate of certain complications like infection because of prolonged surgery and also limb length issues. This is more common with hemiarthroplasty. Operative time is longer for hemiarthroplasty, and consequently intraoperative bleeding also is more for hemiarthroplasty and the possibility of infection. A PFN generally requires shorter hospital stay, early discharge. Hemiarthroplasty may require additional days of admission, including possible ICU transfer. Deep venous thrombosis is a dreaded complication. All of us know about this complication, and all of us are afraid of this complication. Wound infection. The moment we see a picture like this when doing a dressing, our pulse rate starts increasing because it's not easy to handle infection. Maybe a little better in early infections, that too superficial infections, but if the infection is deep-seated and cannot be cured in the first attempt, then it becomes more challenging problem. Cost of the joint replacement, hemiarthroplasty is slightly higher. Hip function recovery affects, most of the results are comparable, but in hemiarthroplasty, the patient walks earlier. Consequently, most of the complications related to bedridden status, it comes down. A well-done hemiarthroplasty usually doesn't go for revision. More so in this age because the patient's lifestyle is less demanding. A person who is 70-year-old or 80-year-old with osteoporotic bone is already frail and his daily basic requirements are minimal. Consequently, the possibility of failure and revision is less likely when compared to younger, vigorous individuals. Somewhere long back in my post-graduation days, I read that mortality rates after intertrochanteric fracture after first year after fracture are very high, somewhere around 50%. The main causes of mortality include cardiovascular reasons, pulmonary complications, central nervous system related complications. Patient might already be having some of the systems involved in the diseases like hemiplegia. What makes Indian patients different when it comes to internal fixation or even hemiarthroplasty, where the stem is fixed into the femoral stem is fixed into the bone stem? The diameters of Indian patients are less when compared to Western patients. Most of the implants are designed by the Western pioneers. Their sizes are increased. So many times we feel that DH is slightly a bigger size for this patient, etc. More so in female patients. So the standard diameter of dynamic hip screw is 12.5 mm. Pediatric screws of 10.5 mm diameter also are available. Neck shaft angle in Indian patients is higher when compared to Western people. Femoral neck width also is narrower in Indian patients, more so in females. Cross-sectional shape and also varies, and vascularity is mostly in the posterior superior surface and also medially, less frequently in the anterior. So there's a feeling that anterior approach is better because it will disturb the vascularity less. Why we are choosing bipolar arthroplasty, not unipolar, and why not THR? Why we are choosing bipolar is simple, as this is for youngsters, juniors. It provides two surfaces for movement. Two mobile surfaces are provided. So why not THR? Because THR takes much longer time when compared to bipolar arthroplasty, and also blood loss, operating times, anesthesia time, everything increases, and the possibility of the infection also increases in THR. The idea is to get out of the OT with this kind of patients in the minimum possible time by doing bipolar instead of total hip arthroplasty. It's a well-known fact that if the patient is very old, then we may not prefer THR, we'll do bipolar and get out of the OT in a safer condition. In my experience, well done bipolar arthroplasty, the dislocation is very low. One case I had, that day I was tired, I had to come out of the OT early, and while shifting, the theater technicians did something wrong and it got dislocated after THR in a rheumatoid arthritis patient. Next day I could not reduce it in close reduction, then I had to open and re-reduce it again. Surgical approach in intertrochanteric fractures, its approach is more like a transtrochanteric approach, and the fracture surface acts as a trochanteric osteotomy. Here dissection is different because we try to preserve the blood supply of both the fragments, the trochanteric fragment by inverting the fragment superiorly, and the minimum dissection which is required to expose the wide base of the femoral neck is done, and if necessary femoral neck distal portion, the base, is nibbled off in small pieces, and then we can extract the head just like in IC fracture. Correct limb length can be determined by various techniques including gentle traction and taking reference points. And all the soft tissues, all the particularly important soft tissues they have to be repaired meticulously. So in osteoporotic patients, I found this wiring techniques are very reliable and more feasible, more practical, and less disturbing to the vascularity of the fragments. Sometimes even soft tissues can be sutured with Ethibond 50 or rarely 2-0. The ethibond sutures are less likely to fail when compared to SS wires. This is a X-ray of the patient which I operated. First he had a fracture of right hip, intertrochanteric fracture with comminution. I operated and then patient disappeared as usual. He was from a place which is 220 kilometers from Hyderabad. They did not come for regular reviews after suture removal. They came back after 11 months. Patient was trying to stretch for a book from the cot. Because he could not reach, he moved forward and forward, fell from the cot again. This time he had left-sided fracture and I had to redo the similar surgery on the left side. This is another patient, lady patient, 76-year-old lady. Similar fractures, similar surgery. Another 30 seconds. This is the post-operative result because I forgot to take the video at the hospital. I requested the patient's attendants. I told them, I did not even request. They took the video. They were kind enough and they sent it to me. This is a patient walking at her home. So type 2, 3 and 3 fractures of intertrochanteric type. We do this surgery. Hemiarthroplasty is better in terms of implant related complications and partial weight bearing time than the internal fixation group. This reduces the possible complications of prolonged immobilization, pressure source, pulmonary complications including DVT, reducing the family burden whereby the patient is mobile. It provides a stable postoperative hip whereby the patient can be made to walk average on the second day of the surgery. Sometimes they walk on the first day also after 24 hours. So for me the motivating factors I already mentioned, so I am not going to repeat that. Conclusion, internal fixation is associated with higher complications in hemiarthroplasty in this group of patients. So I think hemiarthroplasty is a better option. Thank you.
So, next speaker I would like to call upon Dr. Anand to speak his topic on fracture neck of femur in children. Please go ahead.
Yeah, can I start, sir? Yeah, thank you, sir. Good afternoon, everyone. I'm Dr. Anand. I'm a consultant pediatric orthosurgeon. You have seen all adult orthosurgeons. I'm the only guy here today. So I'll try to tell you what happens with the kids. It's an easy option of the adults that you just go do a replacement. That's not possible in a kid. So you have to scrape up a little more and, push yourself to the next level. Yeah, so this is the basic classification of neck of femur fractures of kids. I think you all might be knowing it. It's a Delbert classification. Type 1 is a physeal type, type 2 is transcervical, type 3 is basicervical, and type 4 is a petrochanteric. So what is the difference between these fractures and the fractures that we had seen previously? These are all something, they are not complete normal fractures where a baby has a fall or a trauma. The baby can be having a pathological bone already wherein there is a fracture. And this kind of stress fracture are also pretty common, the second type. And third one is the cystic fractures are also pretty common. So these cannot be treated normally like other fractures. So yeah. So what are your basic goals of treatment? The one is fracture union, next is painless hip with good ROM, and to prevent complications for the baby. Conservative treatment. How many of you really do a hip spica? I do a lot. I am very happy doing a hip spica, very, very happy, because most of the babies don't require any surgeries. These are very common fractures in less than 2-year babies, and pretty undisplaced fractures up to the age of 5 years can be treated only with a hip spica, nothing else. So, but this paper was a very rare find that I got, which had 8 undisplaced fractures which had displaced over a period of 2 weeks time. and half of them got displaced. So make sure even if you put a hip spica, you repeat x-rays every weekly once, at least for the next 4 weeks until the union. Next, what is happening with this guy? So 11-year-old boy had a fracture and someone operated it, and this is what happened with him. So this is a disaster. So please don't, if you don't have proper people to help you, proper CM guide and all these guys, there's no point operating a case in the midnight and screwing it up like this. So what happened to this guy? Yeah, this was very good fixation, very happy to see, but after 3 days he comes back like that. So this was unnecessarily opened. So it was open reduction was not required. So closed reduction was good enough. So this is what happens if you are untidy. So this Delbet type 2. What have we done here? We have just done a simple CC screw fixation, 3 points. And what's happening with this? When would you do an open reduction and a closed reduction? And the studies are very funny to say, because they tell the quality of reduction is more important and multiple reduction attempts is very bad, especially in closed. So rather go for an open reduction than doing a closed reduction and really biting your tongue later on. All complications are less with anatomical reductions. So this is what's happening here. So if you are going for Delbet type 1 and type 2, your incision should be a little anterior from the ASIS to the anterior part of the thigh. And if you are going for type 3 and type 4, it should be a little lateral or the posterolateral. So message is reduce anatomically, closed or open, it really doesn't matter. If you are getting very good reduction in close, pretty good, no, then opening should not be a problem at all. And use an easier approach that you know. So timing of surgery. So and what is the mechanism of injury? If it is a very high energy fracture, then as soon as possible is the best thing, because the hip is already losing blood supply. So this is what happened with this baby. What do you feel is really bad in this? So there is a very low kind of Delbet type 3 fracture, and they have done screws, and it is pretty bad, and over a period of time it breaks. And also there is avian, though this is pretty sad fixation, this is very bad. So what is happening with this guy? So there is no compression at all, and there is no spins, I guess. I'm also not sure of the implant name here. So no spins, right? More spins, okay. Yeah, I also didn't know that. So eventually it goes on to avian, and it's very bad. So please choose a proper implant. Very important thing here is Powell's angle. So when you have a low angle, then it's very easy, you just put a screws like that. But when you have a high angle, make sure you put a angle blade plate or a DHS kind of device with a durotation screw. So this is a very nice paper which has come from all the way from Austria. But these are very sad surgeons. To see 22 children losing or reduction in 12 patients is pretty sad. So by this we know that Austrians are very bad surgeons. So yeah, so when you have a very high Powell's angle, you should always use an angle device. So this is what happened with another baby. Another complication that you can see in necrophymosis, secondary slipped capital femoral epiphysis. So this is what happened here. This was a type 1 fracture wherein eventually it was not properly purchased, and the selection of implant, you see, you should never have threaded implants for such a small baby. So eventually it went bad, and it's bad now. Yeah. So type 2. So such a small baby, Delbet type 2 or type 1, when you go and put a screw, this is very bad, a very bad implant. So what you see, eventually you see a physeal arrest, and this baby is going to limp for the rest of his life. So this is what happened with the 80-year-old boy. So this was given by NIMS. Thank you NIMS College for giving me this. So they had a very good fixation, but over a period of time there was a complete collapse of the proximal physis. So 80-year-old boy, more than 10 years only, you are pretty allowed to cross the physis with a big screw. Otherwise it's only the CC screws. This was bad. Yeah, so yeah, Delbet type 1. So this is one thing that happened. They have done CR plus pinning. But what happened, and also immobilization, especially when young kids comes to you, like 4 years, 5 years, 6 years, young kids, don't leave them out just by fixing out and thinking that they will start walking. They are very notorious. So this guy was put on a hip spica. So eventually what happened, we still have bad news that there is physeal arrest and there is coxa magna and coxa valga. So yeah, so growth arrest, you have to keep following up until the complete growth for this kind of fractures. So message is less than 10 years of age, use smooth pins most of the times. It's good for the patient. and if you lay more than 10 years, then 6.5 mm screws are pretty good, and you can cross the physis, nothing is going to happen. So monitor for growth arrest also. Next, what is happening here? So del bit 1, what are the when to cross the physis and when not to cross the physis. So when you see del bit type 1, this kind of fractures, obviously. So what is happening with this 12-year-old guy? What happened was, a simple technique is, you always don't need to open the fracture. You just give a traction and internal rotation, you get a very good reduction like this. Then what you do, you just put a pin and try using it like a joystick and just reduce it well, and then push some screws. So eventually he goes this way, and yeah, 1 year later he's like this. How many of you are happy with this? Happy, unhappy? I'm pretty happy, because he's like 14-15 years and the physis is already closed, and then, hardly there's any growth in the proximal femur, so baby will have a good life, nothing to worry. So next, what happened with this? So del bit type 3, when transcervical, always use a angle blade plate or a good DHS system, pediatric DHS or adult DHS also sometimes, and a good angle blade plates with good attachment into the GT is also a good thing. And as you can see, there's a good derotation screw and a DHS in place. So what happens in less than 3? If the baby is too young with the type 4, type 3 or type 4 fracture, rather go for a hip spike and a simple KOS. They also give a very good reduction. So age appropriate implant is a very, very important thing. Please discuss it with someone and then only take a decision. Next, what is capsular tamponade? So what happens? Oh, I lost time. Okay, yeah. So we are always, the important thing is you need to do a lot of aspiration and capsulotomy, and take home messages are early anatomical reduction, stable rigid fixation, decompression, and always consider immobilization if you feel the guy is mischievous. And please follow up till the complete growth of the baby. Thank you. Any questions for me, sir, in the last? Do you have any questions in the last, sir?
No, last. At the end of the session, we will take up that. May I call upon Dr. Krishna? Fractures.
I have the slides. Good afternoon, chairpersons, ladies and gentlemen. Thank you, Dr. Ram and Dr. Vedaraju and Rakesh and all the organizing committee. I'm going to speak for the coming few minutes on distal femoral fractures from biomechanism to the reconstruction. As we all know, the incidence of distal femoral fractures are increasing, especially in elderly patients with the trivial osteoporotic fractures cause morbidity and mortality in the elderly people. What I wanted to bring to your notice is the distal femur is just not a cortical cylindrical shaped bone, but it continues distally as a rhomboidal shape of the intercondylar or epiphyseal area. Therefore, with this unique geometry, it demands accurate fixation for the mechanical reasons. You know that distal femur has multiple attachments, be it in the muscles or tendons or the capsule of the knee joint proximally, the various ligaments medially and laterally, the intercondylar area, ACL and PCL proximal attachments, all are having an important role in considering the treatment of the distal femoral fractures. As I told, it is not simply the end of the distal femur, but it transmits a load right across the knee joint and also constrained because of the ligament presence, and the fractures and fracture fragments may be deformed because of the various muscular forces, and more importantly, the proximate nature of the neurovascular areas. And another point is
The distal femur has the proximal articular surface area, which is a very uniquely shaped trapezoidal, and the posterior aspect is wider than the anterior aspect, and this is important in reconstructing the fracture attention so that it creates the natural native anatomy of the proximal knee articular surface. The sciatic nerve is posterior along with its both branches, and posterior to the knee, more importantly, the popliteal artery and the tibial nerve of the sciatic nerve are at risk at the fractured site. And more importantly, proximally at the canal of the Hunter, almost close to 10 centimeter proximal to the knee joint on the medial side, the superficial femoral artery enters the popliteal fossa. All these need to be considered in reconstructing the fracture. Not only that, the distal femur experiences a constant changing magnitude because of the various joint reaction forces during the knee flexion, and the contact area changes throughout the guide cycle like this. Heel strike, there is a transemping loading response, high joint reactions, and mid stance, sustained axial compression both through the medial and lateral femoral condyles. In the terminal stance, the posteriorly directed force and sagittal bending causes different forces across. What you need to understand, various compounding factors in treating the distal femur is various biomechanical forces. Axial compression causes load transmission, bending causes deformity of the fractured site, the torsion causes rotational stresses, and the shear stress causes fragmented translation and instability. And various muscular activation factors, they modulate, causing compression, bending, and fragment displacement, including knee flexion. It dissipates the compression shear forces across the condyles. Therefore, what I wanted to say is, because of the knee flexion progresses, alters the magnitude and direction of the distal femoral loading, a fracture in this region, distal femur, compromises both the load transmission and the knee mechanics, which is very important. It may compromise your walking, stair climbing, squatting, and daily activities of living. Gastrocnemius pull causes apex posterior deformity because it puts posteriorly. The fractures within the intercondylar extension cause rotational deformities. The adductor pulls, especially the varus, because of the adductor magnus over the distal fragment. You need to consider all these things while doing. Coming to the classification, many classifications available, but the common one which we regularly take is a AO classification. You know that type A is extra-articular, type B is partly articular, and type C is completely articular. Preoperative planning, always take a 3D CT imaging because it gives you an overall picture. Then pre-op planning is very important for the selection of the implant because of the presence of the comminution, which one is extra-articular, intra-articular versus periarticular. Then problem list, always know is there any bony defect or the compromisation of the soft tissues. Importantly, the Hoffa's component cannot be overlooked. Now, various surgical approaches, you know that from the lateral, which is very commonly done, bicolumnar, anterior, modified anterior Schwarzbuckler approach, etc. Posteriorly, very rare we do Hoffa's fragment fixation. Then the evolution of the fixation, you know that, starting from the plates, then the dynamic condylar screw, which we have all done our generation, then angled plate, yes, we do. Then move to retrograde intramedullary 2000, perhaps in 99, etc. Then a combined fixation, then dual plating. Then comes a distal femoral displacement is one of the options that we need to consider. I need to say, based on the fracture anatomy and their close proximity to the articular surface, we take the various implant selections. Locking plate laterally is one of the standards, but remember, it being a load-bearing implant, it may fail because of the medial comminution causes varus collapse, and if the medial column is not addressed, finally the implant bends and breaks. This is one example, a nicely done fixation. And even latest literature says that lateral LCP is maybe fail. Why? Because if you do not address the medial comminution, the varus movement causes plate fatigue. Therefore, you need to restore the medial column, add medial fixation as needed. If necessary, go for a hybrid fixation, intra and extra both. So comes to the dual plating, this kind of gross comminution, both medial, lateral, in the metaphyseal area, they do demand this kind of dual fixation, especially in the periarticular fractures and also in periprosthetic fractures. Then comes the retrograde intermedullary nail, which is a load sharing device, which is more for extra-articular patterns. But the limitations being, if the fractures are too distal, you need to address it separately, and articular fractures need to address separately. Then comes the double protection, increased construct stability using both intramedullary and extramedullary, especially during metaphyseal comminution in the presence of osteoporosis with medial bone loss. Say for example, this kind of fractures do need this kind of fixation. In this particular case, there is a intercapsular fracture, neck of femur also is there. Therefore, this is reconstructed like this. Then come the most important challenging one is an open distal fracture with the soft tissue and bone loss with intra-articular extension. So this is algorithm. First assess the patient, then do the immediate interventions to give the life-saving measures, then assess the wound. At the same time, assess the neurovascular status. Then what you do is, you scan the patient, plan and span across the joint. When fixation alone is not enough, augment biologically. Whenever there is a bone loss, iliac crest autograft is there, fibular stud graft is there, and then bone graft substitutes are there. But when there is a presence of combination, there is no need to do bone grafting. Then comes the autologous bone marrow aspirate concentrate. Even now, recombinant BMP type 2 also is being used because its osteoinductive signaling causes recruitment of the osteoprogenitor cells, and therefore it will cause good bone union. Then consider pharmacological bone optimization by augmenting teriparatide, especially in osteoporotic elderly patients. Then the distal femoral displacement, last two slides, doctor. Distal femoral displacement, now there is an increasing tendency, and in the literature also, in the clinical experience also, there is increased incidence of being distal femoral displacement implant. Especially you can see distal femoral displacement has seen a notable rise to 14.9% in the recent literature close to last 5 years. Especially when there is no fracturing required and patient needs early weight bearing, early mobilization, potential active rehabilitation, severely osteoporotic patients consider distal femoral replacement with severe metaphyseal bone loss and severe osteoporosis like this. This is, for example, in my own case, last month done, 74 years female patient, see the kind of severe osteoporotic and combination, then fracture reconstructability is compromised, bone stock is not there, age is old, union requirement is not really a point, early weight bearing is needed. Therefore, considering mechanical, biological, functional and systemic factors, component factors, we did this. Patient is walking from the second day onwards. So, distal femoral replacement once upon a time was rarely done. It is being now considered in the armamentarium of the distal femoral fractures in elderly people, right? Then the take home message is, whenever there is a distal femoral fractures, identify the bone quality and patient physiological condition and age. Native bone cavity there, then reconstructability, go ahead, reconstruct. Poor bone stock, not reconstructible, go for distal femoral replacement. And I sincerely thank you for the patient hearing.
Thank you, Dr. Subramaniam.
Thank you.
I request Dr. Ashok Raju to come up on and present his lecture on acetabular fractures. I'm a pardon. I may be pardon. So.
Sorry, Ashok sir couldn't make it, so
Yeah.
I'm filling in for him. My
Yeah,
name is
please.
Dr. Praful.
Yeah,
so
please.
I will
Go ahead.
start it on.
Thank you.
So good afternoon. Thank you for the invite, Ram sir and Tosa. So I'll just straight away go for the topic. So established fractures in 50 years old patient. It's like a 50-50 game. So let's see. So what happens? Why 50 years old is a pivot point? Because 50 years old is neither the young age group nor the geriatric age group. It's a ambiguity. So there are two things to consider. As my senior Subramaniam sir has said, it's a bone quality is at stake. But 50 years, when we compare to 70-year-old individual, it is bone quality is better. So it's always a game between an arthroplasty or a fixation. Myself being a trauma surgeon, I always try to reconstruct, but if decision comes to replacement, I consider this following ease: established post-traumatic arthritis or already existing hip arthritis, elderly patient with low functional demands, and extremely poor outcome of intraoperative with cartilage loss or irreparable posterior wall or with the impactions. So these are the 4 E's I consider before going for reconstruction, which 90% of the time comes out good, but you have to keep in mind of replacement also. So everybody knows about the Establishment 2-column concept. I'm not going to go in detail. It's basically like why one is anterior, another is posterior with a central dome of a quadrilateral plate. Classification is an elementary classification of simple fractures, which is the first row, and associated complex fractures, which are elementary plus hemitransverse components and transverse components of the both column fractures. So instruments we generally use for these fractures are Schanz pins, reduction clamps, which are Cummins Webers, and Faber-Hoffs and Jollinger's classification clamps and ball spikes, and also the distractor is almost another reduction tool, and wires are very helpful in these scenarios. So when we go for any surgery or a reconstruction of these cases, we always go by step, always disimpact your articular fragments, provisionally reduce the wall with either your wires with a provisional reduction or maybe with a reduction plate, reduce the transverse component, it can be the column first, and definitive fixation. Most important criteria for reconstruction is the quality of the reduction. The more the better, the quality is better, it doesn't go for the replacement or the post-traumatic arthritis. So as we call it the Marta's criteria, it is less than 1 mm is always the anatomic, 1 to 3 mm is imperfect, more than 3 is poor. That time if you think it is that reduction is not appropriate, I would advise go for hip replacement at the start. So we go for the first column, which is a posterior wall and the posterior column. Generally these are the cases we see, which is a posterior wall, posterior column and hemitransverse. So generally the approach would be for these fractures are the KL approach, or you can go for Gibson's. Position is generally, I go preferably lateral, but some surgeons prefer the prone, so the gravity assisted reduction also is helpful for the posterior part. Instruments, as I told before, Schanz screws, bone hooks, pointed reduction clamps, ball spikes, 3.5 small plates also, and C-arm. Reduction technique, it can be an indirect reduction or a direct reduction. If you're considering indirect reduction, you can give a manual axial traction. I sometimes try to use my femoral distractor also with one pin in the ilium and another in the distal femur shaft. So he can see the reduction of the wall here. Okay, I am here isolating the fragment. There is a wall. So with my ball pusher, I am going for the buttressing of that fragment. Now following this, I provisionally reduce these fragments with my wires. Thereafter checked in the C-arm about my concentrativity of my reduction, and try to apply the wires which you can exchange it with your screws, and it should be always be in the safe zone as peripheral as for the rim. Generally we consider the 1 centimeter away from the rim is the safe zone. And during this posterior wall and this, you always watch out for the impaction. you can see if your cartilage is facing you, that means it is definitely impacted and subsided, collapsed. You try to reduce it and make it concentric, as you can see here, and reduce it with your wires or with your screws for the fixation. And when we come to the column, we always direct the deforming forces. You can see here, I am using my hook, correcting my deforming posterior vector and getting it straight. That is the first step for any of your posterior columns. Then following that correction of the posterior force, you can use your Weber's clamp or pointed reduction clamps and getting the impaction of the posterior column. Or if you have difficulty of placing this Weber clamp, you can use your Faber-Hoff clamps with the screws, which is also helpful, but generally I try to avoid it because if you have to place a plate, it will be coming in between. You can use your Marta's clamp also, which is asymmetrical. Always check for the reduction on the other side with the clinical palpation of the index finger. That is more important than anything else before final confirmation of your column fixation. Fixation can be with a provisional lag screw or with a reduction plate. So posterior column fixation, when you do, I generally under counter the plate. Always try to under counter the plate so that when you are putting your buttressing screw, it doesn't open up on the far side of the fracture. As you can see in the pictorial, I have put a straight plate and that is buttressing my far cortex, which is your anterior column. Never counter the plate appropriate to the posterior wall or the column. Try to under counter it. Now we move up the anterior column and the medial column. Here you can see the superior medial impaction with the medial vector and the anterior vector. Hemi-transverse. Generally we go for the approach here is Topaz and the pararectus. Ilia inguinal also can be used, but the working horse approach generally for this is Topaz. So fixation strategy is the same thing. First we reduce from the columns or from the ring. So we start from the periphery, which is the ilium, then go from to medial, that is from lateral to medial. The high fractures, larger extraarticular fragments, enough bone, we have to go for the primary fixation. And low fractures, very little, we ideally go for the directly for the medial components. Articular reduction is mainly assessed with your extraarticular fracture lines under the fluoroscopy. If there is a medial migration of your head, always try to disimpact it with your shank pin or with a distractor. Here you can see the shank pin applied in the neck and trying to disimpact it with the lateral traction. This will indirectly give you a reduction in the of your medial quadrilateral plate or superior medial anterior column. And check for your marginal impaction. As you can see in the picture, we can see the gull sign, seagull sign over there. I have reduced it with my osteotome and provisionally fix it with the wires. This is very important. Generally we try directly the column reduction without noticing this gull sign. This is paramount because without your adequate reduction, you are going to have a very painful hip. And reduction strategy in certain types of anterior column, always start with the anterior column. Sometimes in your anterior column, in your ilium, it has an incomplete fracture. There is never a complete fracture in the ilium, especially in the 50 years old. So try to osteotomize those complete fracture, make it mobile, then go for fixation of ilium. Try not to fix it in that position. So peripheral reduction should be the most appropriate or most mandatory thing before going for the anatomical reduction of the quadrilateral plate. First start from the periphery of the ilium, because if you don't get your extraarticular reduction appropriate, you are bound to get a malreduction in your joint. So iliac vein and pelvic brim reduction plates, generally reduce the reduction tools is first is derotation with your Faber-Hoff clamps, then use your lateralization force with your ball spike and get that intact reduced pelvic brim to the intact pelvic brim. And always try to use your under counter plate. 2 minutes. So go for, sometimes you can use for temporary fixation with your wires and the lag screws as well. If there is a posterior column fracture, first reduce with the posterior column, with the quadrilateral plate reduction also has to be done with it. And you can use your follow with a suprapectineal plate. So Sometimes if there's a hemi-transverse fracture, you can reduce it or you can get your posterior column fixation with your column screws and quadrilateral fixation with your spring plates or with your intrapectineal plates. So small. So you can see this is generally the anterior column hemi-transverse fractures. So here you can see first the anterior column ilium is been derotated with a Faber-Hoff clamps and use the joystick stand spin. Using the lateralization of my ball spike, I am reducing first my ilium and fixing it with a interfragmentary screw. Follow it up with an undercounter straight plate and getting that pelvic brim with the suprapectineal plate with the anterior column in one piece. Thereafter, I am going for my Weber's clamp and getting that intact pelvic brim into the play and completing the construct with my anterior column plate. So in a conclusion, reduction is a major determinant when you're going for reconstruction. If reduction is at fault, please kindly redo it, or we can go for arthroplasty. Always the rule of thumb is first the column or else first the periphery, then go for articular. Reconstruction still remains as per the analysis and the meta-analysis as a working horse for the fit oral individual. So reconstruction should stay the light. Thank you. And I take the opportunity to kindly invite you to the OTS summit, which we are going to have a lot of trauma. Thank you.
Thank you, Dr. Praful. May I invite Dr. Ravindranath, the next talk?
Yeah, there is one announcement. There is an announcement for the postgraduates who are interested to undertake the quiz. They are having a written test in the underground floor art gallery at 4:30 p.m. Please note.
At the outset, let me thank the team of Tosa Oasiscon, Dr. Ramkumar and Dr. Vijaychandra. This is a little different from more of lateral thinking than routine procedures here. Is osteosynthesis possible in all non-units of neck of the femur in adults? Maybe yes. I'll just tell you how it is yes. But we have some firewalls in the form of improved technology in the liners of the acetabular cups and metallurgy in the femoral stems and increased longevity of these implants, and then fast life. Nobody wants to see the videos for 2 minutes. They want to see videos for only a few seconds. Patients are not able to tolerate the waiting of 3 months or 4 months weight bearing. So the firewalls, I grab them and then they don't come to us. But still we have some cases leaking out from the firewalls and then reaching to us. So we have some criteria. How do we do this osteosynthesis in non-unions of the neck of the femur? May I draw your attention here? The duration of the fracture, it doesn't matter at all. It can be from 4 weeks to 9 years. 4 weeks to 9 years. And age, I always consider not chronological age but physiological age here. And then the neck of the femur. Do we need to have neck of the femur at all? Sometimes we don't need to have the neck of the femur. Neck can be absorbed. Still we can get osteosynthesis. And then complaints. As I said, patients should be able to tolerate non-weight bearing period for about 4 to 5 months time. Then can we do the same procedure in pathological fractures? Maybe yes, we can say that. And then for all these things, we should know the vascular to the head of the femur. I just derived a sort of observation. How do you make out the vascular to the femur on plain radiographs again? So this is the plain radiograph.
And the fourth most important is congruent to the head. Suppose somebody is walking on a non-union for about 4 weeks or 9 years time, when the congruity is well maintained, the head is not collapsing at all. That's how you can see that congruity is very important. And we have the anterior wall of the acetabulum and as posterior wall of the acetabulum. That part of the head, which is not overlapped by the acetabular walls, you see and compare with the opposite side, if they cast the same amount of radial density shadow, that is a viable head. So if you have the congruity of the head and the non-overlapping head of the femur is considered to be, you take it considered to make it a vascular head. So then how do we achieve the osteosynthesis? So it can be achieved by open reduction. My favorite is muscle pedicle grafting, or we can go for a valgus osteotomy. We have 10 cases in the pipeline now. And then the most commonly favorable surgery for me is Meyer's muscle pedicle graft. We have done about 80 cases in the past 25 years of time. And we have Sartorius muscle pedicle graft, about 8 cases. And we have some other procedures which can also help in osteosynthesis in the case of a non-union of the femur. So let us talk about the few procedures here. The surgical procedure for Meyer's pedicle, you should not feel insulted or what called inferior when you want to put a Buck's traction. When somebody comes with pain in the hip joint, put the fellow on the traction for about 1 or 2 days, so the pain comes down. And then the difference between Meyer's is my procedure is lateral decubitus is what I choose, and I go for southern approach or azimuth approach. And that is the position of the patient, and those are the landmarks and incisions. And we take out the cordyceps, we isolate the cordyceps, and then we define the cordyceps, the superior border, the lateral border, and the inferior border, and we delineate the area of the insertion of the cordyceps, quadratus femoris. That's what we make with a cautery or a small osteotome like thing, and then we elevate it. The crucial point in Meyer's muscle pedicle is elevation of the origin of the insertion of the quadratus femoris is very crucial. We should not break the graft, or we should not take very too thin sliver like thing. And then we elevate like that, see that there is bleeding from the elevated part of the or insertion of the quadratus femoris, and that's how it looks like that. Then we go for capsulotomy, and the crucial point is one should not do too much of fingering at these 2 points, the superior part of the capsule as well as the inferior part of the capsule, and we should not put anything or fingering in the insertion or origin of the around the what you call short rotators of the head. That's the orientation of the head when you are seeing from the that's on the right side of the hip joint. Then freshening of the edges is done, and then we use this K-wire as a joystick to get the head onto the so-called leftover head neck to get into valgus as much as possible onto the trochanteric area or part of the neck if it is available. Then how do we get the views? A simple way is since I am doing it on lateral position on normal table, without changing this position of the C-arm, we can change the position of the limb and get the both AP as well as lateral views. Very comfortable, no difficulty at all. And then after the fixation, you see the stability of the fixation by rotations as well as flexion and extension of the hip joint. So we have some case examples. This is about 2-year-old and 37-year-old patient, and non-union of that. There is not much neck on the head side, a little neck on the femoral side. We did the same procedure, the immediate post-operative X-ray of the Meyer's muscle pedicle, and there's about a 1-year follow-up. Unless I show the clinical results, one should not go for weird surgeries like this. And that is the integrity of the joint there, and that is the gait, and the Trendelenburg is negative here. So this is about 2 years old non-union. And you have a 51-year-old lady. People jump in for doing a total hip replacement. It's about 9 months old non-union of the neck of the femur. And then we did the same thing. Just check the integrity, the Kalakshethram femoral by getting a X-ray in internal rotation and traction. And then you reduce it on the table. These are the CM pictures. How do you reduce it? And you use the same joystick, K-wire joystick, to get the head onto the neck of the femur, whatever residual neck is there, into valgus position. And that's how you get it. You can see the joystick coming down towards femoral side to get the head onto the valgus position. And that's how you use it there. And this is the final fixation. And after 8 months of post-op follow-up, you can see the results like that. This is the preoperative gait. Patient comes with that much of pain. and that's the post-operative period. He's got little limb shortening. We can't do anything for that because the neck is not much there. And tendon sign is negative here again. And we have one more case, you have a 34-year-old male with a trivial injury. And then he comes with 4 weeks old pathological fracture. So this part of the neck is important. It looks like a geographic type of lesion there. And when we did the MRI, it came out to be some cystic lesion in the neck of the femur with a pathological fracture. We did the same Mayer's physical. After 1 year of the follow-up, the report has come as a simple bone cyst, and that is the integrity of the joint after about 1 year in a 34-year-old fellow. We have a 6-year-old patient again, 60-year-old fracture with 55-year-old lady. Again, we jump in to do a total hip replacement or bipolar. This is the procedure done about almost 15 years ago. This is a 4 years follow-up here. And then you can see how happily she is squatting on the floor. That cannot be possible when you do a total hip replacement. Is there any other procedure other than this Mayer's physical? So this is a 1-year-old intracapsular fracture in a 22-year-old patient, no neck at all. Head is congruous, and then head is congruous and viable head there. So we planned for a sartorius muscle pedicle graft. That's why you harvest the sartorius graft from the anterior leg spine about 3 centimeters long, and then fix it to the anterior part of the neck of the femur, and then few minutes please. And this is immediate post-op, 4 weeks post-op and 8 weeks post-op. Unless you show the clinical results, preoperative gait, painful gait, and that's a painless gait. This is about a 17-year-old girl. When she was 8 years old, she sustained some injury. Somebody has done a nailing for both femur as well as tibia for a floating knee and missed the intracapsular fracture there. And this is about 9 years. This is about 9 years old intracapsular fracture neck of femur with a non-union. And we just planned it. We should plan like this. The pelvis is tilted when the knees are parallel to each other. Unless you correct the pelvis tilting by your surgical procedure, you will not get success of the surgical procedure. And then the planning should be very meticulous since it's 9 years old. We can't take it very lightly. So we have done it under anesthesia under CM without anesthesia, the distal migration of the trochanter. But under anesthesia, again we see the trochanter is almost at the level of superior part of the vestibular cup, vestibular lip, and then we fixed it with valgus dilatation osteotomy, which is very useful for this particular case. And you need to have meticulous planning for that. This can be done on your PowerPoint presentation, and then see how you are going to do it before doing surgery, and that's how you do it. And once you fix that with a DHS and derotation screw, do a valgus osteotomy, lateral closing, and that's how you should get the final impression on the table. And the execution should be very precise there again. You can see the narrowing of the gap, and then fixation with DHS and well as derotation screw. Here the capsule is very much intact and is immediate post-operative, and that is about 3 months post-operative period, and no limb length disturbance at all. And she comes with a nice gait. The one thing I want to address here is the improved abduction because of the distal migration or distal pull of the trochanter. She gets a beautiful normal gait as if she has no fracture previously at all. The last one slide, sir. It's a day 1 failure. All juniors should understand what is day 1 failure for any fracture, in fact. But intracapsular fracture is very crucial again. It's a fresh fracture, and somebody has done that. And this is definitely going to be a day 1 failure. The reason is very simple. Unless you do like this, there should be a biplanar screw fixation or F fixation. That screw is very crucial, calcar screw. And then you should have one more screw right angle to the fracture line, and a derotation screw again. This is going to heal the fracture. Since it is not done, we are left with only a valgus osteotomy again, and that is a valgus osteotomy. He comes to us with about 6 months' time, nice gait, and nicely united non-union of the neck of the femur, and good integrity of the joint, and able to squat reasonably well. So do we have any complication? Definitely, the avian is there, and then we have the cutout of these screws initially, and there is somebody doesn't allow complain with the non-weight bearing. It will go for a gradual collapse and then varus there, and leading into telling by Kate et al. Echo messages is very, you should know viable to the head on plain radiograph based on congruity as well as non-shadowing of the both lips of the acetabulum. And the physiological age is more important than the chronological age. And all these processes are reproducible. And the anatomy is not disturbed when you are going for a muscle pedicle graft in case somebody wants to go for a future total hip replacement. And this is very crucial. Markata niti. That means you should always hold on to your mentor. That's very crucial. And thank you very much for your time.
Thank you, sir, for your great presentation. Stay, sir. I invite Dr. Ravi, sir, Dr. Anand, Dr. Krisha Subramaniam, sir, Dr. Praful, Dr. Ravindranath, sir.
Yeah, in between. There is an announcement. In order to have the 2 TGMC credit points, the delegates are requested to go to B34 TGMC stall and register themselves, so that we can have the 2 credit points which are assigned for today. B34 TGMC stall before 5 p.m.
Dr. Anand here.
Dr. Anand? She is not there. Any questions you can ask the speakers. You can.
Any questions, please?
This is the question to Dr. Ravindranath. Apart from assessment of the viability of the head with the plain X-ray, comparing the opposite head of the femur, if it is a similar radiological density, you have assumed that it is viable. I agree with that. But there is a much more sensitive investigation in the form of MRI. Is it going to be of any help? Of course, your results are speaking that the head is viable. Even then, MRI has become a routine investigation.
Yeah, I do agree with you, sir. MRI is definitely a useful investigation. But I feel, if you believe me, I have done about 80 cases.
I know everybody will not have your eyes.
Yeah, that's true, sir. But yeah, one thing is, I am comparing the X-ray film of the when it's taken at the one time only. So you are seeing both hip joints, not that it's a digital film or whatever it is. Definitely, MRI is going to help you like anything. Definitely, it's a useful investigation.
Especially in the teaching institutes where you can ask for an MRI without making the patient pay more money, especially. And if you request the diagnostic person, probably they may also help even for poor people. Yeah, thank you.
Dr. Ravindranath, sir, in between Sartorius versus Mayer's muscle particle graft, you said you have done 80 and 8 almost. Which one you prefer and why?
The disadvantage of Sartor's muscle pedicle is it's difficult to open the fracture in the Smith-Peterson approach. So when the non-union is there with normal or varus angulation of the neck of femur with not much displacement, I prefer to do a Sartor's muscle pedicle because we are doing it on a fracture table, and in the anterior approach, anterolateral approach, it's difficult to open the fracture and freshen it. So that's the only reason why I could do only 8 cases in my study.
So, Dr. Ravi, I'm interested. Do you take doing a hemi-hip replacement in all the comminuted intertrochanteric fractures? Any guidelines?
It all depends on the physiological age of the patient. Patient may say that suppose we get 3 patients who call themselves 70-year-old. One patient looks to be 80-year-old, another patient looks to be 60. All of us know this. So the patient who is unlikely to tolerate the bedridden status, I go for hemiarthroplasty. Frail, fragile patient, just like the old lady I have shown in my video. And if it is more comminuted also, including neck, then the neck healing chances in elderly patients is more difficult, and also the bone density, bone quality. Obviously, the bone healing capacity of older people is less, much less.
Any tips to reconstruct the abductor mechanisms under trochanter?
Yeah. We can do tension band wiring. We can do the soft tissues which we are going to incise. Because as I told, approach to this fracture, hemiarthroplasty in these fractures, IT fractures in elderly, is something similar to transtrochanteric approach. Only the difference is here we have the fracture already. We don't have to do the osteotomy of the trochanter. And the tissues also, tissue dissection, I do accordingly. Like I don't do routine posterior anterior approach. This is a transtrochanteric approach kind of thing with minimal tissue dissection. And the soft tissues I prefer to repair with Ethibond. Ethibond is less likely to fail, as I told already, when compared to SS wires. It lasts much longer than SS wires. SS wires are prone for fatigue fracture. Whatever diameter you use, even if you use thick diameter SS wires, it takes a little longer to fracture.
Dr. Praful, you said 50 years is a cutoff point in situations where especially bicolumnar fracture with severe osteoporosis of the iliac wing itself. What are the bailout situations?
50-year-old with a severe osteoporosis, as I said before, sir, it's if it is reconstructible or non-reconstructible. You always check out for your marginal impactions or any loose bodies. If you are able to reconstruct that marginal impaction with your cartilage without any defect, the outcome would be more favorable for the salvaging the joint. But there are some cases where the cartilage loss is very fragmented. So in that sporadic cases, there is a literature saying that you can go for primary hip replacement with the column fixation. We cannot go for the primary hip replacement without the column fixation. So it's a hybrid thing where we do a column fixation from the superior anterior column and go for the posterior hip replacement and reconstruct the columns. So columns bear the point for your hip replacement. We can augment, sir, but if it is just a fresh trauma case, it doesn't come for the so much of collapse where we require to use a augmented implants for the hip. So it can go with you can as well use your head also, native head, and we can do that. I would say that 50 years old osteoporotic, I will still go for the reconstruction and tell the patient that profile him later for the possibility of the hip replacement.
Ravindra sir, I want to know immediate post-op precautions, how you advise the patient, and also so we are all not doing this Mayer's muscle pedicle graft as you were all doing all those times, and I want to know how you counsel these days when you operate a muscle pedicle graft, Mayer's muscle pedicle graft.
I operate in line with preserving the head. I ask the patient, suppose a 22-year-old fellow comes to us, he is going to live for at least 60 years. 3 months of weight bearing is not a big issue at all. 3 months non-weight bearing. So that's how I tell them. You have normal hip joint. But if the firewalls are coming the way, I'll make you walk next day morning with replacement. That is not the way I do. I do counsel them. You have to wait for 3 months time. Till 2 nights, he'll be mobile. He'll be walking on other limb with a walker. He'll not be in bed at all. But he follows the 3 months to 4 months time of non-weight bearing. Throughout his life, rest of the 40 years of life, he'll have his own head and neck. That's what I positively counsel them that way. And Dr. Ravi, suppose when you have a Boyd Griffiths type 3 or type 4, when you take out the head and neck, how do you assess the anteversion of the femoral neck? You have any surgical tip for that? There is no neck at all. Trochanter is much away from it. Let's say trochanter is somewhere else. how do you maintain the antiversion of the, or normal antiversion of the femoral component?
So as like all of my seniors, I do most of these cases in lateral position, only the posterior approach right. By flexing the knee joint, the foot gives the orientation regarding the rotation of the anteversion or retroversion otherwise. And also one can reduce the lesser trochanter into position. And based on that also, we can assess particularly if the fracture is simpler fracture. In more severely comminuted fractures, we have to go with experience like I told, flex the knee joint and rotate it. In older textbooks of Campbell, etc., they have described this beautifully. The orientation of the foot and leg, that gives a rough idea to the regarding how much anteversion is required, how to decide on the anteversion.
The easier surgical tip is that so you are doing from posterior approach or anterior approach. Anterior approach is you drop the limb down to the anterior part of the table, and posterior approach is you flex the knee joint and then keep it 90 degrees as you assess for total hip replacement. The linea aspera is very crucial. You put the long axis of the stem on the femur, trial stem, and then see that the head looks into the wound. So in the posterior approach, the head should look into the wound by about 15 degrees in corresponding with the linea aspera. Linea aspera is a constant structure, it is not mobile. Suppose you're doing a posterior approach, suppose you're doing anterior approach, you just do the same thing, take the linea aspera under consideration, get the head, neck of the implant away from the hip joint, away from the wound. Away from the wound is the anterior approach of the hip joint. Towards the wound is a posterior approach in relation to linea aspera. That's very crucial, and you can easily get on without any dislocation at all.
This is the trial stage you are advising.
Yeah, trial stem. Keep it on the posterior part of the. You can see the linea aspera nicely, isn't it?
Agreed, sir. But the osteoporotic bones, the stem starts playing around, sir.
No, you have stem there, and you have linea aspera there. You put the stem, trial stem on that, and then rotate it so that it looks into the wound by about 15 degrees. That is anteversion from posterior approach. Reverse it is anterior approach.
Completely agreed, sir. But only I was trying to say that when the stem is loosely fixed, the trial stem, again we have to control that a little bit and do what you said.
Most of the time we do distal bearing, weight bearing femoral components most of the time.
To overcome all these problems, there is a modularity of the...
Yeah, that's the case.
Sir, my question to Dr. Krishna Subramaniam, sir. Always we need to plate medially, or we can put rush nails medially to have good support for the medial cortex during fixation of distal femur fractures?
To keep the rush nails or tens, whatever it may be, it lifts off the fragment. So I would prefer to neutralization plate over the nails.
The two criteria for me to stabilize on the middle side for supracondylar fractures is if there is a gross comminution on the middle side, definitely it's the indication for supporting on the middle side. If there's a void on the middle side, I prefer, as I said, a plate, or preferably I go for a 2.5 or 3 mm titanium nail or rush nail. We should go beyond the proximal extent of the lateral plate. That's very crucial. Not distal to that, beyond the proximal extent of the plate. That gives stability on the middle side. They unite very nicely.
Sir, one more question to Dr. Ravi, sir. Is there any experience regarding calcar replacement processes for IT fractures?
Usually I prefer cemented, where the calcar is comminuted or missing. And these fragments, if possible, can be approximated with encirclage. Encirclage is a neglected technique. In this situation, it is very helpful, and if it is properly done, it helps. And you can supplement with ethibond sutures, soft tissue stabilization. Soft tissues are also very important, not only the porotic fragments of the bone which are seen on the X-ray.
Thank you.
Thank you. Thank you, Chairperson.
Thank you everyone for the nice presentation. We request the chairmen to come forward and felicitate all the speakers. We request organizing chair. Thank you to all the chairmen and speakers. We go ahead with the next topic, that is plateau to patella. We request chairpersons Dr. Kali Prasad sir, Dr. Pattabhiramaya sir, Dr. Smarath to kindly come and chair this session.
Good afternoon to everybody. Now session 6, priority to patella, precision in trauma. This, I would like to call Dr. Srinivas Thati. Happened that? No, is there? Thati. He will speak on current principles in managing multi-element knee injury, AG technique, official reconstruction. Please go ahead.
Not coming? Check.
With the permission of the chair, request all the delegates who are postgraduates or faculty here to go to TSMC register counter number 34, B34, and kindly take 2 credit points which will be scanned. Thank you.
Okay. Thank you, organizing committee and Dr. Ramkumar sir, VCS sir, for inviting me for this talk. It's always a homecoming coming back to Warangal. So I work as the head of the department and the director at AG Hospitals, Gachibowli. I'm going to talk on current principles in managing multi-ligament injury. I did a modification to the LaPrade technique. That's why I call it as a AAG technique of reconstruction. So if you look at the multi-ligament injuries, different connector? To connect it. Okay, thank you. So this topic is chosen because even though it is a very rare injury, it is a life-changing injury to the knee joint. Most of them are because of the anterior dislocation because of hyperextension injuries, but 1/3 of them can be because of the posterior dislocations due to dashboard injuries. In India, of course, RTA is the most common cause of these injuries. So why this topic? The multi-ligament knee injury is still an unsolved problem because there are controversies around the timing of surgery, whether you want to do early surgery or a delayed surgery. Early surgery certainly preserves the meniscus and the articular cartilage. However, the risk of stiffness is pretty high. But when you look at the late surgeries, your risk of having meniscal injuries, cartilage damage, post-traumatic OA, they are pretty high. staged or all surgeries at a single stage or a staged surgery for the multi-ligament reconstruction. Again, there is a controversy. And repair versus reconstruction or the graft choices. You want to use an autograft or allograft. In India, we don't have that much of allograft supply, so we are fixed to the autografts. And certainly there is no proper rehab protocol because these are very rare injuries. So the consensus committee, which is formed by 39 surgeons from 14 countries, in 2024, has defined certain nomenclature. A multi-ligament knee injury is not just restricted to the collaterals and cruciates. You do see meniscal injuries, patellotendal injuries, cartilage injuries, as well as bone injuries. To include all these, there is a change in the nomenclature. The diagnosis, again, it is not just MRI. You also need to do a CT angio if you are doubting any vascular injuries. And certainly treatment, the level of agreement on all of this is around over 90% in the consensus meeting, and everyone agrees that better to do a early surgery than late surgery unless there are any specific contraindications. I follow early surgery, single stage reconstruction using autografts, and certainly use reconstruction of the cruciates and PLC, and when possible I repair the MCL with augmentation. I had done more than 11 cases now so far in last 3-4 years, and most of them are from RTA. Two patients had fall from height, and one had a cricketing injury. 8 of them had really good injury, good outcomes. One had stiffness, and one patient had infection because of open injury. So case 1, this is a 57-year-old male who is a farmer who had involved in RTA and was not able to weight bear because of the dislocated knee, which was reduced at the time of injury itself. He had altered sensation in the foot, but no motor deficit. The X-rays were looking normal, and he had a small abrasion over the medial aspect of the knee. MRI scan does show a complete tear of the ACL, complete tear of the PCL, and posterolateral corner, both the LCL as well as the popliteus. His vascularity was intact, and there was, except for altered sensation, there was no other motor deficit. And the medial meniscus is extruded because of the strain on the MCL. And this examination intraoperatively, you can see in the Lachman's and antidroyer, they were all grade 3 plus, and also mediolaterally it was opening up on either side. So the surgical plan, graft choices wise, I use superficial quads for the PCL, semi-T for the ACL. I use all inside technique, so I can use a single tendon. The peroneus longus, this is where the variation is. When you are doing a posterolateral corner, the Leprard describes using 2 tendons for the posterolateral corner. Here I used only a single tendon for the posterolateral corner. And the Gracile is used to augment the MCL repair. So single tendon graft for PLC, literature classically describes 2 tendons. So this is a technique which I used for the screw fixation for the LCL as well as the popliteus on the femoral side, and a suspensory fixation of the tibia. This is the new technique where normally we used only the screw. The advantage of using the suspensory fixation is at the end of the procedure you can get decent tension in the graft. Majority of the late failures or the instability post surgeries are due to lack of good tension in the posterolateral corner due to weak PLC, popliteofibular ligament or popliteus tendon. This you can revert or you can go away by using a suspensory fixation, which will give a good tension in the graft. And use a screw for the LCL on the fibula. This is intraoperative images, the ACL and PCL, and you can see the 2 guide pins on the tibial side, on the femoral side, and on the tibial side there is a suspensory fixation on the last image. That's a reconstructed ACL, reconstructed PCL, and intraoperatively the joint is stable in both mediolateral and anteroposterior planes. So this is a follow-up post-op X-rays, and the knee wounds are very well healed. There was no issues with the wound healing, and this is a rehab protocol which we follow. We'll start the patient fully weight bearing from day 1 in a brace, and the brace is used for 6 weeks, and always make sure that the patient is using support for 6 weeks so that the tissues are healed well into the bone. And the second stage is around after 2 to 6 weeks, where you go for full range of movements and increase the muscle strengthening and start off with some joint sensing exercises like proprioceptive exercises. Over 6 weeks, it is a rebuild phase where you can start with the proprioceptive exercises, and the patient can start walking without support. There's a patient at 3 months, he has full extension and near full flexion of the knee joint. So there is no stiffness in this patient. He was done within 3 weeks, and he's able to sit cross-legged at 12 months post-op. So the case 2, so this is where the nomenclature is important. MLKI is not just limited to the cruciates and collaterals. You also have involvement of the menisci as well as the patellar tendons as well. This patient is a 28-year-old male who had a RTA and was not able to weight bear. He has a dislocated knee which was reduced in ER, and X-ray has shown only a small fracture, avulsion fracture from the fibular head. He did not have any neurovascular injury. This MRI scan which does show the complete tear of the ACL, complete tear of the PCL, the posterolateral corner is sprained, and he has a medial meniscus and MCL tear as well as patellar tendon rupture. So this is a shank 4+ type of injury. So these are the intraoperative videos where you can see the joint is pretty unstable and it is dislocating, and there's a second image on the coronal and sagittal planes. Intraoperatively, there's a medial meniscus which was completely flipped out, avulsed. The roots, both the anterior and posterior roots were avulsed. So you have to repair the roots and push it back into the place. Following that, I have done the patellar tendon reconstruction using the gracilis tendon. So this is the stability at the end of the surgery. The intraoperative image shows repaired medial meniscus, the MCL as well as the patellar tendon. This is the arthroscopy images which show the repaired medial meniscus which has gone right to the back of the capsule, and the anterior horn and the reconstructed ACL in this patient. I did not do anything for the posterolateral corner because once the MCL and ACL was done, the posterolateral corner was very stable. And this is a patient follow-up at 8 months, walking independently without any discomfort. He has full extension of the knee, indicating the patellar tendon is well healed, and he is able to go sit fully cross-legged, full flexion. So to take home, when you see these kind of injuries, the first thing you do is reduce and assess the level of injuries. Always check for the vascularity and neurological status. If there is any question about the vascular injury, do a CT angiography. You have to classify them. Don't just stick onto the shank, go beyond that. Time the surgery. Now the current consensus is time it early if there are no other contraindications. Stage the decision depending upon how the patient is and your resources. Better to do as a single stage than 2 stage, and certainly rehab is very important. So as a medical ethics TGMC member, I request all to stop referral payments practice as my colleagues. Thank you very much.
Thank you, Srinivas sir, for giving your valuable inputs. Next, I want to invite Dr. Akhil Dadi sir regarding the talk 3 decades and trauma implant changes. Not available.
Both anterior posterior instability and medial lateral everything. So primary repair, all the ligaments are crack-o-stitch with fiber wire and passed through the fine bony tunnels by bead pin or 4 mm the augmentation with fiber tape. All are kept in position. This is during surgery. While tensioning, I checked the stability. All are repaired. Post-op day 1, I asked all the patients to move, walk with support, and ROM brace while walking, not in the bed. In the bed, full range of movements are allowed. All the ligaments are healed. The continuity is seen well. This 3 months post-op. Case 2. Here only 3 ligaments are injured. ACL, PCL from the femoral side and MCL from the tibial side. MPFL also. This is the MRI. This is pre-op assessment. During surgery, go to next case. Case 3, this is ultra low velocity injury, just slipped and fell down at home. Knee dislocation, all 4 ligaments torn, neurovascular intact. The dislocation during anesthesia, all surgery, all are repaired. Here LCL also repaired and augmented through a separate incision laterally. On the table, post-op X-ray, 1 month post-op. Case 4, a two-wheeler accident, tibial side avulsion of ACL, PCL and associated medial tibial plateau fracture and also medial lateral meniscal avulsions. As my previous speaker suggested, whenever there is a meniscal injury, always repair at the earliest. This is the MRI report, this is post-op X-ray. In this X-ray, you notice a small bony fragment in the posterior intercondylar fossa, which disappeared after 2-year follow-up. And this is the 2-year follow-up video. The learning points is single stage repair of all ligaments as and when possible gives best results. There is no clear consensus on optimal management strategy and timing, but whenever possible you repair whatever the possible ligaments, because a ligament repair gives a better better joint mechanics and better rehabilitation. So, but in some cases we can do repair, but some cases we may have to do reconstruction. Especially when the patient is less demanding, repair gives reasonably good results. And all cases are not same. You have to tailor the treatment according to the patient needs and demands and the particular case. So, literature supporting primary repair. So, whenever this is the guidelines I followed. Thank you.
I would thank Dr. Venkatamana sir for showing all challenges, cases and promising results after a complicated surgery.
Thank you.
Thank you, sir. Next, I would call upon Dr. Rajesh sir. The topic is depressed proximal tibia fracture, orthoscopic assisted technique.
Good afternoon, everybody. Good afternoon, respected Chairman. I thank Dr. Ramkumar Reddy sir and Maheshwar sir for this opportunity. Today my topic is about arthroscopy assisted tibia plateau fracture. The caption is see, reduce and fix. So as you all know, we are pretty much aware and have a knowledge about Schatzker's classification, which you have been learning. Type 1 fracture is a simple split, type 2 is split with depression, type 3 is depression, and type 4 is medial condyle, type 5 is bicondylar, and type 6 is comminuted fractures. And as you also know that 3D based classifications by Leo et al. And Crossi et al. Has classified into columns, and you can sub-classifications in the column by cross classification. The role of arthroscopy comes more in the central and posterolateral part in further discussion. So what is the operative goal in such fractures? Because tibia-ablative fractures is also a point of knee joint. So restoring joint congruity, correction of alignment, stable fixation, and preserving soft tissues is one of the important essentials when we think about and fixing of these fractures. Then what is the role of arthroscopy here? Arthroscopy helps in the direct view of the articular surface. It helps in the identification of occult injuries like meniscal, chondral, and ligament pathology. And we can see all these associated occult pathology can be treated in the same procedure. And the important point is we can confirm final joint surface after the fixation. And you know that in open procedures, when we try to elevate this kind of fractures, there is a lot of soft tissue injury and maybe a vascular injury to the meniscus surface when we are trying to elevate the meniscus and trying to see the joint and lift the articular fragments. So where does this fixation stand? According to Perkin et al., more than 2 mm of fracture depression and varus greater than 4 degrees are associated with post-traumatic osteoarthritis. Hung et al. Has suggested that surgery is recommended when articular surface displacement is more than 3 mm and tibia articular suppression is more than 5 mm, and if there is any malalignment of more than 10 degrees. The most common fractures that can be treated by these are Schatzker's type 1, type 2 and type 3 fractures, and especially type 3A and B, which are associated with central and posterior lateral depressed tibia-ablative fractures. Now, mostly the classification is by CT and X-rays, and by X-ray and CT we can see the fracture pattern, we can plan how to reduce the fracture, we can see which columns are involved in CT, and most important is we can see any split or depression that is only in one plane. Whereas in arthroscopy we can see the complete articular surface, we can see if there are any meniscus injuries, chondral injuries, ACL and PCL injuries, and if there are any loose bodies. Now if you see how the orthopedic OT setup will be, the patient is usually supine and tourniquet is required. We require good suction apparatus, and C-arm is also helpful and it is very much required. A good arthroscopy setup, fixation set, ACL, PCL, meniscus repair sets, and we have to see that there should be, after having, in spite of all these things, there should be good freedom of movement inside the operation theatre, and most important is the proper portal placement technique. And if you see the instruments, the key instruments are battery operated drill, tongs, hammer, elevators, and most important here is ACL jig, preferably a Arthrex flat ACL jig with a bead pin is very much required, and also bone graft set. So the key to a good fixation and identifying the associated pathologies is good visualization. So tourniquet, after applying the tourniquet, when we do an arthroscopy, diagnostic arthroscopy, we need to do, when we enter through the anterolateral portal, the hematoma is drained first, followed by saline wash till the fluid that comes out of the cannula is as clear as possible. And we have to remove the, then we have to make the anteromedial portal, put our shaver, it should be at very low suction pressure initially, to take up the fat pad and increase the visualization, and never the suction should be at the high level. And the simple reduction technique is, first we have to target, then elevate, reduce, support and fix. What is meant by that? When we identify the depression in the fragment, we have to put the ACL jig, and through the anteromedial cortex we pass the bead pin, and after identifying it we have to elevate with the tongs. That should be very subtle and very gentle, seeing that the articular surface of the tibia doesn't get overly out, and also to take care that the bead pin doesn't damage the femoral condyle. Whatever loose bodies are there, we have to remove it. And nowadays bioabsorbable interference screws are also used for the elevation, and maintaining of the elevation is by the tricortical bone graft. And we can fix with any implant of choice, that is CC screws, buttress plates or raft plates. And the most important point is to stabilize the whatever cortex we have, whatever bone graft we have used, we have to stabilize it very well to hold the fragment. This is an arthroscopy view that you can see. There is a clear depression over there. And with the help of ACL jig, a bead pin is passed at the fracture site. Generally it is elevated with tongs, and it should be always under the C-arm guidance, because by arthroscopy we can see the fragment coming up, but to really see the implant, the bead pins and all those exactly, we require a C-arm support. And this is the joint congruity that can be restored to its anatomy as possible, anatomical as possible. So treating hidden injuries is the key when we use arthroscopy. Meniscus injuries are associated, especially lateral meniscus, in 48%. And in one of the studies in Indian Journal of Orthopedics, it is proven that lateral meniscus tears can also, that creates a good portal for visualization. And cruciate ligament injuries can be treated wherever possible, especially Sherman type 1 and type 2 ACL injuries, and reconstructions are also being done nowadays. So what does the literature say? There is an article in 2006 by Abed Hamid et al., which has showed that the key findings of this study in 98 cases are 71% associated injuries are there, ACL injuries are about 25%, meniscus injuries are 57%, peroneal nerve injuries, we have to be very careful, we have to see for those, which is 1%, and there was no arterial injuries. And arthroscopy, Journal of Arthroscopy and Related by Cheng Zhen in year 2015 has also proved that arthroscopy can be helpful. There is an article by Chiang Zhen in arthroscopy assisted percutaneous fixation, where they have done meta-analysis proving that arthroscopy is a good procedure for fixing specially depressed kind of tibioplateau fractures. This is from Indian Journal of Orthopedics, published in the they have proved that any lateral meniscus lesion can be a good visual, can be a good point to see and clearly see the articular surface. And there is one more paper by Najan et al. In European Journal of Orthopedic Surgery, where they have concluded that arthroscopy procedure is the treatment of, can be a good treatment. This is a comparatively evidence study by Tiang Zhen. It is published recently in 2026 March, where they have proven that most of the good functional outcomes, less complications with arthroscopy assisted. This is total, this is complete literature review showing that arthroscopy provides better fixation, less complications, and may result in better outcomes. So this is a video presentation of my case with type 3 fracture associated with ACL, and this is how a complete setup is there. We clear the hematoma, then we take out with the debris. There was an ACL tear which has been repaired, and the articular surface is elevated by ACL guide and by passing bead pin. This is again rechecked on the C-arm in AP and lateral views. Outer cortex is first drilled with 7, then after adjusting the bead pin, it is drilled with the 10 mm reamer, and tongue is put to elevate whatever subchondral bone is there, and we have to carefully wash the articular surface. but at the same time the ACL also is fixed. Cannula is very important when we are trying to repair the ACL. And he had an associated lateral meniscus tear which has been repaired with outside in technique. So this is the post-op where we have put a raft plate. The articular surface is very much well elevated. This is case 2 where there is a lateral tibia plateau fracture depression, and of course a CT scan is also required to know the configuration and the position of the fracture. This is the post-op X-ray of this is third case where I have put a buttress plate to stabilize this fracture. This is case 4 where there is split with depression. The most important point is to use reduction clamps wherever possible to hold the split, and arthroscopy assisted anteromedial elevation can be through the portal, anteromedial portal can be done, and it is fixed with a raft plate. This is a recent case that I have operated about a week back where I have fixed with a raft plate, and she was a 60 years old lady. So what are the limitations of arthroscopy? Excessive fluid extravasation can lead to compartment syndrome, hence we have to see, always watch, constant vigilance of knee and leg is required. Additional time we have to take about 15 to 20 minutes to drain out whatever hematoma is there. It is a complex maneuverability between fluoroscopy, arthroscopy, various surgical instruments and training of OT personnel. Of course it's a long learning curve, but once we have mastered the technique of knee surgeries, it is a time that we can try to go and fix arthroscopically. So what is the post-op protocol? I put a ROM knee brace for the patient. ROM and knee exercise has started as tolerable. Suture removal after 10 days. DVT prophylaxis for at least 3 to 6 weeks. Partial weight bearing up to 6 weeks and full weight bearing by 12 weeks. So this is the post-op range of movement of one of my patients. We can get a good range of movement, stiffness is very less, and definitely we can get the articular surface as anatomically as possible. So the take home message is, if you are arthroscopically well versed, you can try doing arthroscopy assisted tibia plateau fractures fixation, especially for type 2 and type 3 fractures. But we have to be very cautious for type 5 and type 6. One of the studies they have it was demonstrated for even type 6, but there is every chance of compartment syndrome that we have to be very careful. And wherever possible we can fix the ACL and we can try to repair the meniscus. And once you start doing arthroscopically, you like to do every fracture with arthroscopy assisted. Finally I concluded that the best view comes after the hardest climb, and it is worth it. Thank you very much.
Thank you, Dr. Rajesh, for your lecture on depressed proximal tibial fractures. Now
Thank you, sir.
I invite Dr. P.N. VSV Prasad on topic tibial condylar fractures, bag of bones, treatment with Ilizarov method.
Good evening. Any pointer is there? Pointer is there? No? I thank the organizers for giving me this opportunity. Till now, you have seen regular tibial condylar fractures, but already uploaded. But now you will see a different scenario of of a comminuted fracture which will not fit into any of these classifications of Schatzger and how to treat them. There are at times when in trauma, when we are in a confusion state, what is a better implant? Many of the times, we may not be able to fix to any of the implant that is available in the market. And you will be in a dilemma, what to do, how to solve this, treat conservatively or treat operatively, or what to do. But in those cases, Elizaro comes in hand to help you out or to sort the problem out to the patient and also to you. A 40-year-old male sustained open type 2 injury to his right knee in RTA, came to me 2 days after that, who was COVID positive on arrival. Sent him back with the existing slab and asked him to come after 10 days for surgery. So I do not know what classification, this is what I am saying, I do not know what classification it is like, and you can see total combination of shattering of the upper end of the tibia, all tibial condyles, posterior, anterior, medial, lateral, intercondylar remnants, everything. To my bad luck, he promptly came back after about 12 days and tested negative. No blebs and skin condition is reasonably okay and wrinkle sign is positive. So now what are the options? Any implant anybody can suggest at this stage? I think no implant can hold all the fragments that are there in that, and so I felt that Elizarov is the only answer. And spanning Elizarov fixator has been applied starting from below using ligamentotaxis, gently manipulated the fragments using thick K-wires. A big chunk of medial condyle initially brought under the medial femoral condyle and stabilized with a simple K-wire. You can see a vertical K-wire from medial tibial condyle to femoral condyle. That is the key of fixation, and maintained with thin multiple K-wires, the other fragments. And then spanning has been done by supracondylar addition of ring, and a hinge. After 3 weeks, additional ring has been added to stabilize the condyles, and hinges were applied at the knee and range of movement started. Initially in the previous X-ray it was not there, but now you can see the hinge and ROM has been started. This is to be pointed to where? Okay. At 6 weeks, the ring above the knee has been removed along with hinges and continued with the ROM exercises. And this is the range of movement after removal of the frame, and reasonable alignment and joint surface has been restored. Another case of, go back. 50-year-old male sustained injury in RTA, another case of bag of bones, except a small triangular chunk of medial tibial condyle, which looks intact. A triangular piece of medial tibial condyle looks like intact, but all other area is totally comminuted without any interarticular surface is seen. Next. and Elizarov fixator applied from below, and as patient is very tall, an additional dummy ring was needed. Ligamentotaxis used, articular surface restored with thick K-wires and stabilized with thin K-wires, and this is the restoration you can see. And there was no ring attached at the tibial condyles initially, only ligamentotaxis has been used at the using another additional ring at the supracondylar area. And you can see that hinge has been added and removed, and additional ring has been applied at the tibial condylar level at this time 3 weeks, and removed supracondylar ring and started ROM exercise at 6 weeks. And you can see a very good range of movement, almost 80 to 90 degrees has been achieved. And this is the final restoration, and the range of movement is more than 110 degrees. And another case of severely comminuted compound type 3 fracture, both bones upper 4/5 of the leg with bone loss and fracture patella. And you can see that there is lot of comminution intra-articular and almost shattered vertical splits up to the upper 2/3 and this thing, and only the lower fragment is not comminuted. It took almost few hours to restore and put it into multiple K-wires, and I call it as mighty K-wire. And I could restore initially only the this thing. I was doubtful about even the survival of the limb, and so only K-wires were kept and posterior slab applied, and all the anterior wounds have been sutured. And you can see that there is an elevation on the left right lower thing. There is an elevated plateau, which I could, that is an intermediate fragment or intercondylar eminence area, which I have put my finger in the intercondylar area and pushed it downwards and stabilized with K-wire. And then it got reduced. You can see in this second X-ray almost near normal reduction of the intercondylar area in lateral view. And Elizarov frame has been applied. Once I was sure that the limb is surviving, then Elizarov frame has been applied, and the K-wires have been removed after about 3 weeks, and angulations corrections were made. And you can see almost very good alignment in the intra-articular area, and you can see that there is a lot of bone loss even in the other side X-ray. Next. This is the healing of the wound, and you can see that he is walking, he is using his only stick for walking, even with that much of comminution and intra-articular. Can this video play on the right side? Yes? No? Okay, he is using his stick, and then go to the next slide. If it is not playing. And this is the final outcome with almost only one screw remaining, frame removed, almost at the time of 1 year. I have removed everything, and a very good union has been achieved and a very good range of movement. Another case of intra-articular tibia, upper third, with vertical splits and patella and lateral condyle femur, and you can see a lot of comminution, and it has been femoral condyle has been restored with CC screws. Patella has been vertical split of the patella is also there, which also has been stabilized with 2 CC screws. And this is the Elizarov application. Lot of vertical splits in this also, and ligamentotaxis has given me a very good reduction. And sorry, next. Yes, this is the restoration of the alignment. Next. And this is the range of movement and union at the time of after removal of the frame. and I am skipping this. Okay, next, next, next. So mobility is very important and should be restored at any cost. Even in such badly comminuted fractures, range of movement can be restored, and they may develop OA changes in due course of time, which can be solved by way of TKR at a later date. Thank you.
Thank you, Professor, for your wonderful experience in trauma. Thank you.
Now I request all the speakers to kindly come on the stage. We want to do a small felicitation to you all, organizing team. Sir, Professor always has been a savior of limbs and also the orthopedics department. He was earlier the Tosa president as well. Thank you, sir. కొంచెం ముందుకు రండి సార్. Request the organizing team to also felicitate all the chairmen of this session. Hello. We request, we are going to start the last session of today. As far as the scientific program is concerned, we request Professor J. Venkateshwarlu sir, Professor Radhakrishna sir, and Kranti sir to kindly chair this session. This is it's a special session, Growth, Empowerment, Excel and Elevate, the Rise of Women in Orthopedics. Kindly join sir.
Good evening. Thank you, organizers, for giving us this opportunity of chairing this session. Now I request Dr. Santoshini Nemuri. A welcome note, how far we have come, celebrating progress and envisioning future.
Good evening, everyone. I warmly welcome you all to 4th growth session at Tosa Oasiscon. I extend my sincere gratitude to Tosa body, organizing committee and Oasis for granting us this opportunity, with a special thanks to our respected President Sir, Dr. Ram Kumar Reddy Sir and past President Timma Reddy Sir for featuring this session on CME Day. It is a dream for us since 4 years. So it is a true honor and privilege to moderate this special session. So before we begin, I would like to acknowledge Dr. Chiranjeevi Madam, who is a true pioneer in our field, as one of the first women orthopedic surgeons in Telangana. Thanks once again to our organizing team and colleagues for your continued support. I would like to begin now. This is the growth session. What is growth? This is group of rising orthopedic women of Telangana in harmony. Theme for our session is like rise of women in orthopedics. Myself, Dr. Santoshini. I am pediatric orthopedician, state representative for growth and EC member Tosa. So, how far we have come, celebrating progress and envisioning the future. From creating a space for women to creating a generation that belongs in every space. Story behind growth. It's a small beginning that became a movement now. In 2023, Women's Session introduced at TosaCon during the tenure of our State President Dr. Murthy Sir. His shared vision created a platform where women orthopedic surgeons could meet, learn, mentor and be heard. I don't forget the people who made it possible. With the guidance and encouragement of Dr. Timma Reddy Sir, Kasha Sir, Vijay Bhaskar Sir, Ranjit Sir and many more, their support gave us the idea, permission to become a reality. Initially, we started it as a vote, that is Women Orthopedic Surgeons of Telangana. Then later, with suggestion of Dr. Rujita ma'am, she is a national leader and mentor for women in orthopedics through VOICE, Women Orthopedic Surgeons in India Collective Empowerment Group. 4 milestones. In 2023, we have started Women's Session as vote. In 2024, under organizing team of COSA in Karimnagar. Third one with NIMS as organizing committee. Now we got opportunity with Warangal VOSA and Tosa Oasiscon session. Progress is not one big leap. It is a courage to keep building year after year. So, long back from 2012 to 26, before that also in 1988, Chiranjeevi ma'am has pursued her PG. From 2012 onwards, girls started taking orthopedics. So what has changed from then? A few women looking for a platform, a need to connect, and conversation that is not yet found at home. Now, women are visible across orthopedic subspecialties. They are participating in workshops, faculty panelists, and mentoring. We are invited as speakers at state and national conferences. Next, it is not just participation, it's leadership and not just representation. We have to influence and not just opening doors, holding them open for next generations. Our girls has grown up with confidence, exposure in workshops, conferences, and hands-on learning, mentorship, learning from seniors and becoming mentors ourselves. And every corner of orthopedics is now being pursued, every subspecialty. Invited as faculties and speakers at state and national platforms, and a community, a network that makes ambition feel possible. So the road was laid before us. Every woman who entered the branch before us made the path a little wider. I would like to thank Dr. Chiranjeevi ma'am. Due to her personal commitment, she is not there here. She is a true trailblazer in Hyderabad orthopedics. She is a senior consultant in orthoplasty. And Dr. Banureka ma'am, she is a senior academic and HOD at Kamineni Medical College. Another important example of women occupying leadership, teaching and training roles in orthopedics. So, Dr. Chiranjeevi ma'am, she is our inspiration. She is India's first robotic orthoplasty surgeon, pioneer in robotic joint replacements in India. She is a senior orthopedic surgeon at KIMS Sunshine. She is the former professor at Osmania Medical College. She is a mentor, guide, and role model for generations of women in orthopedics. And she is honored with prestigious Hall of Fame award in orthopedics at Times Health Excellence Awards 2024. And a book was released, Beyond the White Coat. This is like a novelistic biography of Dr. Chiranjeevi ma'am. So I would like to thank Dr. Chiranjeevi ma'am for showing us that dreams have no gender and determination has no limits. Growth is bigger than a session. It is a culture we are building now. Connect, we create genuine professional network across Telangana, make it easier to find colleagues, collaborators and mentors. And we are growing structured mentoring, skills workshop, research and academic collaboration, leadership opportunities, and leading more women as faculty and in committees and leading institutions, research and professional organizations. So we are not asking for a seat at the table, we are building a bigger table now. Our vision for the next chapter as mentor and learn, every woman should have access to hands-on learning and academic opportunity, and to lead, every capable woman should see leadership as an expected destination, not an exception, and every successful woman should make the path easier for the next one. So database of growth, initially we started as 40 members in the group, now it has increased to 205. Almost 165 members have completed their PG and fellowships in different subspecialties. And one small note, our senior Dr. Bhanuprabha ma'am, we lost her. She did her PG from KMC Warangal from 2013 to 2016. And these are few achievements. There is no time for elaborate. Thank you for the people who made growth possible. And we have come far, but this is not the destination. May the next generation look back at us and say they did not just open the door, they made sure we never had to knock. These are few pictures from our last growth sessions. I would like to thank you for the opportunity, and I would like to play a small 30 seconds video. Awesome.
लेकिन हर काम औरत के बस का हो ये जरूरी तो नहीं।
Thank you for the organizing team for giving us this opportunity, and we'll proceed with the session.
Excellent presentation, Dr. Santoshini Madam. Okay, thank you, Madam. Next, I request Dr. Haimavati. The change of face, changing face of orthopedics, empowering women surgeons.
Could someone help me with this?
Brian.
Good evening, everyone. I thank the growth mentors and Tosa organizers for giving me this wonderful opportunity to give this talk on the changing face of orthopedics empowering women surgeons. Hi, I'm Dr. Lakshmi Haimavati. I am practicing as an assistant professor in Surabhi Medical College, Siddipet, and I'm currently working as a spine surgeon there. Earlier, the question was if women belonged in orthopedics at all. The face of ortho, I believe, is changing because now we are asking more important question, that is, how will ortho look like if women start belonging at every level? As Santoshini ma'am has already addressed earlier, the specialty was considered as not for women. It was maybe a little gender biased, but seats were taken only with courage and often without any roadmap ahead or without any proper mentorship or any idea of what we are getting ourselves into. So those first women like Dr. Chiranjeevi ma'am for us has made the impossible visible. Surely now many women are entering surgical training, that is happening, but numbers are improving. That doesn't mean equality in numbers means progress, right? The aim shouldn't be simply equality of entry. I believe it should be equity in opportunity and respect and also influence. Women bring diversity to this field, I believe, with their extra empathy, resilience, emotional intelligence and innovation. But if at all we are not giving them more leverage and more opportunities, half of this talent will be underused, and that will lead to a monotonous society, I believe, with growth being very stagnant. So the specialty loses more than numbers, it will lose the imagination. As ma'am has already addressed, I think for even girls, we shouldn't always think the doors are closed. We should start, it is always the door nobody tells you is open, because there's so many barriers, I think, in our thought and are also in reality. And some of these barriers are this unspoken rules about cases allotment and fellowship recruitments, where we ourselves are, I don't know, we are not going for those opportunities, I believe. And there are informal networks where some decisions are already made. But I think as women, we are always pushed to keep proving our legitimacy that we are worthy of the opportunity.
And also, maternity is one big issue that cannot be blindsided. This happens during the crucial career years, especially for women. So what happens is, with family responsibilities and all, the training milestones often collide. And this translates into career penalty. And I think that is one thing we should start addressing. The perception bias, where the capability is often judged when it comes to women, even before the performance is evaluated thoroughly. The networking gap, where certain important conversations happen in spaces where women are either absent or they're uncomfortable or unheard or sometimes uninvited. And the biggest issue is the sponsorship gap. Here the opportunities often follow revenue generators. I think the onus is upon us to start changing it by changing our existing circles of networking and also increasing our visibility in the market. This is not any allegation, and I am not trying to show this as a weakness of women here. I think this is a design problem. So a mature specialty like orthopedics could come up with some solutions to solve it. As women, these platforms of, say, conferences are giving us an opportunity to participate, right? So more sessions like Growth Women sessions is giving us more visibility. And this, with time, we have to improve our credibility so that our voice translates into influence and starts bringing about the change we want. So representation, I believe, is just the beginning of it, but our influence should also change have influence on any policy changes, or it should be heard. So how can institutions step up to this? Could be some of the solutions we want is, if at all recruitment happens more intentionally, creating a diverse candidate pools and promote transparently where there is no bias in promotions, using clear criteria for our advancement, and definitely giving more equity leverage by sponsoring us deliberately. By that I mean recruit women deliberately into the roles and into those opportunities, and build flexibility, like for example, anything of maternity or any choice of career gap shouldn't end up being a career penalty for any of us. So this inclusion cannot be a woman's burden alone, and we cannot ourselves take it upon us to change the entire system. Now this becomes everybody's responsibility. But I think, as there are many students here I see, so see, what we can do for ourselves is we have to step up, ask for that case you want to do, ask for that fellowship you want to pursue, and ask for that podium presentation and that committee role if you think that is going to leverage your visibility. And document your work, audit it, publish it, present it, and teach it. Build your peer circles not just in your institute level, in your state level, but across states and languages and even institutions. If we start mentoring students early, I believe they will stop quietly opting out or giving upon themselves, okay? So, and whoever is in a very successful position, to all our mentors who have given me the opportunity, I think they gave me that space where I could grow in my own capacity. So I believe the success should create space and not distance, so that the next student should not have to discover that the door is already open. So these sessions and all are giving us a sense of belonging, sure, but women belong in every sector, like clinical, academic, or even leadership roles. But equity becomes a system responsibility, and visibility eventually will translate into influence. So step up for all the presentations, or step up and try to increase your visibility like that. And understand that if anyone, like even Santoshni ma'am or Chiranjeevi ma'am, all they have done is they saw that the door was open, but what they are doing is they are trying to open the door wider for us, and I thank them for it. Thank you all.
Lakshmi Haimavati, for your talk on the challenging phase of orthopedics. Now I call upon Dr. Mrudula for a talk on Beyond Strength, Skills that Make Great Orthopedic Surgeons. Dr. Mrudula.
Yeah. Good evening, one and all. Good evening, everybody. I'm Dr. Mrudula. I'm a consultant pediatric and orthopedic surgeon and a trauma surgeon. I work at Kim Sunshine Gachibowli and Arid Hospitals Gachibowli. My topic for today is Beyond Strength, the skills that make great orthopedic surgeons. So, orthopedic surgery requires more than physical endurance. Surgical success is a blend of technical precision, which is hands, intellect, which is brain, and empathy, which is mind. Great outcomes rely on a blend of all the three. Now, surgical and technical skills. So, spatial awareness, visualizing complex 3D bone anatomy from 2D scans. So, generally we get X-rays done in your OPD, but for you, you should not see only your tibia fibula, but you have to also see the surrounding ligaments and explain it properly to your patient. Surgical precision, making proper incision and cuts and placing hardware perfectly. So it is more about your precision and skillful cuts, which is more important than your hardware stuff. Then hand and eye coordination, operating smoothly via tight and microscopic viewpoints, which is very, very important for arthroscopic surgeons and laparoscopic or endoscopic spine surgeons. Coming to physical stamina, you should be having physical stamina to maintain steady hands during your multi-hour procedures, and have the skills to have that adaptability, which is like shifting your tactics instantly whenever the surgery requires an alternative procedure, that is requiring your presence of mind during the intraoperative period. Then remember, it is always precision over force. Now comes the critical thinking and decision making, which is your brain. Diagnostic accuracy, identifying the root causes among the overlapping nerve or joint pains. So just don't blindly rely on your radiologist report. Whenever you find something important, you should be able to read your MRI and also try to get trained in reading ultrasound reports. Clarify it with different radiologists. You should have a vision what is going on inside the patient body. Risk assessment, correctly choosing between immediate surgery versus physical therapy. So it is not that just because the patient has an IT fracture, a PFN has to be put. It depends upon your physical status, it depends upon the financial status, it depends upon your age criteria. Calm under pressure, keeping complete emotional control during sudden complications intraoperatively is the main important thing, which even I don't have. So important preoperative planning should be done. And custom problem solving. So custom made treatment plan should be made for non-standard fractures or deformities. Next, communication and patient care, which is the human element, the mind. Empathy, which is very, very, very important. Calming anxious patient facing life-altering mobility issues. So if it is a femur fracture, it might be just a nailing case for you, but it is 3 months of bed rest for the patient. So you should be very empathetic to the patient when you're talking. Just don't talk like this is an X-ray, okay, we'll have to fix it. But you have to talk about the months of loss of schooling or the months of loss of work he's going to have. Clear explaining, translating complex biomechanics into simple comforting terms. So if a patient comes with ACL tear, just don't tell it's an ACL tear. You have to show a knee model showing this is the ligaments, this is how your instability happens. So he should be able to understand what is going on inside. Team leadership, which is very important, directing your nurses, tech staff and the anesthesiologist seamlessly is very important. And bedside manners, keeping patients motivated throughout long painful rehabilitation phases is really important. Okay, now what else do you need? Is it only about your hands, mind and brain? So this is all about the patient. So now what about yourself? Professional habits and lifelong growth. You should know how to future-proof your practice. Then continuous learning. So orthopedics is always evolving. So we should know how to master the new robotic arms, navigation software, lasers, and what are the new innovative things happening within the subject is what we'll have to always get trained. Then ethical judgment, prioritizing patients' well-being over experimental or complex tech, which is even more important. Time management, balancing your trauma calls, clinic hours and intensive paperwork, where all the three are important and really important. Then growing your social media presence, which is an important topic again. With growing competition, making your presence felt has become really important. Anything else, ladies, girls? So skill to manage your family and career, which is very, very important. Okay. So balancing your work along with a good family time is really important. So career versus kids, it is never career or kids. So remember that, married ladies especially. So question yourself every year, if you continue the same career path, where would you see yourself in the next 5 years? So if you're an SR, is your goal to become an AP? If you're an AP, if your goal is become to an associate professor. Or if you have a clinic, what do you want to do next? You want to build up a hospital, you want to increase your clinical practice. So what next should be there at the end of every year? Draw your boundaries everywhere, in your house, in your workplace. Then always, girls, hire help. There's nothing wrong. Use your effective time for the betterment of your career. Strength training, which I seriously suggest all ladies. Include it in your daily routine, not that you're an orthopedic surgeon, but to be a better person than your peer group. So what does an orthopedic surgeon, what is the difference between an orthopedic surgeon and an elite orthopedic surgeon? So it is not about your physical strength. So physical strength only builds the foundation, but technical, intellectual and human skills builds your legacy. Balancing strength and skill gives you an excellent patient recovery. Thank you.
Thank you, Dr. Mrudula. You gave just excellent talk. This is common for both male as well as orthopedic surgeons and beautifully she narrated to women, orthopedic, like as for family care, etc. Good, nice talk. Then I call upon Dr. Madhusmita for radiation safety and protective innovations.
Good evening, respected chairperson, eminent faculty and my dear colleagues. Today I'll be talking about a hazard that is invisible, cumulative and painless, yet it is available with every orthopedic surgeon who deals with CM, that is radiation exposure. Myself, Dr. Madhusmita Sahu, currently I am pursuing Arthroplasty Fellowship at KIMS Sunshine. So radiation in the OR room, it is an invisible occupational hazard. So in the roadmap, what are the issues we see? Why radiation safety is still an unresolved crisis in the OR? What is scatter radiation? What are the effects, that is deterministic or stochastic effects? And what is gender specific risk, that is breast cancer in female orthopedic surgeons? And as low as reasonably achievable principle, that is time, distance and shielding. What are the protective innovations coming up like lead-free personal protective equipments, dosimetry and robotics? So here we are understanding the threat. Scatter radiation is a real enemy. The C-arm X-ray tube produces the primary beam, but it is a scatter part of the patient and the table that irradiates the surgical team. The primary surgeon is at the highest risk of exposure. Eyes, thyroid and exposed scene are the most vulnerable sites, and at 2 meters of distance, the scatter beam becomes virtually negligible, and it is a preventable thing. So here, radiation causes harm in two ways. Deterministic effects, it occurs above a threshold value. Severity increases with additional exposure like skin erythema, cataracts, hair loss, sterility issues. It is preventable, largely a function of cumulative dose control. Whereas the stochastic effects, no minimum threshold, random in nature, not severity graded, linked to teratogenesis and carcinogenesis. It includes DNA damage that elevates cancer risk over a period of time. So the ICRP says the critical safety thresholds, like when the exposure area is to the whole body, we should have an annual dose limit of 20 millisievert per year, averaged over a period of 5 years. Whereas it is, when limited to the eye, it should be 20 millisievert per year. When skin and extremities are involved, it should be like 500 millisievert per year. And when a person is in pregnancy, fetal exposure, we should have less than 1 millisievert in each pregnancy. And no single month should exceed 0.5 millisievert. So what is the awareness gap? In multiple studies we saw there is no formal CM training before you use it, around 66.7%. In 73% we saw no training on radiation safety. 77% we saw they are unaware of the issue. And 70% there is lack of up-to-date facilities which are available with us. So here are the two articles which study has been done among US female orthopedic surgeons, where we found the gap is around only 24.2% regularly used dosimeters. 60% related radiation safety trained are unsatisfactory. Only 36.4% had correctly fitted lid protection, whereas 56% expressed concern about radiation health issues. Whereas another article states fertility issues around 17%, 38 to 39% experience pregnancy complications like preterm birth, and miscarriage issues in around 40% of the female surgeons. So the groups needing special consideration are the trainees, residents, pregnant surgeons, female surgeons, that is the apron gap. What is that? Standard lead aprons leave an axillary and lateral chest gap. Breast ductal tissue is highest radiosensitive in those areas, and we need prompt purpose-built designs. Why standard aprons fail the female surgeon? The unprotected zone, fit is protection. A well-fitted gown is a clinical necessity for every female orthopedic surgeon. Position matters. Exposure to the upper outer quadrant is highest during cross-table lateral X-rays. Lead sleeves and axillary supplements significantly reduce those exposure. So this is the vulnerable area which I was speaking about, upper outer quadrant, and we need very much PP protection like axillary supplements to preserve from radiation exposure. And for fetal protection, pregnant surgeons require deliberate case selection, distance tracking, and reinforced double shielding. So in general, there is 2.9 times higher risk for female orthopedic surgeon for breast cancer when compared to baseline female population. And the default PP we have lacks all the axillary sleeves protection. So the most vulnerable being the pregnancy gap, 82% receive no real-time radiation monitoring. 41% receive no individual risk assessment. 41% report insufficient education regarding how we can prevent ourselves, whereas 36% offer no outside how can they work beside the fluoroscopic rooms. So the most important is the ALARA principle, which includes time, distance, and shielding. We should reduce the fluoroscopic time, we should increase the distance at least 2 meters, and we have shielding proper PP aprons. What are the protective innovations worth adapting? Like we can have lead sleeves and axillary supplements, Rampart and Protigo. These are engineering system nowadays coming on. These are mobile lead barriers rather than PP support. These are mobile lead bearings which comes in between the screen and the operator, so that the huge weight of PP aprons can be avoided. Whereas real-time personal monitors, dosimeters should be attached head up so that the surgeon gets a real check. How much is the radiation exposure? And lighter lead-free apron, like we can use beside lead, antimony, smith, other ergonomics-based materials. So they are light-free. What are the checklists for every female orthopedic surgeon? You should have your own personally fitted PP aprons with goggles, thyroid collars, vests, wear 2 dosimeters, collar outside the lid and near the torso. Book your annual eye checkups. Maximum cataract cases have been also observed in yearly checkups. Declare pregnancy early and always have a real risk assessment rather than being very late. Add upper outer quadrant protection, layered lead sleeves, use time, distance, shielding effects in every case. Know your numbers, how much you have been already exposed. Have your dose reports checked. Push for training. Ask your organization for radiation safety programs and formal orthopedic curriculum and regularity for occupational health risk. What is the future of protection? It should be a smarter, lighter and safer way. We must move beyond from the conventional communal lead aprons towards active monitoring and zero weight wearing aprons. So these are the real-time dosimetry head-up displays. It tells up actively how much for every case the dose you have been exposed. And these are the mobile bearing ceiling based monitors which are being upcoming. And these are the newer your B-spotted fitted aprons which are coming up. So the beam will always be there. It will be always prevalent. Our vigilance is our choice. We should know our numbers, practice, time, distance, follow protective innovations, mentor the next generation for a safe occupational path. These are the latest protective innovations which we have already discussed. Thank you.
Nicely spoken, Dr. Madhusmita, and good information given.
Thanks.
I next welcome Dr. Harika to give her speech about challenges faced by women orthopedic surgeons in India. Welcome, Dr. Harika.
Permission of the chair, I make a small announcement. It's last 15 minutes for anyone to go for TGMC registration. If someone has not got it done, I request all of you to go to the respective stall and get it done. Thank you. Stall B34.
Can I start, sir? Okay. The year is 2026. A record number of female students are entering the medical field. But when it comes to the orthopedic specialization, the numbers are very few. Why? So, good evening all. I'm Dr. Harika, working as an assistant professor in Gandhi Medical College, Hyderabad. Today we're going to discuss the challenges faced by women orthopedic surgeons in India. So what is a challenge? It's a difficult task that tests your skill set. Now, there's a lot of literature and awareness around this topic, but then I thought, why not? Let's do a real-time survey. So, why the need for a real-time survey now when there's already literature? Let's think of this real-time survey data as the bridge that is connecting the gaps from what we already know to what we have to go to. So we really conducted a very quick 100% anonymous survey over 1 week duration, and this was done from August 13 to 28th, just before the growth session, the Tosa conference was started. It was circulated among all the female orthopedic surgeons who are a part of the voice group and growth group WhatsApp communities, and a record number of responses, 204 responses were recorded in just 1 week. You can see the data speaks for itself that a vast majority of the respondents are under the age of 40, which is reflecting the surge in the number of female orthopedic surgeons which are entering the field now. From Kashmir to Kanyakumari, this survey captured a wide, diverse geographic cross-section of women practitioners across the country. The majority of them are from Telangana. Though this survey represents a localized form of representation from Telangana, it gives us a candid snapshot and it gives a concrete evidence of the challenges being faced. A lot of other states have also responded, but in minor numbers. Most of them, almost over half, are currently in their training period as the postgrads, senior and junior residents, highlighting the crucial period where mentorship and support systems are most needed.
Most of them, up to 39% of them are in government institutions, 27% are in self or private practice, the remaining are in corporate sectors and deemed universities. While general orthopedics dominates, women are actively participating across all the major subspecialties, including trauma, plasty, pediatric orthopedics, arthroscopy, and sports medicine. The core issue. 76.6% of them faced difficulty during training when they were asked the question, did you face difficulty during your training years based on your gender? This is a staggering majority, which has confirmed that gender has played a direct role in the hurdles that they have faced while they were acquiring surgical skills. The mentor confidence gap. Nearly 60% of the respondents explicitly agreed that their mentors lacked confidence in their surgical abilities compared to their male counterparts. Some of the discouraging myths, almost up to 80% of them have heard this. Requires physical strength to be an orthopedician, it's a male-dominated branch, it's not suitable for women, and family life will definitely be affected. A combined 72.9% either required a break from work or strongly considered taking a break due to overwhelming systemic challenges at workplace. It's very interesting to note that 49% of them have responded positively, saying that their values, decisions, concerns were valued equally like their male counterparts. But if you see, more than half of the respondents felt that their voices were either actively ignored or silenced by the fear of professional retaliation. Now, standard hospital equipment is rarely designed with female ergonomics in mind, leading to severe physical discomfort and long-term occupational hazards. Combined with this ill-fitting lead aprons, the high concern regarding radiation exposure points to an urgent need for the better protective gear specifically tailored for women. There is a mixed responses here. Neutral, a lot of them are neutral when you ask them the question, do you think physical strength in the OT is demanding? A mixed response was seen again when the question was asked whether you were criticized for the duration of surgery taken. While the physical speed may be occasionally criticized, the precision and outcomes of the surgery remain the primary focus. This is the advantage of getting a real-time data and a current survey. Everyday microaggressions. Most of them, almost all women will be mistaken for a nurse or an assistant and never as a consultant or a senior. There are microaggressions on a daily basis where their confidence gets undermined. Sometimes the patient prefers a male surgeon over a female surgeon. Most of them are overworked, overburdened with little or no help and are excluded from decision-making process when it involves patient care. We asked them a question. Do you think the society's perception that ortho is specifically more suitable for men? If you see the pie chart, it speaks for itself. Most of them strongly disagree. There's almost a quarter of them which either agree that, yeah, maybe. Now, seniors within the profession are the highest source of active discouragement, pointing to deeply ingrained institutional biases. Many of them have reported that they have less time for self or with the family. It's very encouraging to see that 32% of them have reported that it had had no impact on their personal life. 25% of them have reported delayed marriages, delayed in family planning, and 16% of them have considered changing their specialty. Institutional support and infrastructure also plays a major role when it comes to women inclusion. It is disheartening to see that less than 5% of them were having childcare support and nursing rooms, and there was no clear maternity leave policies or dedicated restrooms for the women. 59.3% strongly agree that a female orthopedician would be a better role model for young female orthopods. Shared experiences provide a blueprint for navigating a male-dominated field. Because of time constraints, I didn't include the other graph where the question was specifically put. Do you think the gender of the mentor plays a role in mentorship for the mentee? And almost 90% of them disagreed that the gender of the mentor is not important for mentorship. Now, when we ask them, what do you think is the most needed support right now for you guys? The primary demand is not for special concessions, but simply for equal access to operating table and structured guidance. We had 4 open-ended questions and let them respond in short paragraphs. One of the questions is, what is the biggest challenge encountered after choosing orthopedics? I summarize them, and it is constant scrutiny, facing discriminatory access to hands-on surgical exposure during training years, and the dual demands the pressure of balancing active career with motherhood or your personal life. Then we asked them, what do you think is the biggest challenge for women in orthopedics? 3 major themes have stood out: stereotypes, second-guessing women's strength, capabilities, bias systems, which is very difficult when you're already dealing with the technical difficulties of orthopedics. You don't need another hindrance in the form of an inherently gender bias system. Glass ceilings, confronting severely limited leadership representation, making career advancement exponentially harder. We asked them, what would be the one change that you would recommend? All of them, this was a very interesting narrative, and it stood up under 4 strong headings. 1, merit-based equal opportunities, fair surgical exposure during training years, structured mentorship, institutional support via policies for infrastructure and supporting a diverse workforce, and zero tolerance, enforcing strict, uncompromising policies against discrimination, harassment, and toxic behavior. We asked them to share their experiences, let it be positive, negative, or a learning experience. The key positive points that stood out were strong peer network, supportive mentors, and profound growth and immense satisfaction from positive patient outcomes. Recurring concerns stood out to be gender discrimination, exclusion or being sidelined, and toxic work culture. I would like to conclude by saying, ultimately, competence commands respect, mentorship matters, resilience is essential. The passion for orthopedics is gender neutral, but the challenges are not. The barriers are architectural, not biological. So what is stopping us from dismantling these architectural barriers? The future of orthopedics is not male or female. It is precision, perseverance, and presence of mind. Thank you.
Well spoken, Dr. Harika. I think your challenges were heard by many of the seniors as well, and will be taken care of in the future. And I think you women surgeons are a guiding force and inspiring light for future generations to come. I request Dr. Sabha to come over and make her speech on unlearning the superwoman syndrome. Welcome, Dr. Sabha.
Good evening, respected dignitaries on the stage and off the dais. I'm Dr. Saida Sabha, and I'm assistant professor in Apollo Medical College, and currently I'm doing a fellowship in hand surgery at Apollo Hospital. So a few days back, I got a call from Dr. Santoshni ma'am, and she was asking me regarding, like, are you available to give a talk in this particular session? To take her call itself, I was busy. Then I just called her back, and then I asked her, like, ma'am, you called me, and what was it regarding? Then she told me, we are going to have a session on women orthopedics, and you will have to give a particular talk. When I got to know what the topic is, I was myself wondering, unlearning the superwoman syndrome. Wow, what is superwoman? And did we ever discuss about this? So then I thought, okay, I should actually go ahead and do some research and do what can be done to help our fellow colleagues. So I would like to ask my female colleagues here, how many times when you are asked, how are you feeling, what is your answer? Many of the time we just say, we are doing fine, because we don't want to appear weak. I would like you all to go through this checklist. How many of you have been through these questions, and what is the real answer you give? How many times have you said yes when you wanted to say no for a particular thing? You have worked despite being exhausted, and you have felt guilty when you have taken time off for personal reasons. And how many times have you genuinely compared yourself with a fellow orthopedic woman surgeon who you think as per your standards is doing better than you, but their perspective might be different? How many times you have considered answering to your patients or calls from the ward or a consultant even after working hours, and you felt guilty about family when you're at work, or vice versa? So, and despite all this, you still think, I should be doing more, I should be putting some more efforts, right? So if you think you have done at least more than four of this, welcome to the Superwoman Club. Congratulations. So normally your daily routine start with getting up early than the rest of the family members. You have to wake up and do your preparations, go to the hospital, do your rounds, then come to the OT, then followed by OP, then focus on your academics, your research work, or your marketing, all these things go on, similar to your male counterparts. Then you also have to give time to your family. That comes last for most of the people I know. And still when you get time for yourself, that's around the last hour of the day, you will still think, tomorrow I need to do better. Today was not enough, right? And somehow we call this normal. I would like to tell about rule of 3. Imagine you have a glass and first drop you put is expectation. Expectation that you should be able to manage everything on your own. That's good. Second drop when you add, that is drop of guilt. That if I say no, I will be letting my team down. We have that thing in our mind. We are very guilty to say no. And when you keep adding similar drops of perfectionism, that we have to be flawless. We are not bound to make mistake. We should not give any chance for anybody to say anything against us. That's how our mindset is. So similarly, burnout happens. It doesn't happen by a single massive crisis. It is a result of such small drops which collectively overburden us and make us down. What do I mean by being strong? It is a very strong word. Strong itself, you can see, is a very strong. There are multiple definitions. We all know of being strong. But what I would like you to know is what is not being strong. Strong doesn't mean you have to be silent. It doesn't mean you have to be available 24/7. It doesn't mean you can never ask for help. Strong doesn't mean you can never make mistakes. And strong doesn't mean you have to do everything on your own, especially when you have a supportive team and good colleagues. Strength is knowing what deserves your energy and put exactly towards it. I would like to use one example. Suppose I have a case posted for surgery. For the better understanding, I will just go for trauma case. And when preparing any, for example, there's a tibia nailing case posted. And a surgeon, we have like all instruments in the OT. So I have Chanley's retractor, I have spine instruments, and I have scope instruments. Just because I have it, do I need to carry all of them for the case? No, right? I should be carrying only the thing, and carrying all the instruments for that case, does it make me a better surgeon? No, because I need to carry what is required for that particular case, that will help me deliver the surgery better and make me a better surgeon. And good surgeons don't use every instrument, they choose the right one. And if you are getting my point, this is not about surgery or being the surgeon. It's about the qualities which you carry in your hospital or surroundings and give the correct importance at the right time. So we work in a society where there are double standards, and if a man is confident, that is termed as leadership. And if it's the same with the woman, she seems too aggressive. If a man is very busy, it's considered he's very important. But if a woman says the same thing, they term as she doesn't have any time. And if a man is being very assertive, that is he's decisive. But with females, she's too difficult to deal with. All such terms we have to deal with. And if a man delegates, he's termed as very efficient. But similarly, if a female does that, she's termed as she's not able to do things on her own. That's how the society is, sadly. Same behavior, but different interpretation. But do we need to take that pressure? We should be sufficient to take control of our future, and we should not be affected by the society. What if I don't have to prove myself anymore? The moment you start following this, no perspective of others will let you, fail. So let's start unlearning. Try to change the prospect of I have to do it all to I have to do what matters, what actually is important. Instead of saying I must be perfect, try to say I must be competent and not flawless. it should not be like I cannot ask for help. Definitely, we can take help of our colleagues, or juniors, or seniors, because great surgeons build great team. Be the change. Ditch the old superwoman, which was termed as who can do everything, never complain, never fail, never say no, and who can carry everything flawlessly. No, that's very old school of thought. You have to prioritize things, delegate properly, collaborate, and you have to set boundaries. You can ask for help. You can make mistakes. You can learn, lead, and ultimately live your life. Not less, being strong doesn't mean less powerful. This is just a better way to be sustainable. I want you all to be strong, be kind, be ambitious, but first of all, be a good human. Try to say no to things which drain our energy and doesn't add any value. You can say things, you can make things wait which are not much importance. And yes, only to the things which are of utmost importance. I would like you all to give yourself permission to say no. You can ask for help. You can make mistakes, learn from it, and try to become a better person, a better surgeon. You are allowed to take breaks. You can aim for more. You can aim for the sky. But you just be satisfied and just keep on working towards progress. Perhaps sometimes women don't need motivation. They need some permission so that they can change something within themselves, so that they can work for a better environment and better future. We don't need superwomen. We need women who can lead without losing themselves. Thank you.
Thank you, Dr. Sabha. And I think most of the speakers have completed or finished their talk in time, maintained the timings. So women surgeons, they know value of time. And I have a recommendation. I recommend organizers hereafter, from next Tosa onwards, or the Oasiscon onwards, I request 1 or 2 orthopedic women surgeons to chair this type of sessions, so that they can add some suggestions, or they can add some points to their presentations and for their well-being and for their growth. Thank you all very much.
Finally,
I request all the...
Finally, I would like to end saying, Ma Durga was the vision of, idol of empowerment. So, we need not give our women surgeons any need for empowerment. They are empowered themselves. They should inspire the future generations more and more.
Born with empowerment. Now, I request all the speakers to come on the dais and take the felicitations from the organizing team. Request Srinivas Reddy sir, Maheshwar sir. వచ్చిందట. small announcement. All the delegates, post the inauguration, vehicles will be arranged from here. We have an inaugural dinner at Vajra Gardens. Request all of you to join us. Take that facility and reach that venue of inaugural dinner. Thank you. Now we will felicitate the chairmen of this event. I request all the women orthopedic surgeons and postgraduates to come on the dais along with the speakers and panelists here. All of you, postgraduates, request all of you girls to join. Quickly, now you have heard an hour of women empowerment. You should be very quick now. Young doctors, I wish they would come in the center. Youngest team, volunteers. Go in the middle. Go. Postgraduates, orthopedic postgraduates, women's. And madam. Join. Madams. You don't want empowerment, you are staying there. Outstanding. Hurrah! Thank you, everyone. Shall we all proceed with the inauguration of Tosa Oasiscon? So we start this program with a welcome dance. Few of the children of our orthopedic surgeons are performing for you. అంతే సింపుల్ అంతే కోఆర్డినేట్ చేసుకో First in the program is a dance by baby Roshini. It's a welcome dance. Anyone standing outside the hall, I request all of them to come into the hall. The inauguration of Tosa Oasiscon 2026 is about to begin.
मूषिकवाहन मोदक हस्त चामर कर्ण विलंबित सूत्र वामन रूप महेश्वर पुत्र दीन विनायक पाद नमस्ते मूषिकवाहन मोदक हस्त चामर कर्ण विलंबित सूत्र वामन रूप
Excellent, excellent. She is a daughter of our orthopedic surgeon, Dr. Ramakant from Warangal, sir. Next dance is by Baby Hershey Krishna. Arushi. She is a young daughter of Krishna Kant. Today is her birthday and she has delivered a wonderful dance exhibition for us. She has completed her 6 years and turned 7. God blessings to you, beta. The next performance is by a medical student, final year medical student, Miss Aditi. I request Aditi to come forward.
पुष्पांजलि अखिलांडेश्वरी अंब परमेश्वरी सर्वाणि रुद्राणि भवानी पुष्पांजलि अखिलांडेश्वरी अंब परमेश्वरी सर्वाणि रुद्राणि भवानी पुष्पांजलि 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 अखिलांडेश्वरी आमा गामा री गा सा निगम पुष्पांजलि अखिलांडेश्वरी पामा गामा री गा सा निगम पुष्पांजलि अखिलांडेश्वरी पद पमगरि दप मगरि सा गरि सनि दप गनि सरि ग म पद पमगरि दप मगरि सा गरि सनि दप गनि सरि ग म पुष्पांजलि अखिलांडेश्वरी वेदमुలని बहुशाखలతోడ విలసిల్లినై సభాసదులకు వేదములని బహుశాఖలతోడ విలసిల్లినై సభాసదులకు వేదములని బహుశాఖలతోడ విలసిల్లినై సభాసదులకు కవినట గాయక సాహిత్యములో ప్రతిభగాంచిన కళావేత్తలకు వేదములని బహుశాఖలతోడ విలసిల్లినై సభాసదులకు కవినట గాయక సాహిత్యములో ప్రతిభగాంచిన కళావేత్తలకు పుష్పాంజలి అఖిలాండేశ్వరి పుష్పాంజలి అఖిలాండేశ్వరి అంబ పరమేశ్వరి సర్వాణి రుద్రాణి భవాని పుష్పాంజలి 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 అఖిలాండేశ్వరి అంబ పరమేశ్వరి సర్వాణి రుద్రాణి భవాని పుష్పాంజలి దివ్య పుష్పాంజలి నృత్య పుష్పాంజలి
Excellent, Amma. Excellent. Very good. We appreciate you, Aditi. You're continuing your efforts in pursuing this dance. May I now take the privilege of felicitating the 3 young girls who participated in energizing the moments of this event, Tosa 2026. May I now request Oasis President Dr. Krishna Gopal Garu to come and felicitate the first dancer. I request Oasis Secretary General Dr. Roshan Kumar Garu also to come onto the dais and join the team here to felicitate baby Arushi Krishna. Wish her on her birthday too, sir. I think she needs lots of kisses. Her father needs to join her. Krishnakant, kindly join them. Pragya, come up. She's Dr. Pragya, our IMA girl here. Kindly join her. I request Tosa President and today's organizing secretary and the team to felicitate a medical student, Miss Aditi, a final year MBBS student. Thank you, Maditi. Bear with us, we'll give a soft music for you now. We are arranging the dais for the inauguration of the event and all the dignitaries will be here soon.
his love for you is true. But does he know you call me when he sleeps? Or does he know the pictures that you keep? Or does he know the reasons that you cry? Or tell me, does he know where your heart lies? Where it truly lies?
Good evening all.
We welcome you all to the inauguration of this prestigious Tosa Oasiscon 2026. We have witnessed the wonderful dances by the kids. Now, we call upon the dignitaries onto the dais. President Oasis, Dr. Krishna Gopal Ramurthy Garu from Puducherry. President-elect Oasis, Dr. P. Vijay Chandra Reddy Garu from Warangal. Secretary General Oasis, Dr. Roshan Kumar Garu from Karnataka. President Tosa and Organizing Secretary, Superintendent of MGM Hospital, Tosa Oasiscon, Dr. K. Ramkumar Reddy Garu, one and only dynamic leader here. Give him a big applause. He is responsible for this wonderful event. Secretary General Tosa, Dr. Jagan Mohan Reddy from Hyderabad. Please welcome, sir. President-elect Tosa, Dr. Alwal Reddy Garu from Hyderabad. Our senior and our big brother. Our guru, our mentor, past President Tosa, Dr. Timma Reddy, sir. President IOA, Dr. Naveen Thakkar from Gujarat, and Secretary IOA, Dr. Rajiv Raman sir from West Bengal are unable to come and they have sent their video messages. Now I invite special invitees. Guest Rajendra Reddy sir will be here in a few minutes.
He consented to continue the program.
Yeah. He has given the consent to continue our program. He will join us shortly. Guest of honor, Principal Kakte Medical College, our beloved Mohan Das sir. Immediate past President Dr. P.N. Vasudevan from Kerala. One more guest of honor, Superintendent, MGM Hospital, Dr. K. Ramkumar Reddy sir. Senior Vice President Oasis, Dr. Shivakumar sir. Vice President 2, Dr. Ashwin Kumar Singh sir from Karnataka. Now I invite the President and Secretaries of all member states, Dr. U. Venkatramana sir, President OSAP from AP. Dr. Vijay Krishna Reddy Garu, Secretary General OSAP, Andhra Pradesh. Dr. Sachidananda Rai, President KOA, Karnataka. Okay. Dr. Sachidananda Rai sir, President KOA, Karnataka. Dr. Harish Murthy, Secretary General KOA, Karnataka. Dr. Subin Sugat, President KOA, Kerala. Dr. Subin Sugat sir. Dr. Ansu Anand, Secretary General KOA, Kerala. Dr. M. Prakash, POA, President of Puducherry. Dr. Bhuvanesh Gopal, Secretary General, POA, Puducherry. Dr. Bhuvanesh Gopal, Secretary General, yes, already come. Dr. S.R. Sundarajan, President TNOA, Tamil Nadu. Dr. S. Marimuthu, Secretary General TNOA, Tamil Nadu. request everyone to stand up for the prayer. Ganesh.
गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
Thank you. Now I request our organizing chairman, Oasiscon, Tosa Oasiscon, Dr. P. Vijaychandra Reddy garu to give his welcome address.
Yeah, good evening to all of you. The President of Oasis, Dr. Krishna Gopal Garu, Secretary General of Oasis, Dr. Roshan Kumar Garu, and today's guest of honor, Principal of Kakatiya Medical College, Dr. Mohandas Garu, and my organizing, Secretary of Organizing Committee, and also President of the Telangana Orthopedic Surgeons Association, and also Superintendent of MGM Hospitals. It's a multifaceted personality, Dr. Ram Kumar Reddy. And Secretary of the Telangana Orthopedic Surgeons Association, Dr. Jagan Mohan Reddy. and other dignitaries on the dais and off the dais. It's indeed my privilege and honor, I feel, to be bestowed on the Warangal for giving an opportunity to host this type of mammoth conference, Oasis. And more important is that we have clubbed this time with Tosa, that is Telangana Orthopedic Surgeons Association, and Orthopedic Association of South Indian States, named as Tosa Oasiscon 2026. I welcome all of you from the delegates of the Warangal, Telangana Orthopedic Surgeon, Department of Orthopedics of Kakatiya Medical College and MGM Hospital, to all the dignitaries who have travelled all together from Kerala, from Tamil Nadu, from Andhra Pradesh, Puducherry, Karnataka, and different parts of the Telangana maximum. So I compliment the organizing committee for taking pains. For almost 3 months, we toiled together to see that this conference has come to this shape, and we should hear from you on the valedictory day how we arranged this conference. I can't say that it's a success right now because we have to see and taste our hospitality for another 2 more days. So today is only starting day. Yesterday we had 5 workshops, and today's CME program was inaugurated by Commissioner of Police Srimati Sweta Garu, and now also another dignitary, our Honorable MLA Warangal West, will be joining us shortly to lighten the lamp and declare that the conference inaugurated. And once again, I welcome all of you, because another opportunity to me will be there after I take over as the president of Oasis. I don't take much of your time. Again, I welcome and thank you very much. Thank you.
Thank you, sir, for your wonderful message. It is because of you this Tosa Oasiscon has come to Warangal. Thank you very much. Now I request our beloved Oasis president to give his presidential address. Dr. Krishna Gopal Ramurthy Garu.
Good evening, one and all. Respected dignitaries on the dais, distinguished office bearers of Orthopedic Association of South Indian States, senior orthopedic surgeons, members of organizing committee, young colleagues, postgraduates, ladies and gentlemen, press and media. It's indeed an immense pleasure and privilege to stand before you as the Silver Jubilee President at the inauguration of the annual conference of Oasis in this historic city of Warangal. I extend my warm greetings to all the delegates who have come across the 6 states. Oasis was founded with the vision of bringing orthopedic surgeons of South India together on a common academic and professional platform. And its annual conference has grown into an important forum for knowledge, fellowship, and collaboration. A conference in a historic city of Warangal is a particularly appropriate setting for this gathering. This ancient Kakatiya capital is renowned for its magnificent architecture and temples and its contributions to the cultural heritage of the Deccan. The Kakatiyas built enduring structures that have survived the passage of centuries. In a similar spirit, the medical profession must strive to build institutions, knowledge, and ethical traditions that will endure long after us. It is therefore fitting that we gather here to discuss how we can build a stronger and more compassionate future for orthopedic care, from restoration to transformation. Orthopedics has undergone a remarkable transformation during our lifetime. From the treatment of fractures with plaster and tractions, we have progressed to sophisticated trauma systems, minimally invasive procedures, joint replacements, complex spine surgeries, limb reconstructions, computer-assisted surgery, and increasingly personalized rehabilitation. Technology is changing the operating room before our eyes. Robotics, navigation, artificial intelligence, advanced imaging, 3D planning, and newer biomaterials are opening exciting possibilities. But let us remember one fundamental truth: technology is a tool. The surgeon remains responsible for the patient. No machine can replace clinical judgment, empathy, communication, and the trust that exists between a doctor and a patient. The best orthopedic surgeon is not merely the person who performs the most technical, difficult operation. It's a surgeon who knows when to operate, when not to operate, how to communicate honestly, and how to remain beside the patient throughout recovery. Our responsibility extends beyond the operating room. India has made tremendous progress in healthcare, but the benefits of modern orthopedics are not yet equally accessible to all. We must therefore ask ourselves, can a farmer in a remote village receive timely treatment after a fracture? Can an elderly person with a fractured hip receive appropriate care without catastrophic financial consequences? Can a young patient with a sports injury receive evidence-based treatment rather than unnecessary intervention? These are not merely medical questions. They are questions of social responsibility. The orthopedic community must continue to strengthen outreach, training, trauma systems, rehabilitation, and affordable care, particularly in rural and underserved areas. India has the most youth population, and so it is with our orthopedic family. You are the future custodians of our profession. Learn the science, master the skills, but also learn the values of medicine. Be curious, ask questions, read critically, audit your results, teach others, publish your work, and never stop learning. Medicine changes continuously. What is considered the gold standard today may be modified tomorrow. The humility to accept new evidence is therefore as important as the confidence to make difficult decisions. At the same time, do not allow technology to distance you from your patients. A computer screen should never become a substitute for looking into a patient's eyes. The greatest strength of Oasis is not merely its annual scientific program. It is a professional friendship that connects orthopedic surgeons across the 6 southern states, and I wish it improves to leaps and bounds in the hands of future presidents and his team. The association's conference rotates among its member states, reinforcing the spirit of shared ownership and unity. We should preserve this strengthen this tradition. Let Oasis become even more than an annual meeting. Let it become a continuing academic family where difficult cases are discussed openly, research is conducted collaboratively, young surgeons are mentored, and institutions work together to improve standards of care. South India has some of the finest medical institutions and orthopedic surgeons in the country. Imagine what we can achieve if our expertise, data, and experience are systematically shared. Collaboration should become our competitive advantage. There is one subject that must remain central to every discussion on the future of orthopedics: medical ethics. As technology and healthcare systems become more complex, ethical practice becomes even more important. We must resist unnecessary investigations and procedures. We must disclose risks honestly. We must respect informed consent and protect patients' confidentiality. The trust placed in a doctor by a patient is one of the greatest privileges in the society. Let us never take that trust for granted. As we look ahead, I would like to suggest 5 commitments for our orthopedic community. Commit to excellence. Whatever our circumstances, let us strive for the highest standards of clinical care. Commitment to evidence. Let scientific evidence rather than habit or fashion guide our decisions. Commitment to accessibility. Let us work to bring quality orthopedic care to those who need it most. Commitment to mentorship. Let every senior surgeon help create at least a few surgeons who are better than ourselves. The last is to the humanity. Behind every X-ray, CT or MRI is a human being whose life may have been suddenly altered by pain, injury or disability. Our ultimate objective is not merely to correct a bone. Our objective is to restore a person's independence, dignity and quality of life. Friends, conferences such as this give us an opportunity to learn from experts, exchange ideas, and discover new techniques. Perhaps their greatest value is that they remind us that we are part of something larger than our individual practices and institutions. We are a part of a professional with a noble heritage and an enormous responsibility. From the historic soil of Warangal, let us renew our commitment to scientific excellence, professional integrity, friendship across states, and compassionate service to society. I congratulate the Telangana Orthopedic Association the Warangal Orthopedic Surgeons Association, and the entire organizing committee for bringing this prestigious gathering to Warangal. Oasiscon 2026 marks the Silver Jubilee edition, celebrating 25 years of academic and professional collaborations in South Indian orthopedics. I wish all the delegates a stimulating, enriching, and memorable conference. May the discussions held here generate new knowledge. May the friendships formed here create lasting collaborations. And may every lesson we take from this conference ultimately benefit the patient who waits for us in the clinic and the operating room. With these words, I am honored to declare the annual conference of Oasis inaugurated. Thank you.
Thank you, sir, for your appreciation for the Kakatiya Kingdom and your concern for our orthopedic fraternity. Now I welcome Oasis Secretary General, Dr. B.N. Roshan Kumar, sir, to give the annual report of the Oasiscon. Oasis.
No, that's fine. That's fine. Covered here. Good evening, respected dignitaries on the dais, seniors, professors, my dear friends and colleagues. So it's an honor for me to present the activities of the Oasis for this year 2025-26. Oasis 2025-26, we started off this year's term at Oasiscon 25, which was held in Pondicherry during August 25, where our President Dr. Krishna Gopal took over on September 31st during the inaugural ceremony. So these are few clippings of that ceremony, change of guard being happening from Dr. Vasudevan to Dr. Krishna Gopal. We had a very vibrant cultural program as well as academic program at Pondicherry and 2025 Oasiscon. So Orthopedic Association of South Indian States, Oasis is a registered body under Register of Societies. We also have a 12A status for our society. And this year I am very happy to announce we worked with our auditor and we got the IT exemption for our association. This is going to be there for the next 10 years. We don't have to pay any tax for whatever income we generate. After 10 years, we need to get this renewed. So these are the office bearers for this term, 25-26. Dr. Krishna Gopal is our president. Dr. Vijay Chandra Reddy sir is president-elect. And these are the office bearers, the executive committee members from various member states, Andhra Pradesh, Karnataka, Kerala, Pondicherry, and Tamil Nadu, and Telangana. Dr. Ram Kumar Reddy sir, our most dynamic orthopedic surgeon. So we also have different committees in Oasis. The main ones are the IT and Media Committee, which is functional. So they take care of the IT and website development and management of all the media part of the Oasis. We have a YouTube channel and also video journals. So this is the committee comprising of President, past President, Secretary General, President-elect, and we have the Academic Committee. We also have Orthopedic Legal and Ethics and Grievance Committee. Of course, this committee did not do anything, so we're lucky that we did not have any grievances this time. Coming to the activities of the Oasis, we had instructional course lectures which were conducted online on first Tuesday of every month. So we had programs, we had a dorsolumbar fracture recent update ICL on November 2025 by Preeti Hospitals, Madurai. In the month of January, we had an ICL, comprehensive management of elbow injuries. And then 11th November, again, Oasis Trauma Conclave on lower limb trauma, which was conducted at Mangalgiri AIMS on November 23rd, that is the mid-year CME. Then we had another ICL on proximal femur fractures by Telangana Orthopedic Society And then we had an ICL on elbow injuries by Andhra Pradesh. Then we had a ICL on 3D printing by Karnataka Orthopedic Association during February. And in March, we had tibial plateau fractures from Kerala. And in April, we had another ICL by Puducherry Orthopedic Association on cervical myelopathy. And in May, we had an ICL by Tamil Nadu Orthopedic Association on Charcot foot joint. So this was the mid-year CME at Mangalgiri AIMS. And these are the few future programs for the coming year under the leadership of Dr. Vijay Chandra Reddy sir. This I will circulate among all the OASIS members on the WhatsApp group. We also have a very actively functioning journal headed by our editor Dr. Tanappan. We also will be having a journal release of this year's issue after a few minutes from now. So this is the report for the OASIS for this year. Thank you.
Thank you, sir. Now, our TOSA secretary will give us the annual report. Dr. V. Jagammohan Reddy garu.
Good evening all. Thanks for giving this opportunity. This is from Telangana Orthopedic Association annual report. Respected President Dr. Ramkumar Reddy sir and Chairman Dr. Vijay Chandra Reddy sir and past presidents and senior members and executive committee members and President of OASIS Dr. Krishna Gopal sir and Secretary Dr. Roshan sir. Distinguished faculty, colleagues and dear friends, it is my privilege to present the Secretary General Annual Report of the TOSA. This has been another very active and productive year for our association with significant progress in the membership, academics, hands-on training, postgraduate education, research and professional collaboration. Membership growth, I am happy to report that our TOSA membership has now reached 1,066 members. Which is a record. Over the last 2 years, more than 300 new members have joined our association. This is one of our most important achievement and reflects the growing confidence and participation of the orthopedic fraternity across the Telangana. Our responsibility now is not only to increase the membership, but also to ensure that every member receives meaningful academic and professional value from TOSA. We placed a special emphasis on hands-on education. During this period, we conducted and supported more than 300 CMEs, workshops, instructional courses, cadaveric programs and postgraduate teaching programs. The programs covered wide spectrum of orthopedics including orthoplasty, arthroscopy, trauma and fracture fixation, shoulder and knee surgery, hand surgery, tendon repairs, pelviacetabular trauma, cadaveric surgical exposures, joint preservation, artificial intelligence, robotics in orthopedics. Our upper limb and lower limb cadaveric workshops provided practical exposure to arthroscopy, orthoplasty and surgical approaches. Postgraduate education remains one of our major priorities. We collaborated with IOA, TOSA and TCOS postgraduate teaching program at Gandhi Medical College was attended more than 250 postgraduate delegates. The program focused on clinical judgments, case analysis and patient-centered decision making. We believe that supporting our young orthopedic surgeons and postgraduate trainees is an investment in the future of TOSA, technology and innovation. This year, TOSA also moved strongly towards emerging technology. The TOSA Artificial Intelligence Workshop conducted on May 31st, 2026 at Hyderabad was an exclusive hands-on program introducing orthopedic surgeons to practical application of artificial intelligence in clinical practice. We also supported programs such as Orthobot 2026 focus on robotics and future of joint reconstruction. Our aim is to ensure that TOSA members remain updated not only with the present day orthopedics but also with the technologies that will shape our future practice. Research and academic contributions. Our members continue to contribute actively through scientific papers and posters, national and international publications and general publications, book chapters, research projects and national and international conference participation. Telangana members also presented several scientific papers at Oasiscon, IOCon, demonstrating the increasing academic presence of our state. Collaboration and outreach with the TOSA contributed the strong collaboration with IOA, OASIS and subspecialty association like CISA and Hand Surgery Association and medical colleges, hospitals and other professional bodies. Our activities also extended beyond conferences through bone and joint health programs, road safety awareness, basic life support training program, and community outreach activities. Looking ahead, as we move forward, our priorities are clear: stronger membership, engagement, more on hands-on workshops, greater opportunity for young surgeons and postgraduates, and strong research and publications, development of our Journal of Telangana Orthopedic Association, and continued focus on AI, robotics, and emerging technology. I sincerely thank our president, past president, and executive committee members, senior mentors and faculties and organizing team and institutes and collaborating organization for their continued support. Most importantly, I thank each of our 1066 total members for their trust and active participation. Today Tosa is becoming much more than association that meets once in a year. Tosa is becoming a year-round platform for education, practical skills, research, innovation, collaboration, and fellowships. With 1066 members and more than 300 new members joined in the last 2 years, we are moving forward with strength and confidence. Let us continue together. Thank you.
Thank you, sir. Tosa is really progressing in a mammoth way in your leadership. Now I call upon our Tosa President, Dr. Ramkumar Reddy Garu, and Tosa Secretary, Dr. Jagannath sir, to give upon the Best Paper Awards, which were conducted last year, Tosacon 2025 held at NIMS by Dr. Chandrasekhar sir and Raju Iyengar sir. I would like to announce the Tosa Consultants Gold Medal Paper to Dr. Srinath Gupta. I think he has not come. Tosa PG Gold Medal Paper, Dr. Varun Kulkarni. I think he's here. Please come on to the desk. Tosa Gold Medal poster, Dr. Vishnu Priya. And lastly, Tosa Gold Medal quiz, first prize, Dr. Shreya and Dr. Mukesh. Second prize, Dr. Shaurabh and Dr. Shubham. Congratulations, Dr. Varun Kulkarni. As our president of IOA has not come, he has sent a video message. I request the people to play his video message. It's a short video message by Dr. Naveen Thakkar sir.
Respected delegates, thankful to Tosa Oasiscon 2026 organizers for inviting here in Mega Congress. We are thankful to Dr. P. Vijay Reddy, Dr. Ram Kumar Reddy, Dr. Sudhir Kumar, and whole team of all 6 states. It's a great conglomeration of all 6 states. Oasis and Tosa are really very vibrant organization. I had visited Warangal previously with a great hospitality. We invite you all delegates, leaders, and PGs for IOCON 2026 at Ahmedabad, Gujarat at Mahatma Mandir Convention Center. It will be a grand mega event in December 2026. Let me inform you that American Academy is the guest nation. First time the German Orthopedic and Trauma Association is going to have MOU with us in the Federal Ministry of Berlin. British Orthopedic Association and Indian counterpart are joining with us. Please submit your abstract or contribution. You can contribute in IOCON 2026. The last date is extended till 25th August. Only last 5 days are remaining. I wish a great success to this meeting. I could not remain present physically because of some health issues. But thank you again very much. I have a very small request at the last to you all sitting in the audience. This Tosa and Oasiscon 2026 team has worked very hard, giving this ambience and curated very well program with many unsung heroes. So they deserve really a grand standing ovation with grand clapping. Please. Thank you very much.
Thank you, sir. Thank you, Dr. Navendra sir, for your wonderful message. We hope you have speedy recovery. Now I invite Superintendent
2026 conference. As the principal of Kakatiya Medical College and basically a general surgeon, I feel a deep sense of pride seeing MGM Hospital, KMC, and our dedicated fraternity of Warangal orthopedic surgeons organizing South India Orthopedic Conference, that is Oasiscon, along with the Tosa for first time at our historic city. There is undeniable and vital synergy between general surgery and orthopedic fields. Whether we are managing, orthopedic surgeons share the same fundamental goal, that is restoring the function, alleviating the pain, and preserving the human life. Orthopedic is undergoing a remarkable evolution. Advances in minimal invasive surgery, robotic assisted joint replacements, complex arthroscopy, and innovative regenerative medicine are continuously redefining what is possible in patient care. Gathering at conference and attending these conferences are very essential. It provides a platform to exchange groundbreaking techniques, discuss challenging cases, and challenge one another to push the boundaries of medical science. To our visiting delegates from across the South India, I extend a warm welcome to Warangal. Your expertise enriches this forum, and I am confident that knowledge shared over the coming days will directly translate into improved outcomes for our patients. To our residential doctors, young surgeons present today, I encourage you to immerse yourselves fully in these sessions. Absorb the wisdom of faculty, ask the questions, and build the professional networks that will sustain your careers. But I sincerely say one thing: clinical examination of the patient, sympathy, empathy are not given by any machine. So you have to follow the fundamentals of teaching. Don't think the investigations will overcome the clinical examination. So basic clinical examination, that human touch to the patient is a must. I congratulate the organizing committee, the departments of orthopedics at KMC, MGM Hospital, and the Warangal orthopedic community for their tireless efforts in making the prestigious event a reality. I wish you all an enriching, engaging, and highly successful conference. I thank the organizing committee for giving this opportunity. Thank you very much.
Thank you, sir. Now we have reached the important session of our inaugural function. honoring and respecting of our senior members from member states. I request Oasis Secretary and other guests to join to respect our seniors. First, I request, Chair, please. అడగండి ఒకసారి. May I call upon Sri Dr. Y. Nageshwar Rao Garu from representing Andhra Pradesh from Kakinada. Please welcome onto the stage, sir. If Madam is there, we request Madam also to be onto the dais. Request President Secretary of Tosa to accompany our senior, Dr. Y. Nageshwar Rao Garu from Kakinada, representing Andhra Pradesh. Welcome, sir. I request the President Secretary of the respective states to do the honors, along with the Oasis Presidents and Secretary.
Yes, sir. Yes, sir. Yes, sir. You can press this. Only two slides. Only two slides. After the rose comes, you can start. Good evening, all. I, Secretary of Orthopedic Surgeons Society of Andhra Pradesh, take pride in reading out a brief introduction about Dr. Y. Ennapu Nageshwar Rao Garu, also called Dr. YNR, with love and lots of respect in the state of Andhra Pradesh. Sir was born in year 1959 in Munugundu village of Konasima, Dr. B.R. Ambedkar district of Andhra Pradesh. His secondary schooling was done in AP Residential School from 1972 to 77 in Hanamkonda and Nagarjun Sagar. Sir has has done his graduation and post-graduation in orthopedics from Andhra Medical College, Visakhapatnam. During his post-graduation time, Sir was awarded with the prestigious Dr. Vagreshwaradu Gold Medal. And Sir has joined the AP Medical Services in the year 1989 and has served in various ranks of professional hierarchy as an assistant professor, head of the Department of Orthopedics, Rangaraya Medical College, principal and superintendent of Rangaraya Medical College for a long years from 1989 to before retiring as additional DME in 2022. Sir has presented various lectures in almost all platforms of across India. He was the leadership personality of presentations, academic excellence presentations in Oasiscon, Oasiscon and IOACon. And he is still the torchbearer of NTR Health University CME lectures. He was elected as president of Orthopedic Surgeons Society of Andhra Pradesh in 2000 for the year 2017 and 18, and is known for his excellent approaches he has initiated in OSAP, like the fellowship programs, monograph publications, and mid-year CMEs were initiated by Dr. Y. Nageshwar Rao Garu, and is still the main content. I mean, he is the pioneer of many objectives of Orthopedic Surgeons Society of Andhra Pradesh. Thank you, sir.
Yeah.
May I now call upon Dr. P. Gopinath sir from Mysore, representing Karnataka. Request Madam also to come join the sir.
Dr. Gopinath. Sir was born on 12th August 1955 at Shivamogga in Karnataka to Mr. Puttappa and Srimati Jayamma couple. Dr. Gopinath sir's spouse, Mrs. Radha MK, she's with us today. Gopinath sir has completed his MS Orthopedics from Bangalore Medical College, his MBBS from JJM Medical College, Davangere from 1974 to 1980. His early schooling was in Bangalore, Malleshwaram and Shivamogga. Professional career, he is presently working as Associate Professor and Sri Chamundeshwari Medical College Hospital and Research Institute since June 2022. He served as medical faculty in Andaman Nicobar Island in Institute of Medical Sciences for 3 years. He was a medical specialist, AIMS, Bijinagar, Nagmangla, Mandya. He was a faculty and contributor in Mysore Medical College 2005 to 2015. He worked as senior specialist, Government Hospital, Coorg from 1987 to 2005. He was also a medical officer for Health and Family Welfare Services, Government of Karnataka at Sanjay Gandhi Hospital. Apart from his professional involvement, he is also a very active Lion Club member. He is served in leadership positions. He has received international honors, Best President Award from Lions Club International USA, represented India at the Lions International Convention in London in 2015. He has immensely contributed to the IOS Bone and Joint Day celebrations every year. He is also a very active participant and he keeps conducting community health services like he's organized many camps for physically handicapped and also distributed orthotics to the amputees, and he is part of innumerable eye camps across Coorg and Virajpet regions. This is Dr. Gopinath for you.
Thank you, sir and madam, for accepting our felicitation. Now I request Dr. Ram Mohan sir, representing Kerala from Thrissur. Please come on to the dais, sir, to accept.
Madam is also there. We invite Madam also on the stage.
Yeah. We request Madam also to accompany the sir.
Dr. Ramohan sir.
Dr. Ram Mohan sir from Thrissur.
Dr. Ram Mohan KP. Sir completed his MBBS from Government Medical College, Calicut, and then his D Ortho. Sir.
Yeah, Dr. Ramohan KP, hailing from Thrissur. He is a distinguished orthopedic surgeon with over 4 decades of clinical and academic experience. specializing in pediatric orthopedics and complex trauma management. He was the editor of the Kerala Orthopedic Journal. At present, he is working at Mother Hospital, Thrissur, and Midas Hospital, Ullur. Completed his MBBS from Calicut Medical College and D-Ortho from Christian Medical College, Vellore, and MS Orthopedics from Government Medical College, Trivandrum. Especially interested in pediatric orthopedics and complex trauma management. He has received a Best Postgraduate Award from CMC Vellore in 1983, Varghese Mathai Fellowship, Professor Venugopalan Nair Gold Medal from KA Conferences, and he has given KA George oration. He was past editor of Kerala Orthopedic Journal, was past secretary of Thrissur Orthopedic Society, past president of Thrissur Orthopedic Society, past treasurer of Kerala Orthopedic Society Association, and past president of Kerala Orthopedic Association. He was survived with Vijay Kumari, retired executive engineer, Kerala State Electricity Board, and 2 children, Abarna working at Yale University, USA, and Kashyap, sound engineer, Chennai. Presenting Dr. K.P. Ramohan.
Thank you, sir. Thank you, madam, for accepting our felicitations. I call upon Dr. Dharamveer Kumar Dubey, sir, from Puducherry.
Good evening. Dr. Dharamveer
Kumar Dubey, sir, from Puducherry.
Okay, sir. Sir is a highly respected orthopedic surgeon and public health professional with over 4 decades of exemplary service in orthopedics, medical education and patient care. He has completed his UG and postgraduate from JIPMER. He has done his government services in Uttar Pradesh till May 2003. Then he has joined Pondicherry Public Services in June 2003, and since then he has been serving there. Sir was the HOD and now he has retired this year. And Sir's key academic milestone is he has started the DNB training program in IGGH PGI Pondicherry in 2007, which has been running successfully till now. Sir has been an examiner at multiple DNB centers and contributed extensively to postgraduate teaching and actively participated in academic programs conducted under the aegis of IOA. Sir, Dr. Dubey is particularly recognized for his commitment to equitable and accessible healthcare delivery. Under his leadership, the PMRC department in Pondicherry Government Hospital has been started, and under his leadership, replacement surgeries and arthroscopy surgeries are also started, and his sustained efforts, vision, leaderships have transformed the department into a center offering advanced orthopedic care. Dr. Dharamveer Dubey from Pondicherry. Thanks.
Thank you, sir. I will call upon Dr. Rajamani, sir, from Madurai, representing Tamil Nadu. Request Madam also to come onto the dais.
Professor Dr. A. Rajamani sir, Emeritus Professor, the Tamil Nadu Dr. MGR Medical University, Founder Professor of Spine Surgery, Madurai Medical College, former Professor of Orthopedic Surgery, Madurai Medical College, former Orthopedic and Spine Surgeon, Government Rajaji Hospital, Madurai, Endoscopic Spine Surgeon, Pritam Spine Center, Madurai. Sir is a distinguished orthopedic and spine surgeon with over 45 years of academic teaching and 4 decades of surgical excellence. His academic teaching experience, he has 45 years of teaching undergraduates and postgraduate students. He has 40 years of undergraduate as an examiner, 40 years of MS and D-Ortho examiner for all Indian universities. Sir has guided more than 150 postgraduate theses. Sir has 35 years of experience in setting PG examination question papers. Sir has been faculty for PG and National Board CMEs and also examiners from past 40 years. He has 25 years of experience as an accreditor in the National Board of Diploma of NB. His professional surgical experience, sir has operated over 10,000 spine surgeries, 2,500 surgeries for quadriplegia and paraplegia, 1,000 deformity correction surgeries, 7,500 disc prolapse and spinal infection surgeries, over 4,500 endoscopic spine surgeries. Sir has presented more than 250 scientific papers in state, national and international conferences. And he has, to his credit, 5 times as best paper gold medal winner. He has 17 publications in state and national journals. He has received Best Teacher Award from the Tamil Nadu from Dr. MGR Medical University in 2011, Best Doctor Surgeon Award in the year 2012, again from MGR Medical University. His leadership roles, he was past Secretary, Tamil Nadu Orthopedic Association, past President, Tamil Nadu Orthopedic Association, past President, Orthopedics Association of South Indian States, Vice President, Indian Orthopedic Association, Chairman, UG and PG Teaching Program, Indian Orthopedic Association. Sir has delivered 20 orations at state and national conferences. This is Dr. Rajamani sir for you.
Sir, madam, for accepting our felicitation. Now the doyen of Tosa, Dr. T. Venkateshwar Rao sir, our beloved Professor Dr. T. Venkateshwar Rao sir.
Sir, yeah, so Yes, sir. Dr. T. Venkateshwar Rao, sir. He did schooling from Nizamabad district, intermediate from New Science College, Amirpet, Hyderabad, between 1974 to 76. He did MBBS from Usmania Medical College, Hyderabad, from 1977 to 1982. And he did MS Orthopedics from Kakatiya Medical College, Warangal, from 1994 to 84 to 87, and he joined as a service at primary healthcare in 1987, appointed as an assistant professor in January 1988, served as associate professor from 2006 to 2012, served as a professor from 2012 to 2017, served as a professor and HOD in charge professor, Department of Orthopedics during the relevant period of service, worked in Malaysia.
I request our senior
Minister of Department of Health from
Varangal, Dr.
1995
sir, to come on to the dais.
retired from regular service
And
in
JV
August
sir.
2017.
Raghuram sir, Hari Prasad sir.
Is the
From
first
Varangal.
register of Kaloji University, served as the first register of Kaloji
Senior orthopedic surgeons from
University of
Varangal.
Health Services Telangana from 2015 until the retirement of August 2017. First rector or pro vice chancellor of Kaloji University, served as the first rector. University of Health Sciences Telangana for 2 terms from December 2017 to December 2023, and extensive experience in teaching of undergraduate and postgraduate, trained and mentored numerous postgraduate students in orthopedics, published several research papers in Index Journal, contributed to the development of orthopedics and surgical services and postgraduate training. Yes, sir. Sir.
Next is I will introduce afterwards. Then it will end up. అవును సార్ ల్యాంప్ రేటింగ్ అయితే అనౌన్స్మెంట్
Thank you, TV Rao sir, for accepting our felicitation, sir.
జర్నల్ రిలీజ్ అవుతుంది ఆఫ్టర్ ల్యాంప్ రేటింగ్ జర్నల్ రిలీజ్ రిలీజ్ అయితే ఎనీ అదర్ బుక్ ఇస్ టు రిలీజ్ ఓన్లీ జర్నల్ ఓకే ఆఫ్టర్ జర్నల్ రిలీజ్
I'm sorry, our chief guest, Nagendra Dinet sir, is not coming. So I request our dignitaries on the dais to attend the lamp, lighting the lamp, sir. Request all the dignitaries on the dais
बुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Now I request our Oasis Secretary, Dr. Roshan sir, to announce the Oasis General and Conference on air.
We'll have the Oasis Journal release now. I request our editor, Dr. Thanapan sir, to come over to the dais with the journals. So I request the dignitaries to kindly release the journal of Oasis, the latest journal of Oasis. This is the release of the both volumes for this year. We have 2 volumes, so we are releasing both the volumes hard copies. After this, we will also be releasing the conference souvenir. So I request the dignitaries to be in standby for the release of the conference souvenir. At this juncture, I would also announce the scientific exhibition to be inaugurated. So, like they say, all good things has to come to an end. And at the end of everything, there's a new beginning. So, the most awaited item of the day is announcement of the Best State Chapter Award. So, we had 3 states who competed in this award: Karnataka, Kerala and Tamil Nadu. And the Best State Chapter Award Selection Committee meticulously went through all the records documents submitted by these states and gave us the result. And this year also, Tamil Nadu has taken the Best State Chapter Award. So I request the Secretary and the President and delegates from Tamil Nadu to come over to the dais to receive the Best State Chapter Award. Like they say, all good things should come to an end. The term of the present President, Dr. Krishna Gopal, sir, is come to an end, and he shall be handing over his baton to the incoming President, Dr. Vijay Chandra Reddy. So after the good things end, there is always a new beginning. So now, gentlemen, I announce the change of guard. What time it's gone? One minute. Some technical glitch. So may I request Dr. Krishna Gopal and Dr. Vijay Chandra Reddy sir to come over to the dais. Stand there. I want the two presidents to be in the front of the dais. So I request Dr. Krishna Gopal sir to hand over the Oasis jewel to Dr. Vijay Chandra Reddy in front of the lamp, Agni Sakshi. So I welcome Dr. Vijay Chandra Reddy sir, the new president of the Oasis for the year 2025-26-27. So a brief introduction about Dr. Vijay Chandra Reddy sir. Professor Dr. P. Vijay Chandra Reddy sir was born to late Surya Prakash Reddy on 8 April 1959 at Warangal, Telangana. Dr. Vijay Chandra Reddy's spouse, Srimati Sudeshna. Sir has a son, Nitin Chandra Reddy, an orthopedic surgeon. Daughter, Dr. Nikhila, she is a gynecologist, consultant at Yashoda Hospital, Secunderabad. Son-in-law, Dr. Praveen Reddy, he is a MD Radiology, owner of Aruna Diagnostics, Hyderabad. Sir's daughter-in-law, Dr. Akshita Reddy, she is MD Pulmonary Medicine. Sir has completed his MBBS from Kakatiya Medical College, Warangal, MS Orthopedics from Kasturba Medical College, Mangalore, Karnataka, and his DNB from LGT, Sion Hospitals, Mumbai. Sir's professional experience, he was Professor of Orthopedics, Kakatiya Medical College, Warangal, MGM Hospital, Head of the Department, RVM Medical College, 2015 to present, Chairman Ethics Committee, AP Medical Council, 2006 to 2014, Executive Committee Member, Andhra Pradesh Medical Council, 2006 to 2014, Past Indian Medical Association IMA President, Warangal 2006 to 2004. He is President IMA Andhra Pradesh State 2012 and 13. Chief Election Commissioner IMA Headquarters New Delhi 2008 to 2014. Central Working Committee Member IMA 2016 to present date. Secretary General Oasis during 2013 to 2016. Vice President Oasis 2020 to present. Now he is taken over as President of Oasis. Sir has received many honors and recognitions. A few to mention are, he has received an award for excellence in 100% voluntary blood donation by NBTC and NACO. Second prize from Red Cross Blood Banks in Telangana by Honorable Governor ELS Narsimhan. Certificate of Merit for Blood Donation Mobilization 2013-14 by Honorable Governor. He has received the first prize for membership drive in Telangana by Honorable Governor Dr. Tamil Sele Soundararajan. Second prize for blood collection initiatives in Telangana by Honorable Governor Dr. Tamilisai Soundararajan. His academic contributions are plenty, a few to mention. He's presented scientific papers at the state and national conferences, published research papers in esteemed journals. He is examiner for undergraduate and postgraduate medical students, faculty speaker at Oasis, Ivocon and Home Osmania conferences. Notable research and conference papers. He also has another side of the coin, his political career. He's been a BJP member since 2012, contested MLA elections, Parakal constituency in 2012 and 18, RSS Swayam Sevak since 1977, 49 plus years. BJP State Working Committee member, 3 terms. He is joint convener, BJP State Think Tank Committee, 2016 to 19. Prabhari for Huzurabad constituency, Mulugu district returning officer. He is former ABVP leader 1976-78, Kakatiya Medical College Students Union President during 1981 to 83. Welcome to you, Dr. Vijay Chandra Reddy Garu, sir, President of Oasis. Dr. Vijay Chandra Reddy sir to address the gathering with the garland on. That's a public demand.
Please give some place for the family members. Request. వదినా రండి. పక్కన ఉండు. అది అన్నట్టు భరిస్తారు కదా వదిలేకి. వదిలే పెద్దదాన్ని చేయాలి. కదా రాని అన్న. This is a proud moment for Warangal Orthopedic Association and Tosa. Our beloved Dr. Vijay Chandra Reddy sir is becoming the president of the Oasis. Happy Hooray!
I request Dr. Vijay Chandra Reddy sir to address the gathering and say a few words and also announce the presidential agenda for this year. Please, sir.
Thank you very much. First of all, the love and affection you have shown to me. I will still say President Krishna Gopal. Thank you, thank you. Secretary General Dr. Roshan Kumar, and today's special invitee, Principal of Kakatiya Medical College and Chief Guest, Dr. Mohan Das Garu, my good friend. All the other Oasis office bearers and all the office bearers from all the southern states. And dear senior faculty members, my well-wishers, my family members, friends. Standing before you today, as I assume the office of President of the Orthopedic Association of South Indian States, is both a deep privilege and profound responsibility, I feel. And I extend my sincere gratitude to each member of Oasis for reposing your trust in me to carry out all the Oasis activities for the next coming year. As I step into this role, my vision for my presidential tenure centers around a single core theme: revisiting orthopedics, bridging the innovation with foundations. So I just repeat, revisiting orthopedics, bridging the innovation with foundations. Because lot of technology is growing up, at the same time, we shouldn't forget our foundations, our basics. As already our chief guest said that never forget our basics. So my core theme is revisiting because many of the young orthopedic surgeons have coming out because of the numerous medical colleges have come up in our country now. So they need one side education, and at the same time they should know how the technology is evolving across the globe. So as the educational landscape is expanding rapidly with increase of medical college across India, large number of eager, talented young orthopedic surgeons are stepping into this workforce every year. So this presents us with a vital question. How do we equip these young surgeons to bridge the gap between the basic medical training and high-level surgical expertise? To address this, my focus during this tenure will rest on three pillars. One is bridging the technical gap without losing the basics. So technological advances like robotics and navigation are powerful tools, but they cannot replace sound surgical judgment, clinical touch, and fundamental biomechanics. As an association, our goal will be to make high-end training accessible so that no surgeon, urban, regional or rural, is left behind in this digital age. And the second thing is a structured knowledge transfer model. So we must create hands-on, structured avenues to transcend wisdom from our seasoned masters to our young surgeons through targeted Oasis surgical workshops, observational fellowships, live surgeries, and structured mentorship program. We will ensure that senior clinical experience directly nurtures the young talent. And the last and important thing, revisiting the essential. A skyscraper is only as strong as its foundation. By this revisiting orthopedics, we commit to mastermind basic trauma, fracture fixation, and primary patient care with absolute perfection alongside adoption of cutting edge technology. So to the young surgeons joining our fold today, Oasis is your platform. Seek out mentors, question existing paradigms, and continuously hone your skills. To my senior colleagues, I urge you to share knowledge freely, for our legacy lies in the hands of those we guide. Together, let us make the coming year a landmark period of academic excellence, ethical practice, and a camaraderie across South India. Thank you once again for this incredible honor. Jai Hind, long live Oasis, and also I thank at the outset and at the end Dr. Alwal Reddy's sacrifice of 5 months of duration of taking over as president. He would have taken in March, now it is August, just because of us, that is the Oasiscon should be clubbed with Tosa. Thank you, Alwal Reddy. Let us all greet Alwal Reddy. He would have taken as president in March itself, but he waited till August. Thank you very much once again. Jai Hind, long live Oasis.
Now, the last thing, vote of thanks. I announce myself. Anything is there, sir? Social, sir? Social, sir, anything left? Now, the organizing committee is pleased to felicitate the dignitaries with the mementos to remember our organization. I request my colleague Jagan Mohan, myself and new president Oasis Vijay sir and all our Warangal orthopedic surgeons and Tosa office bearers, please join us to felicitating the guests. First of all, I call upon our President Krishna Gopal sir. Please take a small memento. Sir, past president, sorry. All right. Yes. One by one. Dr. Krishna Gopal sir, Dr. Roshan Kumar BN, Dr. Vasudevan sir from Kerala, Dr. Shivakumar sir, Dr. Ashwini Kumar Singh sir, Dr. Venkataramana sir, sir, Vijay Krishna Reddy sir, Andhra Pradesh, and Satyanand Rai, Karnataka, Harish Mutsi, Karnataka, Subin Sugat sir from Kerala, Ansu Anand from Kerala, Dr. M. Prakash from Puducherry, Bhuvanesh Gopal from Puducherry, Dr. S. Sundarajan from Tamil Nadu, Dr. Marimuthu from Tamil Nadu. Please accept our small mementos from Tosa. One by one. Everybody. Everybody. Everybody on the dais. Now from our Tosa side, our past president Thimma Reddy sir and President-elect Alva Reddy sir, Secretary Jagan Mohan Reddy, and finally our beloved friend and sir, our guest of honor, Dr. Mohandas sir. Please accept our memento from us. Yeah, I know, sir. Now, finally, I will announce my vote of thanks to all the guests on the dais for gracing the occasion and coming all the way from the different states. And I express my heartfelt thanks for all associations, especially the Oasis from the Krishna Gopal sir and Roshan Kumar and the office bearers, and there's a Karnataka Orthopedic Association and Kerala Orthopedic Association, WhatsApp, Andhra Pradesh Orthopedic Surgeons Association, and my own Tosa office bearers, and my hometown, the Osa Warangal Orthopedic Surgeons Association, and also Department of Orthopedics. I express my gratitude for helping me out conducting this type of conference. Especially thank the organizing members of my team. Each and everyone, I request all of the members and also the faculty, chairpersons, speakers, orators and felicities, and the judges. They were all present in the CME and also who is going to come in the upcoming conference. I express my gratitude to them for accepting our invitation. the trade and sponsors. By name, all will be remembered during the valedictory function, but as a general whole, the trade people are remembered. Finally, the Kuda, the Kaloji, auditorium administration, staff of the auditorium, the audio visuals and the IT department of IMO is conducting this. The Mr. Sunil Verma, a special note to be made to the Sunil Verma and Yogi who made this. So one difference we might have observed, everything was arranged by the local people, no event manager was involved. The Department of Orthopedics and also the Warangal Ortho Surgeon Association, they took it as a personal and everybody involved and conducting the conference with the local, the people without giving any middleman. So this was used to be previously, but nowadays event manager come, that is gone out of our hands. So, and the caterers, security staff. One more important department is the police department. They have put on traffic and regulations, everything. And the last but not least, the volunteers, the postgraduates of my department and the UG students of our college. And all other, which were, if I missed, this is unintentional, please forgive me, but I express my thanks to all of you. And I request all of you to join the inaugural dinner at the Vajra Gardens now. Thank you very much, sir.
Few members of Sir's Fans Association is there in Warangal, sir. As you have seen is in biodata. Few of them also wants to felicitate, sir. A request is brother-in-law, Dr. Subhash. Sir. Dr. Subhash Reddy, sir.
Office bearers, they can go to dinner. We will start from the dinner. We have CCR, sir, and they will continue here. Okay, sir.
Members from his constituency, many BJP members have all come here to felicitate him.
Manjiga, hey, odira bro.